Check, check. Hello. Check. Hello. Check. Hello. 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 Check. Hello. Hello. Check. Hello. 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 Check. Check. Hello. check, check, hello.
आपने जो भेजी थी मैंने वो डाउनलोड कर दी है वो, और कुछ
नहीं, बस अभी तो यही बोलना है मेरे को फिलहाल, और भी भेजेंगे तब। सुनना भैया, अब मुझे इसको बैक करके अब नाम का पीपीटी चलाने के लिए कैसे चलाऊंगा
बुक करके क्लोज करो।
ये
हाँ, मिनिमाइज करके डाउनलोड में चल जाओ। ये रहा जो फोल्डर खुला हुआ है, हाँ डबल क्लिक कर दो। ये चारों हो गए, इसको खुलाओ।
A very good morning to all. We are delighted to have you all here again for the second day of our workshop. To begin the first session of the day, I would like to invite our first speaker, Dr. Gayatri Vishwakarma, currently serving as Head Biostatistics at ISIC. She is experienced biostatistician with 14 plus years of post-PhD experience in academics and research. Previously worked with Rajiv Gandhi Cancer Institute, New Delhi, University of Texas Health Science Center, USA, CDSA Faridabad, Amity University, Noida, Woodward Charitable Foundation, Ethiopia. Expertise includes clinical trial data analysis, sample size calculation, survival analysis, SAS programming, research methodology, conducted several workshops on GCP SAS, biostatistics, published 25 plus research papers in peer-reviewed journals, holds a PhD in statistics from Jabalpur University and completed postdoctoral training in Canada.
Good morning, everyone. I am audible or I need mic? It's okay because unnecessary I have to carry this weight. If it is not, then I'll carry.
Ma'am, I think it will be better if you can have the mic because it might not be very clear at the back.
Okay, I'll carry. Oh, really? I didn't know that. Okay, definitely. Okay, audio also you are recording. Perfectly fine. Okay, thank you. So before starting, let me tell you this was the old biosketch. I didn't see that. It's now exactly 20 years when I completed my PhD. So post-PhD, 20 years of experience. And right now I am associated with the Zydus Life Sciences, doing lots of clinical trials and have more than 60 publications in peer-reviewed journal. So this is just only the update. Doesn't matter. So this is like going to be a little heavy session because of statistics, right? And this is more technical, a little bit. But I will try to give my session as lighter as possible as your breakfast was, okay? So that you can have energy to understand the next couple of sessions. So we have to talk about the study designs and statistics, biostatistics or statistics, whatever you can say. It is interchangeably used, but when we study statistics, it is like specific demarcation has been told that what is the difference between statistics and biostatistics. Bio means what? If you are adding bio, that means you are adding the human beings information in that. Statistics means any kind of data, the IPL players data or anything data can be like meteorological department data, any kind of data. But when we are saying biostatistics, that means we are involving humans human information. Even agricultural data which is on the plants, we don't say the biostatistics. It is the statistics only. So it's only related with the human beings. So let's understand, because it is, my session is little bit related to the research methodology, because what we have to do after getting this GCP and GLP training, you have to develop the protocol, you have to find out the sample size, then what are the statistical method you have to have in your protocol. So this is the overview of the research method which we use in any kind of clinical trial which you are going to initiate. So it starts with the rationale behind the study. That means when you are thinking that I have to conduct the clinical trial, what is the rationale, what is the importance, why I am doing this? Because as you see, after COVID pandemic, number of studies are being conducted, and it's just, you can name and you will get the studies. So after that, if you are thinking of conducting any study, you have to have the rationale behind it, behind this, that why I am doing it, what is the important, what community is going to get it. Not from your perspective that you will get the publication, you will get the promotion after that doing this clinical trial, but we have to think for the community that what we are going to give to the community after doing this trial. Then you have to identify, so this is related research methodology. The whole cycle is related with the protocol development or grant writing application, how you have to go about it. Once you have finalized and identified that this is the rationale behind the study, then you have to identify the problem. How it is different from the rationale. Because I thought that diabetic management is the main issue, and number of drugs, therapies, managements are available, but nothing is going to happen. Okay? So I want to work on this in a different way. So that is the rationale, that you still want to focus on the type 2 diabetes management. But problem identification, that you want to see whether some comorbidities, they are also associated with the diabetes. You want to specify that I want to just work on the glaucoma, whether it is associated with the diabetes. So problem, what problem you are trying to find out, because type 2 diabetes management is a whole soul, is a very broad term. So very specific problem you have to identify, that what exactly you want to do with this. After identifying your specific problem, you have to write down the research objective and research hypothesis. So here, research hypothesis and a statistical hypothesis, there is a little difference, which we will get to know in this presentation. What is the difference? Research hypothesis is just only the statement which you are making as an investigator, that I have seen couple of subjects, and this could be done, and this is working. But just seeing in couple of subjects and making the inference, nobody is going to believe on you. So you have to have some specific data analysis, and then you have to write and use the fancy statistical methods to convince the scientific community that, yeah, whatever I'm thinking. So what you are thinking in the first go, that is your research hypothesis. Now that you have to divide into two, null hypothesis and alternative hypothesis. You might have heard these names. So you have to divide as a statistical hypothesis later stage, but you have to have the research hypothesis. Then based on research hypothesis, you have to write the research question and research objectives. So research question has to be there, research objective. This is like totally, if I will go, the whole day will be like I will be talking in that details, the statistics, but I am going just only the research objective, because this is the order form which is ordering us that what we have to do to find out something, to correlate, to find the efficacy or something. So this is the research objective which you have to finalize. Then with this, you have to come to the study design. So we are going to see the study design. It's a comprehensive package which includes the objectives, sample size. Though I have emphasized it separately, but it is a part of study design only if you are using any kind of randomization, sampling method, how many subjects are there, how you are going to manage your data, all these comes under the study design only. And then you have, once you have decided that this will be the study design for my subject, then you have to calculate the sample size and how many subjects I will be needing. That is the important part where most of the investigators stuck. You have to have some information and some knowledge that what information I have to gather and that give to the statistician who can help me to give exact sample size, calculation, justification, because that is required by the two types of committee. One is ethics committee, one is technical committee. So every institute is having different names, IRB, ethics committee, EC, or scientific committee, different names. But these are the two committees. So your grant proposal or the MD thesis has to go with the two types of committees. One is scientific committee who will see the calculation part of sample size, and ethics committee will see that why you are taking this much of subjects, what. Then they will go and back and to the first point and they will ask that these much of subjects you required and what was the rationale of the study. So these things, these aspects, because ethics committee works mainly for the patient. Then you have to mention the data collection and analysis tool, that what you are going to use. So in detail we will see that how you have to and what you have to write. You have to mention what statistical softwares you are going to use, what data management software you are going to use for the analysis. Data collection will be paper-based or electronic-based, paper, CRF or eCRF, whether you are going to give to the tabs to the nurses for the data collection. So these all details you have to write in this section. And you have to analyze data, and final product is report writing. That means report writing is in terms of thesis, in terms of manuscript, in terms of your project report. Okay, CSR bolte hai, clinical study report. And then finally, I emphasize the 9th point, the limitation study. Every study has some limitation. You cannot say that I don't have any limitation. Name it, maybe the financial limited, maybe the sample size limited, rare disease, and we are not getting that much of samples. Or this is from my perspective, but from the investigator perspective, you might get different kind of limitations. So it is expected, because when you have clarity on your subject, what you are doing, definitely you will be able to write 1 or 2 limitations. And if you write, those who are reading the grant proposal or the synopsis, they will get the idea, okay, with this limitation you are doing all this study, that's okay, and then they will read their interpretation with that thought. So they will not question. So your queries will be less when you are submitting your reports to the committee for review. So this is the question when I started teaching from 2000, exactly 2000. I have been asking this question, and this is going with me till after 20 years. Yes. So how many statistician do you need for your study? And that I ask specifically, sorry about that, but this, because the title of this session was Basics of Statistics. So this whole presentation is for MD students, which I go and give. So just be with me, because you are more experienced and you have everything, but this is just to revise the thing, statistics thing. So yes, if you can say that what will be this is multiple choice question, and you can select more than one also. So let me say the first, not needed. Raise your hand. How many of you are saying not needed? Good. You all are in my favor. Mera job safe hai. That means everyone needs biostatisticians. The second one. Raise your hand if you agree that, okay. I can sense as a statistician 10% people saying one statistician is needed. How about 2? Okay, again 10%. Then how about 3? Only 1 person. हमारी बायोस्टैटिस्टिक्स कमेटी को सपोर्ट करते हुए How about a biostatistical center? Oh wow, everyone wants. Because one is overloaded, right? Great. Because I have worked in couple of hospitals, Rajiv Gandhi Cancer Institute, Roni, and Indian Spinal Injury Center, where I have been giving DNB students these talks, handling the thesis. So this is very much required, and you also might be aware that what is the, if one statistician, hospital is having norm of having one statistician and he or she is overloaded with all kind of work because doctors are doing their research, students are coming and asking these things. So always it is recommended that to have a biostatistical center. But the answer of this question is depend on the what type of study design you are going to conduct. It's not just only your choice that I want a biostatistical center or something like. How it is related with the research design? So the first option, so all options are correct. Let me explain one by one. If you have been, as a participant, are the MD students or DNB students, then the first option is okay for them because they are generally exposed to the orientation program of biostatistics before starting their thesis. So we generally have, wherever I go several hospitals, still they have 5 days or 4 days MD and that orientation program before committing, starting their thesis work. So if you are going to get 4 and 5 days extensive training on developing the protocol and analyzing, then it's the learning point and where you don't need the biostatistician for analyzing your thesis, especially for analysis purpose. You have to analyze your thesis by yourself. One is needed if it is a simple large study and observational study, then it's okay. One statistician has to be there. This is no chance that any research institute is existing without the statistician. One has to be there. The 2 and 3 comes from the guidelines, GCP guideline. So there are 2 types of GCP guidelines. One is ICH, one is Indian GCP guideline, right? So we have to train in both because we sometimes do the global trials, sometimes we do the Indian trials. So this specifically has been written in both the guidelines, but ICH guideline specify the name of 2 statistician and 3 statistician, okay? So they name that you need 2 statistician in a way if you are doing the blinded trial, okay? So they name the first statistician will be the trial statistician, and another statistician will be the independent statistician who will be responsible for generating the randomization code and blinding, just to maintain the integrity of the blinding. So one statistician who is generating the blinding codes, keeping these codes and presenting it to the DSMB later on. So this is independent statistician. One is trial statistician who is involved from the beginning to the end of the study with the institute. So independent statistician doesn't have to be associated with the same institute, but trial statistician can be the part of that institute because he has to calculate the sample size, develop the protocol, write down the statistical method. Later on he has to or she has to analyze the data. 3 means if you are doing some trials with the interim analysis, DSMB member has to be there who is going to assess the analysis in between. Then third member has to be, one person has to be in DSMB as a statistician. Biostatistical center always, if you are doing multi-country and multi-centric large trials, so every site should have one statistician, like let's say for multi-country trial, and one initiator has to be the one representative of this trial, but biostatistical center can be in different places. So let's go to the study design. When we talk about the study design, number of things come into our mind that these are the terminology which you have been using, right? Interventional versus observational. It is very clear that observational and interventional that means you are going to give some intervention to the subjects and then you are observing, and observational that means you are not doing anything in the simple uncontrolled environment and you are observing the patient, those who are coming to the OPD directly. You are not giving anything. Regular medicines they are taking and you are analyzing their data. Now let me ask one thing. Before starting this session, let's say I have given one question paper to you as a pre-test, and after my session I'm giving just to assess myself, not to you, that how effective my session was, okay? And I have given the another, based on the whatever I have written in the slide. So that was the second like post-test. So which kind of study design it will be when I am collecting data, analyzing to check my efficacy or efficiency? Intervention? Everyone agree, or somebody wants to say it's observational? Interventional? Observational? This is always, David, whenever, like this is being 20 years I am teaching, and everywhere people think that there's some people say observational, some people say. So this is just to tell that sir is absolutely right. It will be interventional study, it will not be observational, because intervention doesn't mean that you have to take something or you have to invest something. Like behavioral, I am intervening through my teaching. That is also an intervention. Behavioral sciences and other thing, guidance, counseling. So this is a kind of counseling. So this is an interventional study, not the observational, okay? Longitudinal versus cross-sectional. It's obvious from the name. Cross-sectional, that means one time point study. One time point you are collecting data. So it's related with the data collection. So that's how the data collection also comes with the study design, okay? Longitudinal is a specific thing, like if I am following, because I am doing MD thesis or DNB thesis, I don't have much time. Maximum 1 year, because 1 year is the course work, 1 year for the thesis work. So just only following subjects for a year or maybe 6 months or 8 months, it is not a longitudinal study. Though you are collecting data at different time points, let's say every week I am collecting data, but it will not be called as longitudinal study. It will be a cohort follow-up study, simple prospective, because you are starting in the January, ending your data collection in the December, because you have to analyze and submit your thesis. So it is a simple prospective study. Okay, it will be a prospective study, but when you have to say longitudinal, if it is going beyond 2 years follow-up I am saying. If you have follow-up more than 2 years, you can say it is a longitudinal, and that you can write in the title of your project or thesis that it is a longitudinal study. It is always suggested in title if you are writing after the colon that what kind of study design, a parallel randomized controlled trial or longitudinal study or cross-sectional study, case control study, it is always better, okay? Then what is the difference between prospective and retrospective? There is also one confusion. Prospective means for the future, that you are collecting data from now as a baseline you collected, and then you are going to follow the patient for as per your choice. Like for the anesthesia department, they cannot follow the patient for years or months. They also do the cohort prospective study, but their times of that is in hours or in maybe the hours or seconds maybe, because anesthesia you have to see and how it is going. So that is also a prospective study, because you are seeing baseline, what was the, and when they are going to the conscious after some time. So that is also prospective. Retrospective means what? In a simple English language, retrospective means? So we don't have the time travel machine that we can go, Avengers ki tarah we can go back, and I can go in 2006 and I should say, see कि मुझे PhD की जगह MD करना था, अभी पढ़ के लग रहा है, so I can go and do the MD, I cannot. So we don't have the time travel machine. So what is the retrospective means then? Medical records. So there is one confusion again with the retrospective. I generally recommend, this is my personal experience, you will not get this statement in anywhere in the book or literature. Because I worked in cancer hospital, and we used to get the data, 5 years data, to see the survival and this thing, this is not a retrospective data, because if it is related with the study design and you are writing retrospective, that means you are collecting the past data. Retrospective, that means, because study design is related with the data collection. Data collection when you are doing past wala, right? Then retrospective study if you are writing, that is only one retrospective study exists, that is case control study. Agree? So in case control study, what we do? We have cases and controls at one time point. It's a like mix of cross-sectional study. We are doing at one time point collection. But why it is known as retrospective? Because we are having the outcome and we are looking for the risk, that what risk they were having in the past so that they have got this outcome, right? That is a case control study. So we are collecting data now about the past. That means we are assessing the patient. We are asking the patient. That's how there is a recall bias, because patient may recall correctly or may not. This can be the guesswork. Or when you are collecting data, patient is frustrated with the treatment and he is saying that kuch bhi keh diya usne, whatever is coming there. So that is like lots of bias is there. But this is the only type of study design by which we can get some information and correlate it with the outcome, right? So that is also important. So what happened? Retrospective, if you are collecting data from the MRD department for 5 years, 10 years and analyzing it, this is secondary data. You have limitation. Whatever it is existing, you have to analyze. You cannot do anything. You cannot add on. So that way, I generally don't call it as a retrospective study. Don't write it retrospective. You just say hospital-based data study. Hospital-based data you have taken for 5 years, and hospital-based data study is this. But retrospective case control study means what? You are going to the cases as well as the controls and asking what happened in the past, whether you have been using mobile phone for such long time, you have been cooking everything in the microwaves, or what you have been exposed, or you were working where the pesticide exposures was there and that's how you have got cancer, or that's how you have not got the cancer. So you have to ask at the same time the cases as well as the control about the past, and that is called as a retrospective study. Case control study. Okay, so the data which you are gathering from the MRD department, that is not a retrospective study, so please don't write. That will give you more clarity and you can explain. The next is randomized versus non-randomized. It is experimental studies. So in experimental study, either you can randomize and you can not randomize. You can choose. You have to write a non-randomized clinical trial, or there is another word for quasi-experiment. There is another word for non-randomized. You can write quasi-experimental study. Because sometimes ethics committees say it is not feasible, it is not ethically correct that you have to randomize the subject because of the patient severity. Patient is coming with the severity and you cannot randomize that more severe patient should go in the standard drug, or you have shown the superiority trial is there. You cannot refrain the patient getting the good treatment, right? Because sometimes the patient who is in the mild stage and you are giving the extensive treatment. So sometimes it is not feasible to randomize, but it is a controlled trial, clinical trial. In that sense, you can do the non-randomized control trial. Blinding and open label. So these terminology, if you see, all should come reflect in your, not all you have to write, but you have to choose a specific term which is matching to your study or the program which you are initiating. So blinded versus open label. Open label, that means everyone knows what is being given to the patient, investigator is aware, assessor is aware, and patient is aware. In blinding, there are different types of blinding. Single blinding, where patient is not aware of what is being given just to eradicate the, which effect, which bias? Placebo. Placebo effect, exactly. So placebo effect, because patient will know that what is being given, placebo is giving to me or treatment is giving to me, he will be thinking, yaar yaar main to theek hi nahi hounga, mujhe placebo de. So just to eradicate that placebo bias, we have to blind, it's for the patient only, because it is investigator choice, because he has to assess in between the treatment and then know what is happening, but patient should not know. The double blind means investigator is also not aware what is being given and not the patient. The triple blind means statistician is also not aware. Okay, and there is one term people are using now, assessor blind, because sometimes investigator should know what is going to happen, patient also should know, but assessor who is assessing the outcome, end point, he should not know what he has gone, because the true effect has to be recorded. So you can also write the assessor blind study, apart from single blinded, double blinded, triple blinded, assessor blind study. This is assessor blind, that means who the person we have appointed to collect the data, let's say if he is recording the pain. So he should not know that pain ke liye kaun sa therapy diya, which one he has got. It's like steroid diya or the normal painkillers. So he should not know, otherwise he can be biased writing, अरे इसको तो ये मिला था, क्योंकि patient sometimes is not able to tell कि कितना pain है, right? So he should be aware. So these are the, I have briefed the study design, I'm not going into detail, the basics part, but just to brief you, to get the idea how many study designs you can have in different areas. So let's go quickly on this. We have just descriptive analytical study. Descriptive, again, you have simple sample surveys. That means this cross-sectional study, case series, census, observational studies. Then in sample survey, you can use the different random sampling and non-random sampling based on your criteria, simple random sampling, systematic, and other sampling methods. In observational study, so let's come to the analytical part, because if you are initiating any research, definitely you are going to analyze your data, right? Lots of information. So let's come to this analytical part. You have you can have the observational analytical study and as well as experimental study. So under the observational study, we have already seen prospective, that means follow-up studies. Longitudinal is different than the cohort, which I said. Cohort, that means if you are following patient less than 2 years. Okay, up to 2 years if you are following, then it will be a cohort study. If you are following the patient for more than 2 years, it will be longitudinal study, and other kind of follow-up if you are doing, you can write. Then retrospective control study, nested case control study, and there is no control, just only we are assessing the cases. Cross-sectional study, one time point we are assessing, exposure. Now in the experimental study, clinical trials are there, field trials are there, laboratory experiments are there, but we are mainly focusing today on this talk is clinical trials. So you have to see that whether it is a therapeutic area, diagnostic area, screening, prophylactic, then you are doing with control trial or not. Then you have to say it is a randomized, not randomized. Then again you have to segregate blinded, not blinded. Then if it is a blinded, then that what specific study design I have to pick, and that has to reflect it in the title. So let's start from the research question, because statistical method starts with the research question. Once you have research question, from there only the statistical method, because few information we have to have from this research question. So we have, for example, this is the research question. Does progesterone therapy reduce the incidence of preterm birth before 37 weeks among high-risk pregnant women compared with the standard care? Can you tell, because I know everyone is aware about the how we have to write the research question in which format? There are two formats, PICO and finer, right? PICO and finer. PICO is, are you aware of PICO? PICOT भी बोलते हैं अभी. T, time point. P means population, I means intervention, C means comparator group, if you have any, and O means outcome, and T means time point. if you can include. So let's segregate this. Can you tell me what is the population in this? High risk, pregnant woman. And then I means intervention, progesterone therapy. Comparator group is? Standard care is the comparison. And then outcome is? Incidence of preterm birth. Good, very good. Time point is also given before 37 weeks. So everything is there. So, question. Yeah. So you are saying that, I don't know where this. Okay. No, but we have two different groups. Yeah. So if you see here, what you want to say that population, we are saying high risk pregnant woman. So pregnant population hai. Okay, this is a study population. Then we are randomizing them into two groups. No, no. Yes. So this is our study. So how this study population comes into the picture? How we are defining what are the factors in the protocol? Exactly. So inclusion exclusion criteria defines your study population, right? You have to write inclusion exclusion criteria correctly. From there you will get the population. Intervention, you have to write progesterone therapy. So this is written a single, for the title it is okay, but you have to specify what therapy you are going to give. Number of different therapy might be there, so you have to specify the name. Comparator is standard drug. Here also, like, it is okay for the title and research question, but inside that you have to write what is the standard care you are considering and what is the therapy you are giving. Outcome is preterm birth before 37 weeks. Outcome type, binary outcome. What is the binary outcome? So outcome type also we have to know to calculate the sample size and to know the statistical method. So incidence. And then expected effect is reduction in event rate. So if you are aware about the E9 guidelines, which talks about the statistical principle, ICH E9, they have issued an addendum of 1. They are specifying that if you have to specify all these terms as a estimand. So this is known as estimand, estimate, estimators and estimand they have introduced. Expected effect, no, you have to think beforehand only. You are looking for the reduction in the effect size or improving, that you should know the reduction hai or it is the improvement. So you will definitely, for educational study, you will look for the improvement. So that word has to be mentioned. Change in the outcome. Exactly. But you have to write, yeah. Change from baseline. This is okay. We don't know whether it is going to be positive. Exactly.
If I can add on, sir, जब estimates नहीं होते हमारे पास, so you being a clinician, you will have to give a estimate thinking that what change will be meaningful to you clinically. So let us say there is drug A which cures 60% of people, okay, and we are testing a new drug B, and it just cures 62. Is it really meaningful to you? Clinically, अगर हम देखें तो 60-62 might not be very meaningful, right? But let us say if it is mortality, okay,
be change, just only the change. Yeah, change only. Which group is changing?
I would like to add a point. We are talking about chalkboard or anything, but we are expecting that PowerPoint presentation would be the good option. We are expecting. That's why we are doing the study. Maybe it will prove wrong.
Yes. Yeah.
हो सकता है कि जो हम expect कर रहे हैं वो wrong prove हो. We are just doing study.
So that's how now there is a difference between your research hypothesis that we are expecting that PPT presentation is better than the chalkboard. Okay, this is your hypothesis.
People generally think this way. The old people generally
Exactly.
say
I am with you, sir. I am with you because PPT is just like they take for granted and we will get the PPT and later on and later doesn't come. So that is okay. But for this perspective, what she is saying that then you have to write the statistical hypothesis to test it. Null hypothesis and alternative. Null hypothesis, that means there is no difference. Alternative, whatever you are writing, that you can think. Okay? So,
If you already given the title, that is a positive outcome, then it's a bias.
yes,
Rather, change in the outcome is more, is a neutral bias.
neutral.
It is no neutral.
That means that is a
Title,
research.
that is a bias. If you don't put in title, then whatever the outcome may be, you have to present it.
But you can write this, like we are looking for the reduction, that for this case, it is okay. Because that you are looking for, reduction in the mortality.
नहीं काम मगर सर का पॉइंट बहुत वैलिड है, वो बात
नहीं,
हमें नहीं करना है, जीरो रखना है. हम रिडक्शन चाहिए, हम तो बस देखने के इफेक्ट क्या होगा.
Sir, अगर if you are not looking for reduction, it is not ethical to do that study. If you expect कि आपका इससे incidence बढ़ सकता है, you will never do that study.
मैम मेरे ओल्ड पर्सन प्रोफेसर हैं, वो कह रहे हैं हम तो चॉकबोर्ड पढ़ाएंगे. मेरे नए बंदे हैं जो बोल रहे हैं कि तो पीपीटी
हाँ, this side, let's,
This title right
हाँ,
now. So if you are expecting in this that incidence of preterm birth will increase, you will never do a study, right?
exactly.
Your hypothesis has to be that it will lower it.
You have to
For chalkboard,
you have to convince
you
the,
can always do a small pilot. You know,
exactly.
you can teach students one class with a PPT, one class with a chalkboard. You can do a pilot and generate data and then give it to madam to
Calculate
do a
the sample
size.
size.
These are easier studies.
But
where
you have
do
to
a
have,
pilot. But for these kind
because
of
if you are
studies,
not
you cannot
writing in
say
that,
शायद बढ़ जाएगा.
yes, if you are not writing in the title, people will ask why you have not written, what is your goal? Yeah? Yes. Binary outcome actually incidence how we are recording it, yes and no, whether this has happened or not. That's how binary we are saying. So we'll come to this binary and continuous later on. So based on the study design, if we have parallel, based on the sample size, if we see the parallel RCTs, they have moderate sample size you will be needing. And why? Because you will be needing independent group. Versus the crossover. Crossover, you know, that the same patient is giving both the treatment, but after the washout period, and the same patient act as a control of its own. So that's how you need smaller sample size for the cross-sectional. Cluster trials large because
The crossover is the same patient for them. Rather, two groups are being reverted.
the same group, like one group,
Control was first control and second subject was second. Now the subject becomes control and control becomes subject.
subject, yes, yes. That's how the sample size reduces for the study when you say the cross-sectional study. Cluster trial, why you need the larger sample size? Because you have correlated observations and large scale has to be there. One whole cluster has to be selected for the intervention. The single arm study always smaller because you need only one arm, no comparator is there. Non-inferiority, again you need the larger as compared to the superiority trial, you need larger sample size to prove the precision. Then factorial experiments, they are little complex, efficient, but yes, little complex. Very limited studies are there with the factorial designs. Adaptive designs are flexible. So now everyone is talking about the adaptive designs. Let's talk a little bit about the adaptive designs. Have you heard about the adaptive clinical trials? No? So adaptive means it's kind of, well, we can change anything. Okay? So this is a simple terminology which people think that adaptive, so when you're writing it is an adaptive clinical trial. So that means you are expecting some change during the clinical trial. So that change might be the sample size, that change might be the randomization, that change might be the dose of the treatment. So different, like number of list is there. This is totally different area to understand the adaptive design. But if you are writing in your title, thesis title, that it is an adaptive clinical trial, beforehand, each and every adaptation which you are going to do between the trial, that you have to mention in the protocol before approval, before initiating the trial. It is not that you have an adaptive clinical trial and you can do any changes. That is not at all recommended. So let's say if I am saying I am doing the 3-arm study, one is standard care, another is my new drug standard, one is standard, another is treatment drug. And treatment drug, I am not sure that what is the dose of this. So let's say I am taking 100 mg and 150 mg, 2 arms, just to see. And I am planning interim analysis between, like after 25 subjects, after 50 subjects, I will do the clinical trial. And let's see which arm out of these two is doing better. That I will continue and I will remove the other arm because it is unnecessary, taking much time, patient, and we will shift these patients into that arm. So that adaptation you have to think, you have to say, I don't know which arm I have to, but I might, based on interim analysis, I might close or just leave one arm. So this you have to mention beforehand in your protocol. So this kind of adapt. Let's say, for example, we are doing a chemotherapy trial. So here what happened, that it's very expensive trial. We have, like, this is phase 3 trial. We have already committed that we will do this trial in 300 subjects. But if after the first or second interim analysis, very good results are here, then early stopping is good. Unnecessary why we have to do and conduct this trial. Or maybe this particular drug is not at all working. Because of the futility, we can stop it early. So these things you have to mention, or maybe we can say we are not getting enough subject, we can increase the sample size. We will recalculate the sample size after second interim analysis. This might say the second, based on the results which we are getting in the first or second interim analysis, we will again calculate the sample size, and if it is coming less, we will stop there only, or if it is saying if we have to increase, we can increase that time. So accordingly, we have to plan and generate the randomization list beforehand for the higher side. So adaptive clinical trials, because this is more flexible, interim modification we can do, it is now popular in everywhere.
I have done a study about the ventilator-associated pneumonia, and I have to take the intratracheal sample 1 or 2 times, as I mentioned in my study. But for the few patients which require longer ventilator therapy, and we have taken 4 or 5 samples, I have excluded those patients out of my study. But in case if I have added that like this is the adaptive study, and so I can include those patients.
Yeah.
If I have.
So everything is related with the sample size. If you would have said
I
your
have to mention that thing like every time like I can take 2 samples, or I can take 3 samples, or I can take 4 samples on that
yes.
time of
So
period.
it's not about 1 sample, 2 sample, because statistically you will not get that much of data. So it is suggested, because there are some terminology O'Brien corrections and factors which you have to add at the time of sample size calculation. If you are mentioning that you will assess the outcome, because sometimes it is a blinded and you are not allowed to assess the outcome in between.
Should I have to mention that time period and everything?
Yes, that's how I'm coming to that point, that let's say you are saying that you are recruiting 50 subjects, small sample size. In that, if you are saying that I'll do the 2 interim analysis, or maybe the 3, your sample size will go from 50 to 100, because you have to add that factor that every time you are seeing the outcome and efficacy, and you are increasing the type 1 error. So that I'm going to come that what are these statistical terms. So you cannot directly, you can not write that after 3 patients I will see, no. Then again you have to justify with this that 3 interim analysis at what period of time. One is duration, you can mention ki every 6 weeks or every 2 weeks I will do this, Or you can mention that 10% of the subject first interim will be done, the 10% of the subject, second interim will be done on the 30% of the subject, that means out of 100 subjects. So that you have to stick. You cannot say that I will take the 2 patient or 5 patient, I will do them. No. Yeah, so this is like very technical term. Adaptive itself, you have to learn lot of things like how you can use. From your perspective, you have to go and read, because there are, which I have read, more than 15 terminology, 15 factors by which you can do the adaptation. So which is matching in your criteria, and then you have to follow. Just like for case control study. You cannot do in the cohort study. Cohort study, that means you are taking at one time point all the baseline patient, and then you are following them to achieve the outcome. But in the case control study, you are taking all those who have achieved the outcome or not having the outcome, and then you are asking them about the risk factor. So every study design have their own like assumptions, restrictions which you need to follow. Similarly for the adaptive, you have to follow that what you exactly want to do, and you will get the literature. Lots of ICH also has released the adaptive clinical trial guideline, which you can read, and you will get the idea definitely in that.
Just one point to add on what you were asking, that you have to mention in the protocol or not. So adaptive does not mean that you can change whatever you want at your will. As madam is again and again saying, it has to be mentioned priorly in the protocol that these are the changes that you may make, and what will these changes be based on. So she gave an example that we are taking 2 doses, and let us say in the middle of the study we say that the higher dose will have more adverse event, more severe adverse event. We go to a committee and we decide that we drop that one arm. But this will be prior mentioned in the protocol that we will change the protocol from 3-arm study to 2-arm study. Similarly, if you want to change any timelines, you said because some patients went on longer, that has to be priorly mentioned that maybe your primary outcome is at 1 month, but because primary head or their discharge later or their samples are collected later. This all has to be priorly mentioned. You cannot mention anything based on only the title adaptive.
Exactly.
Adaptive means it is flexible.
Absolutely.
Sometimes like we get to know during the study, then can we add in the protocol and get approved by ethical committee? You can always amend the protocol, but that has to be gone through the scientific review committee as well as your ethics review committee. And of course, it has all other obligations, like if you have to change your
If you are doing a study on surface, exactly, everything, everything you have to mention. You can have 3-4 different factors. Yeah, you can have 3-4 factors, adaptation factor.
only adding the word will never help.
Yes. This we are trying to.
Adaptive word is in the title, but on what criteria this is adaptive will be
That has to be mentioned.
without those criteria, adaptive doesn't mean really anything. If you haven't mentioned, you might change your sample size, you might change the arms, or you might, change some kind of methodological changes, some kind of number changes. If you've not mentioned that, only adding adaptive word is not going to help you.
Yeah. I think I'll suggest first read that guideline, and then you will get fair idea. Otherwise, you can contact us. Dr. Pooja will give our numbers so we can discuss.
And you mention all those things. Thereafter, we think that probably some more corrections are required. It has already been approved by the ethics committee. You have started the trial. Can you change that thereafter?
Yes, sir, you can always take it to the scientific review committee and ethics committee.
Even after the start of trial?
If you have already added adaptive and you have mentioned some criteria and you are changing your design based on those criteria, you will not have to go back to your ethics committee because it is already approved.
No, but here I want to add one thing, sir.
Which is not mentioned in the protocol.
That's how I'm saying here, because we do that kind of trials in our organization. If you are thinking after that, no, this one factor has to be added, then again you have to revise first the protocol amendment you have to do, again go to the ethics committee. scientific committee. Once it is passed, if it regulatory is involved, then you have to inform the CDSU, their SSC meeting you have to do, and then you can apply that. So this is a whole process. Yes, yes. So in between you can do the protocol amendment, that this amendment is required, but the whole process has to do again for that one-pager document. Okay. So after study design, let's talk about data. Come to my own subject, because data is what we worship, because that is giving us DATA, data, DA and TA, right? So we say data, that means it is, we are getting DA and TA from data. It's done, ma'am? Yeah, non-clinical. Observational I am not covering, because, you know, it is all about the good clinical practice, clinical trials only. Because that is another vast area. I have to cover all the sample size design and how we have to take up, which time doesn't permit. So we are starting the basics of statistics now. Study design is over, but that will come again and again. So when we talk about DA and TA, we have to start first thing that how we are going to collect data, but how many patients are required, how many information we have to collect, that is the sample size, right? So first you need to calculate the sample size. How you have to calculate the sample size? We have some information afterwards, so we will see what information is required to calculate the sample size. After that, once you have the sample size, how you are going to collect the data. So for that data collection, you require the data management technique. Just like this is like in clinical trial, very must one-pager document you have to have within the protocol, that how you are going to manage data, where most of the Indian study fails to get the grants and other, because we don't know and we are not mentioning the good quality research we are not developing. So this is the hardcore of any clinical trial, any study. If you are collecting the good quality data, you are going to, important part, even I say more than the statistical method which you write. You know that we have to write the one statistical method paragraph in the protocol. But before that, you have to write the data management, that or it is a database which you are using, how you are going to collect the data, what will be the data capturing method. It will be the paper-based data capturing, or it will be electronic-based data capturing. And you have to see that whether these software with this particular regulations, 21 CFR part 11, especially if you are doing the regulatory trials, then you have to see. Now, let me ask one thing. Let's say I have developed the CRF, case report form, and I am entering that data into the, which type of data collection method it will be? Paper-based CRF, PDC or EDC, you have to give that example. What I am asking, I have developed the distributed to the nurses or whosoever is collecting the data. I am entering the data into the Excel for the analysis, or any software, SPSS or whatever you use. This is EDC, means it is directly going to the server. You cannot make any change. You have to give, instead of paper CRF, you have to give the tabs or mobile phones app you have to develop. From there it is, have some inbuilt procedure. If you are by mistake typo error, let's say for blood pressure, if you are writing 20.5, which is not the correct observation, it will not allow you to put this there, right? So that kind of things are there in EDC, and there are less error, because sometimes you are not able to guess what is the handwriting, and then we do the double data entry in paper-based CRF. Case report form, a questionnaire, then you have to develop the data management plan. This is very important. You have to write in the protocol, if you are not sure much, that we are going to use PDC or EDC, that you have to mention in the protocol. And then you have to mention a separate data management plan will be developed after approving this protocol. And then you have to, another is a statistical analysis plan, which is known as SAP. So these two documents has to be attached with this If you want to do really good clinical trial, that has to be 2-pager, 5-pager or 10-pager. The detailed things will be written because protocol doesn't require to write many detailed things. Protocol has to have the inclusion exclusion criteria, patient, drug, investigator, objectives, all these things, and sample size calculation and what statistical method you are going to do it. So one paragraph of data management plan and one paragraph of statistical analysis plan in brief you can write, and you can write separate data management plan will be developed for this trial before initiation. So this is the process of paper-based CRF because of entry and clarification form has to be filled, resolution and database lock. In EDC it is directly going to the server, but still if there is any query it can be resolved, and this is faster procedure. Now we are using the same terminology in a different way because of statistics. Data, which is the information, and that is we are saying the variable. Variable, why we are saying variable? Different age, not exactly. Everyone is having different age. Age is a variable. So we are saying the information which we are collecting, that is variable. Now again you have come across with different types of variable, primary and secondary. What is the difference between primary and secondary variable? Well, that means you just consider information which you are collecting. Primary information versus secondary information. So primary, that means which you are collecting, and secondary which you have, that is secondary data, because you are restricted. Whatever is available that you have to analyze. But primary, you are having free hand, you can propose anything and you can collect, right? Independent versus, so it is the cause-effect relationship when you have to find out that information you have to correlate. One has to be independent, one has to be dependent on that to find out the cause-effect relationship. Predictor versus, but you can also use this predictor and response in statistical modeling. Again the prediction, the predictor and response, through the response you can predict any outcome. Outcome versus exposure, that highly. You are starting, what is the difference between case control study and cohort study? In case control study, you are starting with the outcome and going back and looking for the exposure. What was the outcome? In cohort study, you are starting with the exposure and looking for the outcome. That means I have taken the subject, those who smoke, and looking forward that out of all some may not develop. Okay. So 2x2 tables generally used in case control study design as well as cohort study design. Then you have nominal variable, ordinal variable, dichotomous variable, discrete variable, continuous variable, quantitative, and so these are the terminology which we use. So we will understand this. This is only the classification of the variables. This separates a number from this slide. Okay. So mainly we classify data into 3 different parts. I have covering, that is the different thing. You can convert that also into quantitative and qualitative. So quantitative and qualitative means, it's obvious from the word, a specific measurement unit. You have to have standard unit. I cannot say that I will quantify blood pressure in kilogram and she will quantify the blood pressure in liters. It has to be a standard unit for all. So you need one standard unit of measurement. That's how, if you have, let's say if you are measuring quantify. If it is not, then it will go into the qualitative, because we have to analyze the qualitative variable as well. These are important variables. For example, pain, back pain or leg pain. So if I want to measure that and I want to see pain reduction, I have to do some analysis. So I cannot say that I will, right? Or pain yes and no, differently. Like I have to categorize in different ways. So that will go in this category. So numerical quantitative variables. Now there are subcategories. So subcategories are continuous and discrete. So what is the difference between continuous and discrete? In general term, we are observing one information, sorry, and then we have the finite option, very finite option, size is 8.75. It has to be 8, 7, 5, something. I have finite options that will go into the discrete. What the shirt size you wear. Shirt from, if infinite options are there like age, temperature, BMI, which we are calculating, you can write in decimal points 1.99999 something. Finite options, number of patients. I cannot say number of patients are 25.65. I have to have a specific number. Categorical, again we have two, ordinal and nominal. What is nominal? For example, severity of disease or stages of cancer. I have 4 stages of cancer. I cannot say it is nominal. Why we cannot say? Because we cannot observe that stage 1, stage 4, stage 3, stage 2, ordinal value. Why it is required to categorize your information in such way? Because as you are saying, one information is categorical, same information, your statistical method will be different to analyze. That's how it is very important to categorize your variable. So pain severity in any categories, like it doesn't matter, you have to order it. You can start from alphabetically A positive, B positive, A negative, A positive. It doesn't. Number of subjects in this category. For male, female, gender is a nominal variable. You have to write male, female or other. If I am doing a study, I will write female, male and other. Now this is one example I am giving. When I was doing the case control study, I have conducted one case control study after doing lots of study for investigator. I thought that let me initiate, because I was reading literature and I was thinking that breast cancer, there was a bimodal distribution we found. Earlier literature, Western literature, what it said, Western literature was saying. But working in Rajiv Gandhi Cancer Institute, I found that very young females were coming there in 2018. I thought there is some initiated. I have listed down hundreds of risk factors because I have done literature search, list down what Western is saying, what Indian studies are saying, and what is matching. Then I all available in Indian scenario, right? Because that is just only for the Western countries. So after that, you can read that, you can find out the name, you will get that research article. And we found that stress factor is associated with stress, and sleeping pattern is highly associated with the breast cancer in the bimodal distribution. So when I prepared the questionnaire for cases and controls, date of birth, as everyone knows that a date of birth आएगा, उससे हम age calculate कर लेंगे. But what happened? When I started collecting data for 1 or 2 patients, not more than 5 patients, the ladies were coming of 72 years age, 75 years age, they don't know their date of birth. Then what I have to do? I have to change the questionnaire, write your age in numbers, like in years. Okay, that is discrete age. So in original form, age is the continuous variable. But how you are collecting method? So I will say I am collecting age in years, discrete form. So they have to just tell, क्योंकि वो उनको याद ही नहीं होता, तो वो कहते थे वो जब लड़के की शादी हुई थी उसके 5 साल plus minus 2 you have to adjust. It's mandatory, but still if you are doing a research at this age, you have to consider this factor. This is true feedback. So age can fall in all categories except nominal. How? I am behavioral scientist. I am not interested in average age. I want to present this behavioral change after post-pandemic. Smartphones. Everybody is in smartphone. Elderly people से लेके देखो तो 5 साल का बच्चा भी mobile phone use कर रहा है. So that will be use age as an ordinal variable. I'll have 4 categories: child, adolescents, adult, elderly people. So that is an ordinal variable for me. And based on that, I'll analyze and I'll say ki what the elderly people think, what the child, what is the status, like that. So similar way, if you have one let's say for example smoking, not write vegetarian, non-vegetarian, or you can write, like I was having more than 10 categories for diet, just to see, because Western literature was saying red meat is associated with the breast cancer. But in Indian scenario, I didn't get any association. Why? Because we put lots of masala, haldi, and that effect already goes away. So diet was not at all related with the breast cancer. But Western literature strongly emphasized that red meat is associated with the breast cancer. So we have to see that how generally student write, the smoking will be the exposure variable. But you know, you have to analyze that variable, how you are going to assess. So can you tell that smoking will fall in which category? Quickly. All agree? But I say that I can measure as a ordinal, I can measure as a nominal as well. This absolutely. Packets, yeah. So if I am collecting information, number of cigarettes smoked per day or number of packs smoked per day, that is the discrete. Okay, if I am assessing that smoking is ordinal, I'll categorize that the non-smoker, ex-smoker, current smoker, chain smoker, that kind of, okay. Then I have to define each and every category. How you are defining ex-smoker? You cannot just only write the categories. You have to write the ex-smoker means what? Those who left smoking 6 months back or 1 year back. That definition has to be there for each and every category. You cannot write just, everybody can have the different definition, okay. Now let's talk about one funny example of coffee drinking. So if I write in my questionnaire that do you drink coffee? So this is open-ended question, behavioral sciences mein kaam aayega, and people may write that I drink coffee when somebody takes me to a Starbucks. I drink coffee when somebody cooks me. I drink only brew coffee. I want just only Nescafe. I don't drink coffee. That means we are collecting information that person is not a coffee drinker if they are not writing. If it is a discrete variable, I will write in my questionnaire that how many cups of coffee you drink every day. So then discretely they have to say I drink every day 1 cup of coffee or 2 cups of coffee morning, evening, or they don't drink coffee, then they will write 0. So we'll get the information. If it is a clinical trial and you are saying that coffee is associated with the pancreatic cancer, positive term or negative term, we are talking about the black coffee without the sugar, not Indian coffee with the milk and lots of sugar. So let's say we are saying that coffee drinking is very good for or to heal the pancreatic cancer or something. Then we have to give measuring cup to the patient and patient diary to them. Every time they are drinking, you have to say that you have to write the amount, 40 grams, 20 grams, whenever you are drinking. So exact amount we will get and we can get. So this is the art of collecting data, how detail you are collecting and analyzing that. So let's come, once you have collected data, I'll quickly go through the statistical method. It is not just like I'm going to teach you how to calculate the chi-square or t-test, just only the brief. So statistical methods are of two types, descriptive and inferential. Descriptive means you are describing, let's say if I am describing how many participants are there, what is their average age, how many males are there, how many females are there. I am not drawing any inference, not any conclusion. Okay, that is descriptive. Let's say if I am saying I am an inferential way, we need more than 2 things to compare, sample to compare with. Then only we can draw the inference. Inference means good or bad, or increase or decrease. So comparison has to be there. In normal life we say don't compare, but research में तो compare करके ही मिलता है paper, right? बच्चे आजकल कहते हैं why you are comparing me with the पड़ोसी का बच्चा, but यहाँ तो compare करके inference मिलेगा, otherwise नहीं मिलेगा. If I will say I am the only statistician in the world, you cannot do the inferential statistics. You have to describe she is like that, she stands, she talks, she doesn't talk. You cannot say. If you have many statisticians, you can compare me with the other. So for the inference, you need comparison. So very like short summary of graphs. Everyone knows there are number of descriptive analysis graphs, pie chart for categorical variables, multiple stack bar charts for 2 categorical variables, histogram for 1 variable, scatter graph, box plot, line is limited, and I have to cover more important slides. So you also know about the measurement of central tendency. We have mean, median, and this is a symmetrical distribution. Your data is symmetrically distributed. If you have different median and more than the mean, then it is skewed. Maybe it will be negatively skewed or positive to the normally distributed. So normal distribution assumption is associated with the sample size. Now this is what graph this is. This is the smartphone. So people used to use, when I was studying, the histogram to assess the normality of the data. But now people are using this box plot, which is a picture of the data, that whether you have any outlier in your data or not, what is the quartiles, median. So this box represent your variation. If box is small, that you have less variation. If box is from the square to rectangle, that means you have more variation. Whiskers are there, the blue lines known as whiskers, that it is negatively skewed or positively skewed. So everything is presented here. If you are giving the box plot in your research article, people will get that what kind of data distribution, and they can make out why you have used. You have skewed data in showing in the box plot, and you have used the parametric test. This is not correct. तो वहीं reject हो जाता है. As an editor, we generally do this. So let's talk about statistical inference. There are two ways to make inference. One is estimation, and another is hypothesis testing. Estimation, that means you are estimating your effect size. Let's say it's odds ratio, or the proportion, or the prevalence, or mean of effect of any drug. So that is just only you are estimating through the point estimation and interval estimation. Another is hypothesis testing, which you are doing. You are having some hypothesis, as ma'am says, that I want to know that this is with some subjects, this is working. So that we will put in alternative hypothesis, and null hypothesis will be null statement, that there is no difference. So general concept of statistical inference is coming from the population. We have, this population is not India population or China population or US population. This is your study population, which comes from inclusion and exclusion criteria. From this population, you cannot assess the whole population, because you are writing pregnant women. High risk pregnant women can be anywhere in the world. But this you have to do in your hospital setup or couple of hospitals, okay? So you will collect the sample, collect the data, do some statistics, and infer about the population. So this is the cycle. We have to have the representative sample of the population, then only you can infer about the. So we use two things, parameter and statistic. These are the two different terminology which we use. Both are the mathematical function. Let's say, for example, mean. Statistic will be, it is not statistics. Statistic will be the sample mean, and if we say population mean, that will be the parameter. P for population, P for parameter. So if one function, one parameter, one mathematical function is using population observation, that will be a parameter, and the sample observation, that will, so as for sample, as for statistics, sample mean, P for population, P for parameter, population mean, okay. So these are the methods which you have seen. So in estimation, we have point estimate and interval estimate, we will see. So you have heard about the effect size and 95% confidence interval. Everyone knows. I am not asking the definition. If you have heard about this term, okay. So I am going to explain a little bit about this. And in hypothesis testing, you have to see whether your data is normally distributed or not. Normally distributed, symmetrically distributed, or Gaussian distribution. Different names are there. Why we say normally distributed? Why we have said it? Because in every aspect of any part of life or research or anything, it is just like that. Your interest goes in the workshop just like that. You reach a peak and it goes down. आज से आपका वो interest नीचे चला जाएगा. कितना पढ़ा रहे हैं? It is normal distribution everywhere you can apply. That everybody will reach a peak and then it fall down will start. So this you have to check. If normally distributed is there, then you have to use the parametric test, otherwise you have to use the non-parametric test. For example, for blood pressure data, you have to compute average and standard deviation, that is a descriptive statistics, and you have to estimate the BP for all patients. So you will calculate one thing. If you are doing estimation, then you have to calculate the sample observation blood pressure and then calculate the point estimate and interval estimate, 95% confidence interval for BP. Otherwise, you can also test if a new drug reduces BP compared to the standard drug, that is hypothesis testing. So this is interval estimate. For example, this is average age of this participant. Point estimate, that means for this particular group, average age is coming 50, but 95% confidence interval, it is saying it is between 40 to 60. So let's say in this medical college, let's say on the same day, 10 programs are running in different departments. This is the average age of my, and another department is conducting another program. If we will say we are conducting lots of program, the confidence interval says that, okay, average age will be between 40 to 60. It may vary between that, but for point estimate for our sample, we have got 50. And how we calculate the confidence interval? This is the very standard formula, calculate the standard deviation, parameter, statistic, and then you have to add the error, okay? So you just change the parameter and statistic, you can, so this is a standard formula. Let's say for statistic is mean, the sample mean we have to write, and we can calculate the population parameter by adding and subtracting some error and alpha factor. And if your statistic is proportion, the similar way you have to, error has to be calculated for the proportion. If it is odds ratio, then you have to put the formula for error for the odds ratio. Any parameter you have to just replace and then. So what is this standard error? Here this error is of this statistic, right? Mean error or proportion error or odds ratio error. This is known as a standard error of mean. What is standard error of mean? Let's say, understand one concept, the standard error. We have one orchard here, okay, in this campus, and I am selecting a couple of, let's say, 3 participants from here, and I have given inclusion exclusion criteria to them. All are having the same inclusion exclusion criteria, same population, the same apple orchard outside. They are going, and I said that you have to pick the 5 apples from there. And you have to remember that inclusion exclusion criteria has to be met. You are going, sir is going, another person is going, and they are bringing. And I am weighing them, and I am getting the different weight. Why it is so? The inclusion exclusion criteria is same. The population is same, the orchard is same, but still we are getting the different weights of these apples. So this is not a mistake, this is known as some kind of variability which exists in this world, and that's how statistics exist. If everyone is constant, there is no need of statistics. Variability is there, and that's how we are assessing. If everything is constant, there is no need of statistics, applying statistics. So it is not a mistake. Error term we have given, but this is not a mistake. This always exists, and that we have to measure and plus minus with our point estimate. And that's how we get the confidence interval. So it quantifies by the standard error of a mean. It provides the measures of accuracy of sample mean. It is probably that the response do not reflect the appearance of the entire population. So as we say that it is not an error, it will always exist. Why it exists, we have seen with the example. And what does standard error tells? It tells about the precision of the estimate, reliability, inference, and it also helps us taking the decision. 95% confidence interval if you are giving, so you are saying with our sample we have got this much of effect size, but it may vary between this and this. So you are giving a one bracket that if somebody else is going to repeat the experiment, it will be in this particular bracket. So confidence interval communicates how accurate our estimate is likely to be, and that is consist of two boundaries, plus minus sign, that means you will get the lower limit and upper limit, and it interprets about like whether you are having the true parameter inside that confidence interval or not, or it is going beyond. And we do not say that 95% probability that the true parameter lies in this particular interval, that is incorrect interpretation of 95% confidence interval. Okay? So we are just going to say that whether true parameter lies between this 95% confidence interval or not. So let's understand few things, alpha and beta, if you have heard about quickly. Alpha and beta, level of significance, and what was the alpha? Alpha, and that comes under this 2 by 2 table. You know the truth is one side, and your decision which you are going to take experiment, that is one side. Null hypothesis may be the true, or maybe it can be false. Whether you accept or reject the table, everyone knows. So if it is true in reality, you accept, that is a correct decision. Similarly, if it is false and you reject it, it is a correct decision. With these two options, where in reality null hypothesis false and you accept it. Similarly, in reality the null hypothesis is true and you reject it. That is the problem. But because truth is unknown, you don't know the reality, that's how you are doing this experiment. So this will always exist. These two situations you have to cope up with, you have to adjust it for. So in statistics we define it as a type 1 error and type 2 error. These two types of error might happen in my experiment when I am doing, because I don't know the reality. Nobody knows the reality. So these are going to exist. So how to tackle these two types of error? And we define in the different terminology that alpha error, type 1 error is defined as a alpha error, saying or concluding that one is better out of two drugs or two therapy, one is better when in fact both are similar. So that kind of error is alpha error, and concluding that both are similar when in fact one is better. So you are refraining the subjects getting the better treatment. You are saying both are similar, nahi hai zarurat iska. So beta error. So we have to balance between these two types of error, false negative, based on the severity. In your experiment, alpha error may be more serious, or maybe the beta error may be more serious. It depends. So level of significance and power comes from this level of that types of error. We define in statistics the probability of committing type 1 error will be alpha, which is level of significance, and probability of type 2 error will be beta, which is power. That means 1 minus beta is power. Okay. So probability का definition सबको पता है, just like average, favorable number of outcome divided by total number of outcomes. That is the simple definition. One more definition we use here of probability theorem, that is successful event plus negative events equal to probability of success plus probability of failure will be equal to 1. Right? Probability of success of any event, we are adding probability of success, and probability of failure, that will come to 1. 1, that means koi probability nahi, it's a perfect event already happened. Probability if it is 1, that means the event has already happened. There is no probability of chance. So the same concept we are using. If we are removing that probability of type 1 error from our experiment, we will be confident. Okay? So alpha, if we are removing 1 minus alpha, if we are removing that, what we will get? The confidence. And if we are removing type 2 error, we will be powerful. Our statement inference will be powerful. So we are removing these two types of error from our experiment, and these are having alpha, beta are having kuch sort of standard values. You cannot take beyond this. So it is suggested that alpha is little more serious than the beta. So alpha has to be less than 10% and beta has to be less than 20%, beta error. So alpha is what? It's about, in layman language we say it's a risk. How much risk you are taking in your experiment. You are saying 5% risk I am taking, so I will be 95% sure. If I am taking 10% risk, then your 90% confidence interval will be. I will be 90% confident interval, okay? Then if I am saying 1%, then I will be 99%. But according to this, whatever you are choosing, alpha, beta, your interpretation will change. Your sample size will increase or decrease drastically. Similarly, for alpha power, you can have 80% minimum power you have to have, but you can have 85%, 90%, 95%, whatever. Now, here one thing comes, statistical significance versus clinical significance, because sample size is directly proportional with the, inversely proportional with the p-value. P-value you know, okay. So, the p-value, as you have the p-value significant, you will say I have got the good result, I can publish. But now the shift is different. People are asking with the p-value 95% confidence interval has to be presented. Because the more focus is on the probability, statistical value, clinical significance give the practical importance. Let's say I have done one clinical trial with 1000 patients, okay, in pain reduction. And I have got the p-value change from baseline, it has got the p-value less than 0.001. Statistically significant, I am ready to publish, but effect size, if you are going and saying the reduction rate is 0.5 on the scale of VAS score, is it clinically significant? That you are reducing, by introducing your new therapy, reducing how much pain? 0.5 on the scale of 10. Clinically, it is not significant. So people are aware and they are more focusing with the p-value on the clinical significance, that you have to show the effect size. You have to choose the minimum clinically important difference that you have to reach at least, then only you will be. P-value तो it's notorious, just like average. Average में एक दो outlier घुसा दो, average इधर उधर सरक जाता. Similarly, p-value. If I am doing the clinical trial, I have lots of money. I am doing the clinical trial with the 5,000 subjects. I'll get the p-value significant, but you have to go and check your effect size and 95% confidence interval, how wide it is. So that historical shift is there. P-value to the clinical importance, null hypothesis testing to the patient-centric outcome, statistical detectability to the meaningful benefits. If p-value generally says that if there is any difference, but that any doesn't matter because it has to be important difference. So clinical significance is very important. So this is related to the policy relevance, because clinical difference is having a strong evidence and statistical significance is little weaker, because from the practical point of view. I am skipping this. So any researcher who is sitting and willing to do the clinical trial, you have to ask these 3 questions after completing, then only you should go for the publication or implementation of that particular therapy. Is an observed effect real or should it be attributed to chance? Okay, so this is related with the p-value. So first question will be answered with the p-value. That means it is by chance or it is real. If it is real, then it's okay. Then if the effect is real, then how large it is? Effect size, that I say clinical significance, you have to say effect size. If I am saying 0.1 instead of 0.5, pain reduction is 2, which is okay. But if this effect large enough to be useful, or if I am saying pain reduction is 1 point, is there, it is large enough to should be introduced, so we have to go back and check what is the therapy, how much it is costing, it is cheaper than the previous one, then it's okay, the poor patient can get benefit at least reducing. So number of things are there. If you are answering this question, you are ready to. So main focus is on the size of effect and their practical significance, not the p-value. Being a statistician, I am discouraging using the p-value. So this is a hypothesis, null hypothesis, alternative hypothesis. You can write mathematically one-tailed or two-tailed hypothesis. This is for students, so I'm skipping that, you don't have to worry about. P-value, everyone, pray for this. Less than 0.05 mil jaye, bas, kaam khatam. But I am not saying this concept is 100 years ago now. This slide is older. I have to revise. And R.A. Fisher has introduced this concept, and he is the grandfather, we generally say, of modern statistics. So you know the story of chai. Chai ka time ho raha hai. Chai ka story pata hai? R.A. Fisher ka. Quickly I'll brief a story to lighten you with the heavy session. So R.A. Fisher used to be a scientist in Cambridge University. He was short height man, beard man, and then very arrogant. That means I cannot, being a statistician, did PhD from a small university, I cannot talk to him. He is the sir. And he used to say that everyone has to say sir. In British, you can understand that sir has to be said to give the honor and something. So very arrogant man, but even then he got married. So as usual, he was very introvert. He doesn't want to go for any high tea party or something, but in Cambridge University, there was a high tea function. As usual, all men knows, wife insisted that you have to come with me, and he has to go. And he has gone there, and that is the real story. And he was sitting at the corner and drinking something else, not tea. This is related to the chai ki charcha. So he was sitting at the back. Suddenly something happened and people were arguing and बहुत तेजी से loud noise उसके कान में गया. क्या चल रहा है? So one lady was shouting on the waiter that why you have not prepared the tea properly. So waiter was arguing, I have mixed the tea and milk. What's the matter? She said no, taste matters. And वो सुन के argue हो रहा था, and R.A. Fisher came and then he said, what happened? Then lady shouted on him. She was also a scientist, but he shouted on the arrogant person that you don't know the little thing. Even if you study in this, or you are a scientist in this Cambridge University, he is arguing that the taste doesn't matter. And he also thought that whether I am pouring first milk or whether I am pouring first tea, because you know how they prepare, they have two jars of, one is with the milk, one is with the tea, and they are pouring. And how can the taste be different? And he said, how come? In chemistry also we mix the compound and we get the one, you know, how does it matter? And then lady shouted on the, और फिर वो तो ego पे आना ही था. And then he took it to the ego और वो p value हमारे सामने है, ego का. So ego is also important, see, है ना? So he immediately said, I do want to do this experiment right away. It is 1920. 1920 was the thing. And he sat in the kitchen, asked the waiter to come along, and he was randomizing. He was not aware of that term that time. He was randomizing the cups of tea, sitting in the kitchen, and writing there that which cup has presented, and waiter has to go to present that cup to the lady, and she was tasting, and she has to write the observation, and it is going inside. See, the experiment happened at that time. And you won't believe he has presented around 12 to 15 cups of tea to that lady, and she correctly guesses all the cups of tea. And that was shocking for him, and he said that everything is not by chance. There's something real effect which we see, and he started working. He has given the theory, and from this theory is being used in agriculture experiment for 20 years. There was no clue in using this in the medical field, and later on it is introduced, and we are also using. That is very useful. So find out the by chance factor. It is real or not. That is the story of tea. So these are the common statistical tests which you know. The chi-square is used for the categorical data. As I said that you have to define your each and every information, whether it is age or it is blood pressure or smoking. As per that, your statistical method changes. Let's say, for example, hypertension. Okay, so hypertension is the one thing. If hypertension is categorical, I will use the chi-square test. Okay, if I have to associate it with the smoking, which is also categorical, right? If hypertension, if I am measuring through the blood pressure, it is a continuous variable. Then it will be analyzed with the different factors. So there are 4 decision points by which you can take the decision, types of data, whether it is categorical or continuous. Number of groups you are analyzing, there are 2 groups, there are 3 groups to t-test or ANOVA as you increase the groups. You have to see whether this is a paired data or unpaired data or distribution of the data, whether it is normally distributed or not. So if you have, let's say, binary data, combination of 2 variables is important. If you have both variables which you are analyzing is numeric and numeric, that means total cholesterol versus age, then what will happen? You will end up with the finding out the correlation between these 2. Okay, what you will be able to do? Finding out the correlation between. You will not be able to find out the hypothesis testing because you don't have a categorical variable with comparing between 2 groups. But if you have numeric versus comparator group, let's say treatment and placebo is one comparator categorical group and total cholesterol is numeric variable, then your statistical method will be t-test if total cholesterol is normally distributed. If it is not normally distributed, then it will be Wilcoxon t-test. So these tests now, the era of AI, you will just sort out your information you have to collect and you have to put and they will give the what test. So this you don't have to understand that what test is required. This is for the student to understand because they have to pass the exam. But you get the idea that how clarity you have to have, how much clarity you have to have for your own variable, then only the AI will give you the right answer. If you have both categorical variable, CHD, yes and no, or smoking, let's say you have ordinal variable, then chi-square will be the only option. Similarly, you have to assess the normality for the continuous data. Normally distributed, you can use the transformation if you are thinking that parametric tests are best. Definitely they are best. But you please don't manipulate your data. You have to just check after log normal distribution or something, if it is coming normally distributed, then you can use the parametric test. Otherwise, non-parametric test also can be applied. So how to check the normality? These are the things, and bivariate analysis, you have to see how many categories you are analyzing. Let's say I have 2 groups, okay, placebo and control. Then I can use t-test to compare the groups. If I have more than 2 groups, let's say I have 100 grams treatment group, 150 gram treatment group and placebo or standard care, then I have to use ANOVA. I cannot use t-test. So like that, how many categories are there, that changes the statistical method. Similarly, if you have pair data before, after or independent groups, if you can guess these different ladies, they belongs to the different groups. First is Malala and then Oprah, spiritual leader, then Mercury, है ना, madam, क्या नाम था? And then third is politician, Hillary Clinton. So these are the independent groups, or before, after, that is dependent group. So your pair t-test लगाना है या independent लगाना है, that you have to check. And these are the simple, about the test which you can get from the statistical test. So I think you don't need this. This is for the students, what test you have to use, if it is normally distributed or not. This is for, this is important. You can, if you want, you can take the picture of this. If your quantitative variable is normally distributed, then you will go to the parametric side. If it is not, then you have to see for the categorical variable, how many categories they are there, they are related or not related. Accordingly, you will choose the statistical method. Okay? So this also talks about clinical significance. 500 drug subjects are there, 500 control subjects are there. We have calculated and got the p-value significance 0.011, but statistical significance is there to reduce the temperature, body temperature, but clinical significance is not there because it is just only 0.1 degree Celsius. Now there are some questions for the students. I think I'll not go with this. That you have to guess that which statistical test you have to go for. Okay? Okay, any questions related to the statistical method, data and study designs? So concluding remarks. Good clinical practice is essential component of the good scientific practice. So this is science which we are involving in the clinical practice. It emphasizes principle of good study designs and conduct, involving an experienced statistician. This is my favorite line. At the planning stage of the study can add fresh perspective to your research. Thank you. I'm ready to take one or two questions because we are already running out of time. But thank you everyone. It was very interactive session and I enjoyed that. I hope you too. Thank you. We are in habit of speaking since morning to the evening because statistics cannot be covered in a couple of hours.
Hello, ma'am. Say something about sample size. Sample size के बारे में कोई ऐसा कोई formula है क्या simple सा?
हाँ, simple सा तो formula नहीं है. It's very subjective. It's something like sample size के लिए अगर मैं बोलूँ तो sample size is like if I ask you where you want to go for the vacations. ठीक है? अगर मैंने instant question आपसे पूछा where you want to go for vacations, so you will not be able to instantly answer. Why? If you are married. You will not be able to. ऐसे ही लोग आके पूछते हैं मैडम सैम्पल साइज बता दो अभी खड़े खड़े बता दो कितना हुआ. We will not be able to. हाँ, so continue with this example. You have to collect number of factors before deciding and answering this question. You have to go and first ask your wife, okay, your family members, their preferences, your budget, pocket ही आपको देखना है. Whether we can do the international trip, अभी मोदी जी ने मना किया है, तो वो भी एक factor add हो जाएगा. And then you have to do the, this local visit. Local में भी कितना local, बहुत सारे factors. Similarly, for sample size, you have to collect all the information. So start from the research question. What is your outcome variable? Because you have to have the primary outcome, endpoint, how you are measuring it. Then whether you have number of factors like loss to follow up, prospective study है तो वो rate भी आपको उसमें add on करना पड़ेगा, co-factor analysis है, subgroup analysis है. So based on number of factors when you come, because like in our organization we have process. If you are initiating a clinical trial, one sample size request form is there that you have to fill. Then you will get the idea that you have to do the literature search, expected primary outcome कितना हो सकता है. Non-inferiority margin, you cannot select by your own. What literature is saying, what the regulatory is suggesting. So all information you have to collect and fill that form and then come to us. We are here to change the alpha and beta. As you have seen that alpha, beta, 1%, 5%. So we'll give you number of combination you can select according to your budget. Budget also you have to see. The time point also you have to see how many patients. So it is very subjective, but yes, you will end up with one formula. So there are hundreds of formula, whether you are doing sensitivity analysis, whether you are doing survival analysis. So based on that, you will come up with one formula, but for this particular formula, what information is required to put, that few things we can suggest you, few things you have to bring. So this is collaborative thing. So it depends. मैं सबको बोलती हूँ मुझे जो भी क्वेश्चन का आंसर पूछा मैं पहले उसको बोलती हूँ it depends क्योंकि यहाँ पे सारे फैक्टर्स आ जाते हैं ना. So if you are doing clinical trial, one thing you cannot do, like you have to have the database which has to be logged in a proper way. Okay. you cannot access this, you cannot change anything once it is gone there, okay? So if you have that database, with the data has gone there, you cannot change anything, then anybody can use and analyze, because that change will not be allowed. Database lock has to be, there is a process, everybody has to sign that database is going to lock. So number of things are there. But it's an observational study. If you are using the Excel, you have to be very careful that Excel, original Excel has to be with you. If by any chance some enter happened, somebody has done and that value has gone, that you can match. So there is no data breach until unless the person is having the confidentiality agreement and they are not publishing or releasing it to somewhere else.
In our hospital, we have a regional occupational disease center also, and I'm working in the general medicine department. So if I'm getting some data from RODC or regional occupational disease center, so what is the process?
So that I think administrative, who is the medical director or doctor, who can tell. Every hospital is having that procedure. So you have to write to the ethics committee and take the permission that I am going to take this data, and you have to write the confidentiality agreement. The data you can take out, and you have to specify that this will be used for only the research purpose, not anywhere else. So this documentation process has to be done within the hospital also before getting the data. Yeah. So every hospital is having different policy that you have to understand. Yeah.
Thank you very much, Gayatri ma'am, on this very extensive topic. I'm sure everyone's mind is teeming with questions. They might reach out to you later on your email or phone call, because it is very, very difficult to actually assimilate all this information in one go.
To advertise one more thing, I am associated with the Biostatistics Consortium, which is in Delhi, and the president is Dr. Abhay Indrayan, who is retired from UCMS College of Medicine. And we are just meant for providing these kind of...
And I hope the tea is to your liking. As you mentioned tea in your story, as if on cue it appeared. So I hope you'll like the tea, and we would also like to, ma'am.
कौन सी वीडियो में
सेफ्टी रिपोर्टिंग सेकेंड वन हाँ
प्ले कर दो पेन ड्राइव भी निकालेंगे नहीं F5
इसी पे करना ठीक है. I would like to invite our next speaker, Dr. Anuradha.
More alert. I think coffee is served. Okay, topic for today is the safety reporting. I think yesterday there was a lot of answer was coming out of you, which was not right. Let us see like how many of you have Googled or to look into the answer of AEs and SAEs. Regarding the AE, SAE and the SUSAR. And then what is the timeline of reporting these SAEs and how to calculate the compensation. And even there is SUSAR, it is only applicable to the clinical trials, but still I just want to add a note on it. What is AE? What is AE? Adverse effect. What is SAE? Suspected? SUSAR. You know what is AE, what is SAE? What is SUSAR? Suspected. Serious adverse reactions. Okay, great. And what is AE? Yesterday we heard. Okay, madam, you said something yesterday. Regarding AE, definition of AE. Would like to redefine it? Yes. Yesterday we heard the definition of AE. What is AE? Yeah, what is AE? and what is. Okay, what she said is whatever the side effect or the intervention. Any pharmacologist over here? Okay, right. Okay, anybody would like to totally? Yeah. Okay, all the speakers disagreed. I second them. That. Well, we call it as ADR, right? Because in the clinical terminology, we call it as ADR. Then what is the difference between AE and ADR? We don't use AE normally whenever any reaction happen during your routine, not AE. Because she said it is due to the drug. Okay, she is attributing that factor is due to the drug. So it will become an ADR. There is a slight difference. Okay, what AE is any or not related. Results during the use of a drug, but causal association is not yet established. Let us say like I'm on drug, I'm just driving, somebody and I got admitted. Is it an AE or an ADR? It's just an AE because I have met with an accident, injury has happened, but it has not happened due to the. That is the injury which has happened during the course of medication, but may not be related to the drug per se. That's one example when you said like yesterday, because I gave that example because you told traffic jam something in the car. Okay. Other simple thing is like I'm on the drug. Okay, I'm on the medication. Let us say the simple drug which you take, cetirizine. Usually all of you know cetirizine causes sedation. Okay, but you don't prefer anybody to drive whenever they are on cetirizine, but we prefer levocetirizine, which is like, is it an ADR or AE? Then it could be ADR because the drowsiness, sedation, which has made me and I fell down or hit something. Okay, I am not in the overdose, and it resulting in any adverse event, which there is a causal association, we call it as an adverse drug reactions. Whereas AE may be related, may not be related. Any injury which has happened during the course of medication or during the course of the study. And then they will attribute whether it's an ADR or not. Then what is SAE? What is serious adverse event? What is serious adverse event? Anybody? Yeah, great. It requires, he said like it requires urgent medical intervention. What urgent? Because urgent is a very subjective term, it varies from person to person, and whether you say urgent, whether somebody else, it should define the same factor. Many things require treatment. Yeah, it can be life-threatening. Okay, there are certain criteria to say that serious. Okay, one is, as sir mentioned, life-threatening. Okay, then. Yeah, very good. It can cause some disability. Okay, we don't say chronic. It can cause some disability or any deformity. Okay, then hospitalization, great. Because if there is any reaction which can be treated, for example, just a rashes, which can be treated on the OPD basis, we don't call it as a serious. But if there is an anaphylaxis, patient requires admission, right? That is an SAE. Okay, if it requires any reaction, requires admission, we call it as an hospitalization. Patient is already hospitalized, okay, but requires some extended hospitalization because of the AE, because there can be some electrolyte disturbances. Okay, you want to keep it for some more days. Okay, so extension of hospitalization because of the reaction also considered as an SAEs. Okay, and if the pregnant woman consumes a medication, if there is any fetal abnormalities, would you like to call it as an SAE? Yes, there is a fetal anomaly. Okay, there are some criteria which ensures that an AE can lead to SAEs. That is, if the participants met with succumb to a death, okay, if there is any death due to the administration of medications, or inpatient hospitalization, prolongation of hospitalization, persistent or significant disability, or incapacity, a congenital anomaly, or is otherwise life-threatening, is termed as an SAE. Okay, these are the 4 criteria which can consider the AE into an SAE. Okay. Clear now? The difference between AE, SAE and ADR. And pardon? No, if the patient is already hospitalized, if the AE has happened, because of AE, you want to keep the patient for another extra 2 days. Let us see, like for the typhoid, we admit the patient. He will be there for usually 7 to 14 days or something. But because of any reactions, I would like to extend his hospitalization for another 2 days. That will become an SAE.
Some patient is taking any drug.
Yeah.
After taking the drug, then he has some severe skin rashes or severe skin.
Right. Let us take like Stevens-Johnson syndrome, which is a life-threatening conditions. Definitely. Stevens-Johnson requires isolation as well. It's a life-threatening conditions. It is an SAE. Okay, I told you mild rashes which can be treated on OPD basis will not be considered as an SAE. Anything like type 1, type 2, type 3 hypersensitivity reactions, definitely yes. Type 4 is delayed. We just treat it as an OPD basis. That is not SAEs. Okay, which requires hospitalization, which is life-threatening, all come under SAEs. When you should report SAE? For example, in the clinical trial, if any SAEs happen for the participants during the course of the trial or even in the investigator-initiated trial, do you want to report SAE? And if at all you want to report SAE, whom you want to report? Ethics committee, sponsor, right? DCGA. Okay, you want to report to 3 stakeholders. One is the DCGA who has permitted your study. One is the ethics committee who will oversee your study. And to the sponsor, definitely who is the one who is the funder, who will take care of all your needs. And because he is the one who is also responsible for giving the compensation. Pharmacovigilance, I'll come to that later. Okay, pharmacovigilance, we do it for the post-marketing surveillance. Okay, for the post-marketing surveillance, once the drug is approved. Once the drug is approved, we do the pharmacovigilance. So it's very clear. We have to report to the 3 stakeholders. And when we have to report? Within 24 hours. Within 24 hours from the occurrence of an SAE? Or when? For example, like patient had an SAE, but he came to the hospital today. And as a PI, like you came to know today itself. But the SAE has happened yesterday. When do you want to report? But 24 hours is already gone. Pardon? It's a valid doubt. Usually people do ask. Not 14 days. 24 hours, sir is rightly said. From the awareness, from the knowledge of occurrence. Because you came to know today. From the time you came to know, from that time your clock ticks. Okay? Because you are not responsible. Because patient should have called you. From the time if, for example, he rang up to you yesterday, from that time clock clicks. Okay? Means like from the time you are aware from the knowledge of occurrence of the ADR. Because earlier days, as per the NDCT rules, from the knowledge of occurrence. Earlier it was from the time of occurrence of the SAE, which has been changed. Because patient, if they report today, we are not held responsible for that. Okay, PI is not held responsible because he was not aware of it. And we cannot make the patient like your fault in reporting and all. Because even they were unaware of certain, they are ignorant about it. Okay, from the knowledge of occurrence of the ADR, from the time they came to know, from that time, like within 24 hours, they had to report to these 3 stakeholders. DCGA, ethics committee, and the sponsor. Clear? And then, that is the initial report. After initial report, can you keep it, or you want to report something else about the SAE? That is the initial report a patient would have admitted immediately, so and so has happened. Like it has been reported. You wanted to monitor the patient? You want to submit some more details to the ethics committee or these stakeholders, or you just want to keep it? I want to know what is the outcome of this SAE, correct? Because initially something would have happened. It can lead to the death later on, or it can be recovered later on, or still it can be recovering, or it can lead to some of the deformity. Anything could have happened. So the detailed report of the SAE should be submitted to the another 3 stakeholders. One is the ethics committee is mandatory, and again the sponsor, and also to the head of the institution. Because you are taking the infrastructure, they should also be aware of it, but the confidentiality will be maintained. Within how many days? That madam said that time, 14 days. The detailed report should be sent within 14 days. Okay, this is the initial SAE. Investigator and the sponsor. See, here, all these things, in case of clinical trials, we have to upload to the Sugam portal in the CDSEO. There's no hard copy communication, email communication, it should be. And the initial reporting will be done by the investigator to the 3 stakeholders within 24 hours. Afterwards, the detailed report should be submitted separately by the investigator as well as by the sponsor. Sponsor also will be tracking you, and he can give his relatedness or the non-relatedness and should submit separately in the Sugam portal within 14 days. Within 14 days, but who usually communicate with the EC? Sponsor or the investigator? Who is the point of contact for any study with the EC? No, for the ethics committee, who is the point of contact? Investigator. Okay, because I think somebody mentioned already, sponsor should never communicate with ethics committee directly. We all detailed report within how many days? 14 days to the EC, ethics committee, and the regulatory body DCGA, and also to the head of the institution there. Very important. Even if you miss 1 day or 1 minute, you should be answerable. And then what is the role of ethics committee? Ethics committee should conduct a full board meeting and then discuss the SAE, and we call the PA to discuss and ask regarding whatever the event has happened, and should do the causality assessment. After doing the causality assessment, should upload the opinion of the ethics committee to the regulatory authorities. We have to upload it. We have to give an opinion letter to the PA as well, and we have to upload this opinion to the licensing authority, that is DCGI, within 30 days of the occurrence of the SAE. Within 30 days, we have to schedule a meeting. They will have their committee, they will discuss, and they will pass the order within 90 days. And once they receive the order, whether they can go with the EC opinion or they can change their opinion by their committee deadline for the SAEs, for the CT related. Any doubt regarding this? This is for all the clinical trial related SAEs. Okay, now the question is, for example, if you are doing the and who will pay for you and whom you want to notify. Just because I think because you are all doing the academic studies, very few will be doing the CT because you don't have sponsor here. Some may be funded. Yeah, you want to report or not? You have to report. Are you reporting? No, but please make it. You receive the approval letter, you would have had one sentence, any AEs, SAEs should be reported. You should report. The same timeline holds good even for the academic studies, but since you don't have a sponsor here, you should report to the ethics committee there. The head of the institution there, the 14 days report, may need to provide the standard of care and also to oversee or monitor the SAEs, what has happened. Okay, it's always good to report. Okay, if this is observation study, we don't, because it is a standard of care. Sometimes you would have started with the investigator-initiated study, which is one of its kind, which is not yet approved insurance. Because EC will look into all the things, whether you have a corpus fund or you have an insurance for this study. That's why they insist for those things where the risk is involved. Okay, for the benefit analysis, we categorize into 4 categories: less than minimal, minimal, low risk, high risk. For the high risk, we always insist for the insurance. For the less than minimal risk or the minimal risk, we don't. We know it's just a routine observation studies. For the insurance are some things. What is the benefit for them? We don't have any connection with the insurance company. It is always, we ask, in the interest of patient. Our primary importance is to protect the safety of the patients. Okay? Hope you are clear with the timelines now. Now I asked one more definition, SUSAR. What is this SUSAR? SUSAR, as you know, it's an unexpected. Means that is not expected, there is no literature for that. Okay? And it's a serious, the definition holds good the same. A serious adverse reaction with at least a reasonable possibility of causal relation, because you can anticipate this could likely to occur with your experience, because there is no literature or there is no actual reason for it. Many times we say it is most likely due to reason not clearly known. Even we say the idiopathic reactions. What is idiopathic reactions? Where the mechanism is unknown, why it is causing, but we know like many ADR would have happened because of the drug. For example, like thiazides causing erectile dysfunction. We don't know why it is causing. Then we avoid it in the young adults, right? Similarly, like there are so many idiopathic reasons could have happened. That is at least a reasonable possibility of causal relation to the investigation product that is also unexpected related to the reference safety information. Means whatever the reactions, whatever the anticipated reaction which is not there in the IB, that is investigation brochure, or in the product label, which you come across, which is very serious in nature, goes in favor of this SUSAR. Okay? And there are 3 criteria. It is seriousness, that is meeting the SAE criteria, which I have already told you the criteria for the SAE. And suspected causality, there should be a causal association from the administration of the drug and the development of the event. And then there is unexpected, it should not be there in any literature. These 3 criteria goes in favor of SUSAR. Okay, this is mainly for the CT related trials, not for the academic studies. Okay, in contrast that any SAE which is expected, which you know, it's there in the literature, or if it is not related to the drug, which after the discussions, after the expertise opinion, it is not going in favor of the SUSAR. We don't call it as a SUSAR. Clear? That is the difference between the SUSAR, AE and SAE. Okay, this we use it for the mainly the CT, for the global studies. When the SUSAR should be reported, it is very important because they trigger some of the unexpected event to the drug, and it should be reported within 7 days if it is fatal or life-threatening, or else it should be reported within 15 days from the occurrence of the SUSARs. Okay, because usually they miss out because it is not going in favor of it. The timeline for reporting the SUSAR is different. Okay, it's not related to the academic again, it's only for the clinical trials. SAE is a known event. SAE is any adverse event suspected. Suspected. You will just report it.
But any event which is serious has to be reported and should be decided by the...
Yeah, that's why. That will be decided. Sometimes they will not report it because they say it is not. It has to be reported. Sometimes it is go unexpected, it is not related to it and all. Then we can categorize as SUSAR also. Even the ethics committee can SUSAR. And in the NDCT rules, we don't mention about SUSAR. It's there in the other international studies, but no, ethics committee will not decide SUSAR because it's not there in the Indian guidelines. It's in the global scenario, SUSAR, because since they have given the definition as, okay, it's an international guidelines, but it's not there. In the NDCT guidelines, only AE and SAE is there. It's very clear because any adverse event, please report it. We'll define it as an AE or an SAEs, and it will be very clarified. Yes, yes, okay. Because there is some terms for the industry, they will report it, that is called SUSAR, that just I gave the definitions. But you can just forget it also.
Can the decision of ethics committee be challenged? Because say ethics committee say that it is unrelated SAE. So can it be challenged by somewhere else?
Somewhere else? No, no. If it is unrelated, we submit that report to the DCGA. DCGA can change it to related. Only person who can change your decision of the ethics committee is the DCGA. Because I might say it is related, DCJ can say with their committee decision unrelated. Sometimes I say not related, they can say it is related. I will say it is not related, then the compulsion may not arise. Okay, but DCJ say, oh, it is related, compulsion is required.
Then can the same be challenged in the court of law?
No, no, no. DCJ is the ultimate authority.
Sir, the DCGI has its own committee. Once the ethics committee submits their report at 30 days that they're supposed to, their timeline that Madam showed, they form their own
60.
committee to decide that. And they take their own time and they are the final authority who decide.
Yeah. It cannot be challenged in the...
Same decision be challenged in the court?
What he's telling is decision of the DCJ cannot be challenged.
The challenge that depends upon the participant. That will be a case that has
Never, because in the last 2 decades, whatever I have come across in this field, they have made the relatedness not relatedness. Many times.
ethics committee give their opinion about the and their causality, but final call is always taken by the DCJ.
Like we are doing as a pharmaceutical company, we are doing present separate tables for AE, separate tables for SAE, separate tables for TEAE, that means treatment emergent adverse event. So that is required. TEAE categories we. Yeah.
Usually we don't also so far, because the compensation is not very, very much unless there is a death.
The basic question is, can the decision of ethics committee be challenged to court of law?
I don't know, we have never come across it. It can be, it can be. But
Sir, theoretically, yes, it can be.
He can do it.
Yes, theoretically, yes, it can be challenged. It can be challenged because the stakeholder has different responsibility. Let's say a ethics committee has decided basis on something, and that's primarily related to participants' well-being, safety, and rights. Whereas if you have a medical situation where the PI feels that this could be like that, and it's submitted to GCGI, and they have their own expert panel on that, but if you still feel, then you can definitely challenge. It is not closed matter. It is like
Yeah.
everybody, every information is evolving. In fact, in many of the studies that I take part in, if you are submitting to international, mostly we don't have to even submit separately. But if you are submitting primarily to Indian regulatory body and they give you an order which you do not agree with or there are challenges, you definitely can challenge. You can represent. It's not called actually challenge. You can represent and take their submission.
Okay, now moving on to the guidelines, like how the compensation will be calculated based on the NDCT rules, which is released on 19th March 2019. The compensation is related on based on these two categories. One is the clinical trial related death, another is clinical trial related injury or the essays, which is other than the death. One is, there are major issues like while calculating the compensation. Till 2013, even the ethics committee didn't know how to calculate it. Because it was like, one ethics committee decides, no, we should give this much of compensation, the other ethics committee, but there was no actual formula per se. But in 2013, there was a notification by the DCGA which made our life easier, because we should have some guidelines to say. Otherwise, simply somebody say 10,000, somebody say 4 lakhs per day, something. We don't have guidelines. And then afterwards, 2013, our life is a little easier. We used to follow the guidelines. And same thing has been incorporated in the NDCT rule as well. Now it is a law. And the government of India has regulated, as per the notification, as I mentioned. And the assessment of all these SAEs will be done on certain criteria, which is mentioned in the table 5 of the NDCT rules. And what are those criteria on which the ethics committee will do the assessment of these SAEs? First is, we'll find out like whether the adverse effect is related to the investigation product or not. Any clinical trial procedure involved in the study, it is as per the protocol or not. Is there any violation of the protocol? Or is there any scientific misconduct or negligence by the sponsor or investigator? We should answer all these questions while doing the causality assessment. And same thing has to be submitted even to the DCGA with our opinion. Failure of investigation product to provide therapeutic effect. For example, in case of any controlled subjects, for example, if somebody is on placebo, we cannot attribute directly that is related to the drug also. That has to be mentioned clearly. Because if there is any SAE in the placebo group, after they unblind it, it will become unrelated to the drug. Then use of placebo in a placebo controlled trial. Then adverse effect due to concomitant medication excluding the standard of care, necessitated as a part of this approved protocol. And then any injury to the child in vitro because of participant of parent in the clinical trial. We have to answer all these questions. We do the causality assessment. Then finally, we have to give an inference opinion whether the event is related to the drug or not. If it is related, then it will amount to the compensation. If it is not related, we say not related, then the patient is not liable for any compensation for this event. And how do we give a compensation? Definitely in the form of money. And what we need to do, I said there is a formula to calculate. And do we cover for the medical management during the course of their admission? Okay? Of course, yes, that is called as medical management to be borne by the sponsors. And there is catch over here, like in case if it is not related to the drug, NDCT rules has mentioned that it need not cover. If it is not related to the drug per se, then medical management need not be covered by the sponsorer. But sometimes some of the ethics committee insist as a humanity to pay for it. If the patient is very poor and the bill is around like 40,000, 50,000, if their socioeconomic status is very low, you can, as ethics committee, you can insist or you can request for the sponsors to pay through PI. Okay, and they do pay it because they are your subjects. We should respect the patient as well. Okay, sometimes they will be having insurance. That time it will be covered. Otherwise, medical management to be taken care of, that responsibility lies with the ethics committee. And the financial composition will be whom to give this financial composition? That is another question. In case of death, everybody will come there. I am very close to this person, etc. Right? In case of death of any person, the nominee, it will go in favor of the nominee, which is mentioned at the time of their enrollment. If they have 3 children, at the time of enrollment, which child was there with him and whose details was there, only it will go to that person. It will not be shared with anybody. And along we have to take the Aadhaar card, everything of that nominee as well. Okay? It is at the time of enrollment. It is in case of participant trial related injury, it will go to the participant itself. In case of death, it will go to the nominee. In case of nominee, in case of death. In case of child injured in vitro, it will go into the account of the child till the child is alive. Nominees would be entitled for the financial compensation. And who should bond all this? Sponsorer. And sponsorer, why sponsor will take it? Because during the clinical trial agreement, okay, sponsor would have taken the undertaking that all the SAEs, related issues, all the compensation will be borne by the sponsor. And even you should check for the insurance, which will cover for the compensation as well. And in case of sponsor fails to compensate, then DCGA will give a show cause notice to them. Okay, and the timeline I mentioned, within 30 days of the issuance of the DCGA letter, they have to give the compensation. Again, once they issue the compensation to whoever is, whether to the nominee or to the participants, that notification should be sent by the PI to the ethics committee with an evidence, with a check, whatever they have given, everything. They should notify to the ethics committee, and then we'll close it. Okay, this is closed. And for the CT related death, this is the formula which is used. That is B into F into R divided by 99.37. B stands for base amount, which amounts to 8 lakhs. And F is the factor depending on the age of the subject based on the Workmen Compensation Act. And R is a risk factor depending upon the seriousness and the severity of the disease. For example, if the study is done in the healthy volunteer, what is the risk factor involved? It's very less. So it will be less, 0.5. If the risk factor is low, the compensation involved is more. If the risk factor is, the person is having multiple comorbidity, his risk factor, okay? And how do we calculate for the F? These are the 3 factors which we should calculate. This is the F. Okay, it is there again in the NDCT rules. For each age, there decreases. It is inversely proportional because it is compensation is higher in the younger age group, lesser in the as the age progresses. The risk is if terminally ill patients, the risk is 0.5. If it is a healthy volunteer, it is 4. The compensation is more in the young and the very less risk. What would be the maximum compensation which can be given? It's amount to around like 70 to 80 lakhs in the very young volunteers, maximum, not beyond that. But in an individual, if the disability is 100%, the compensation is almost 80%, which is amount to the death. 80% of the compensation of death. And again, the quantity is the quantum of composition in case if the death would have happened. And D is percentage of disability. It can be 80% or the 20%, that will be multiplied into 90 divided by 100 and 100. 80% of that of the death compensation. If it is 90% deformity like that. And if there is any congenital anomaly or the birth defect, for example, like a stillbirth or an early death, or in case of no death but deformity, which can be corrected through the medical management or the appropriate interventions, or in case of like mental disability or the physical, these conditions, for the stillbirth and the fetal death or the early death of the fetus, here the compensation is half the amount of the SAE related to the death. That is approximately 4 lakhs. Okay, baseline is how much? 8 lakhs. It is half the amount of the baseline. And if there is no death but deformity which can be corrected through some appropriate intervention, maybe the child requests medical management, whole medical management to be taken care by the sponsor as long as the child is alive. Okay, along with the compensation of 4 lakhs. 4 lakhs plus medical management till the child is alive. Whether it can be 20 years, 30 years, 50 years, should be taken care by the sponsor, along with the base amount. And if there is SAE causing life-threatening disease, the formula which we use it for it is 2 into W into N to calculate the compensation. What is N is number of days for which the trial subjects or the participants remain under life-threatening situations requiring medical care irrespective of number of days of hospitalization. Okay, number of days the person requires a care, that number, and divided by, because during that SAEs or life-threatening condition, he would have missed his work, right? We had to compensate for his work. So that compensation is W is equal to minimum wage per day of the unskilled worker. Even the person is at the higher post of the class 1 officer, but same thing will be given. The wages of the unskilled worker in Delhi, it keeps changing. We have to go with the latest, the act. Okay, it is latest is I think 2025 April, because which we recently calculated for the recent SAEs. Okay, every year it will get updated. It keeps increasing by few hundreds. Okay, that needs to be considered, along with the number of days which they have suffered this event. That will be calculated. Usually it comes around to like in thousands, 10,000, yeah, 17,000, 20,000. Depends, because sometimes number of hospitalization will be like 15 days, 20 days, not more than 30 days like that. And if it is reversible SAE, which is already reversed, and the patient is admitted only for 2 days or 1 day, then we calculate with the same formulas, only the number of days will vary here. Okay? This can be sometimes even 2,000, 5,000, etc. Along with the medical management, if it is related. Medical management should be given, that hospitalization charge, everything. Along with that, we have to give this amount to the participant. Okay? That is given only at the end of the decision of the DCGA, not at the time of hospitalization. At the time of hospitalization, usually the credit bill will be made by the clinical research team towards the hospitalizations. In case if the patient has paid it somewhere else, okay, that can be reimbursed. What are the limitations of these compensations? Well, one of the most important limitation I told you, like if the patient is in the placebo group, we cannot attribute it to the drug at all, because placebo, it is an inactive drug, which is not likely to cause any serious adverse reactions. So that is one of the limitations. The failure of medicinal products to have its intended effect or to have provided any other benefit to the patients. Injury caused by other license. For example, the patient is on multiple drugs. Okay, you attribute that ADR. Usually it happens in case of chemotherapeutic drug in oncology cases. You know that all the chemotherapy drug in the oncology likely to cause some other adverse events. If you attribute that this SAE is not likely to this drug, but is drug which is already approved in the market, then the patient is not liable for compensation. Okay? That is one of the limitations. It might cause also, but sometimes it is more likely to the paclitaxel also, but still this also is causing peripheral neuropathy. That is another, because in the other questions we said like any other drug which is likely to cause this similar adverse event. The possibility of this new drug which is causing the SAE is going to be reduced. That is one of the limitations of this compensation. And patient receiving placebo, which is unlikely to have any benefit or likely unlikely to cause any SAEs, will not be liable for this compensation. No compensation should be paid to the extent that the injury has arisen through a significant departure from the agreed protocol. If some of the participants, if they have breached the protocol, if they violated the protocol, then they are not again liable for the compensation. They breached on their own protocol. They had to be protocol compliant. Then only they are eligible for this. Through the wrongful act or default of the third party, including a doctor's failures. If it is the mistake of the doctor, still it is not liable. Neither it should happen from the patient's participant side, not from the doctor's side. Then we say like doctor have violated the protocol. And deal adequately with an adverse drug reactions and through any negligence by the participant itself. To summarize, you should know what is AE, what is SAE, what is user. Hope you are aware of these differences. And when do we require compensation? Only after doing the causality assessment if it is related to the drug, and when the medical management is required, and who should pay it, and what are the timelines for reporting of the SAEs, and what is the formula to calculate the compensation, and who should do all these calculations. It should be by the ethics committee, not by the PI, but the communication will send to the PI as well. Okay, ethics committee should do it, and then the report should be submitted to the DCGA, and ultimate decision will be taken by the DCGA. So, thank you. PI. That we should decide. Because sponsor might ask. That we see, even the clinical trial agreement will go through that. That time everything will pop up, sir. Then we'll ask the legal advisors only. Because we are not good in that. Because, it's a PA decision. PA decision. Because if you are doing a study in your institution, you should get admitted here. No. Patient cannot decide where he wants to go. See, if he has agreed to be a participant in your institution, he should be here first. He is not. No, but he has agreed, in the beginning itself, sir, when he is enrolling for your study. Just because of that only he has enrolled here, in your institution. He should be withdrawn because he cannot decide like I'll go here and no. Ends there. Yeah, it is in the for example, let us say if the study is conducted in my institution, preferably should come there. But meantime, like he has gone somewhere else to the other place. He had some essay. He can admit there for the emergency condition. But he cannot decide here. No. Oh, acha, private है, government है, nahi. He cannot decide. As a PA, you should decide. Yeah, you should withdraw.
You asked a question before this if the PI does something wrong. So there are insurance policies that covers the PI's
Indemnity.
at the part of the PI. It's called
Indemnity. That's
so
it.
when you buy a clinical trial policy, insurance policy for this clinical trial liability insurance insurance, so you can actually get the clause added.
Yeah, it's there. Usually we check for that also. Yeah. No, we should check. Like, usually it's there. We always check it because that was a query initially. And in our ethics committee, we have a law secretary there. He insisted that even I didn't know how to read the legal terminologies. It's all jargons like some rule 46 or something and another rules are there. It is there. Indemnity will be covered. Ethics committee.
And who will compensate, HOI or
EC will not compensate. EC will not decide who HOI, like I said, like in the beginning, if the study is likely to have a low risk or the high risk, EC will insist you to go for insurance or will ask the letter from the HOA saying that is there any corpus amount in your institution to cover for it. Then only will allow, EC should allow to conduct the study. Otherwise, if there is no backup there, otherwise then PA's responsibility. And it is also like you don't want to do the study, but they're telling you to do the study. It will become a vulnerable population for you, na? So there should be a backup for you in the form of insurance or the corpus amount. Pardon? Yeah, yes, it's same for. I think ma'am can say because she's involved in the device. Yes. Yeah, we for the drug trials, we always followed NDCT rules. Okay, for the device, there is a MDR, Medical Device Rules 2017. Like investigator initiated studies. Okay, right. Yes. You have to take an insurance. Because you must have heard of the processes by Johnson, na? And then you know how much they shell out for all the participants in the US, though nobody claimed in India. Yeah, highest. So you should take an insurance. It's better. Because anytime they can sue you.
Implantation of a new polymer ball. We did 100 cases, and many such trials are ongoing in many hospitals. So my job is to only implant a ball.
Yeah.
Kind of, but
No. Kind of. Yes or no? Yes or no? No. Then
am I legally responsible?
no.
Suppose I implanted the ball.
Then who is doing the study? Who is doing the study? Yeah, you are the stakeholder. No, you are part of the study. Ah. Have you taken the approval from the ethics committee? No, then. But yeah, okay, I understood totally. So you are giving the data to the sponsorer. Yeah, but actually it's illegal. I'll tell you, it's totally illegal. And because lot of things nowadays, the DCJ is not agreeing. They told again go back to the whatever the places, get the even we are getting the trials, we are rejecting it unless they are having an insurance coverage. And they are also telling that we are using this whatever the process is, whatever the devices, it's routinely done. Chalo, it is routinely done, it's off label. No. That is wrong. That is wrong. No, no, no. That is sponsor is misusing you. Sponsor is misusing you. Ma'am, ma'am, they're not taking any consent, nothing. Just like that, they'll give the data. They say it is a routine one, they'll give. Consent as a root. No, no, no. It's a
Just submit, it is absolutely illegal.
yeah.
You are receiving the vial on without any on the record, without getting it on the recorded. Number one, you are not getting it signed by the consent signed by the patient that you are putting an implant without his knowledge, and that or the board, the institution is also not knowing, ethics committee is also not knowing, and you are transferring the data to the person through whom you are also not knowing. Absolutely illegal.
Sir, that
How can you sign, get a consent?
consent should have been approved.
Getting the ethics committee involved and the institution head involved.
That's actually one thing I tell you, that is not a study. that is just an illegal one. Please don't get involved in such things. Because even if you give the data that's waste, why I tell you, they might cook up some, when they submit to the DCJ will ask for the ethics committee approval and we will receive the things. We say nothing has happened with, under our notice, like it's not under our purview. And finally we will be held responsible. Yes. And also the ethics committee. And also the ethics committee is a must. The whatever the local ethics committee where you're working is a must. Yeah. Yes, yes. Yeah, 23. See, usually we ask for 3 forms there. One is MD13 for the import of license, MD23 for the test for clinical trials and all. All these documents will be asked, which is given by the DCGA, then only will allow you. Even EC will ask multiple documents. And you are telling like it's like off-label, it's not permittable. Yeah, thank you.
Can the sponsor quote his name or his site that this 100 devices have been placed at J.L.N Medical College Ajmer and found results? He can also not quote that because you are not giving.
He cannot quote.
I would.
If they are not quoting that, how can they publish it and how can they get it licensed?
Sir, they don't put the name of the institute. They only say 100 devices, 200 devices, 300 devices. It is happening.
It is not possible. They have to give something in record, on record, that where the 100 devices will be placed.
No, it used to happen earlier, okay? But the device rules has come in 2017. After that, it is little stringent. It's very stringent regulation. Before 2017, it was not there. Jan 2017 onwards, the device rule holds good. You cannot be indulged in any of these activities.
I just want to.
It's there in the net, just medical device rule. Go to CDSA website. CDSA website is there. Just Google it, medical device rules 2017, you will get it now.
Ma'am, if I can intervene just once. I think it is because of these practices only that we have organized this GCP, GCLP.
Yeah, I'm happy that at least you are getting aware of it because
workshop.
You will be in the soup. Yeah, because many times we thought, okay, it will be helpful for the patients, poor patients and all. We'll get into the unnecessary trouble. Okay, it is actually, you will be thinking in patient interest, but it's not like, you should also think legally whether I'm doing the right thing or not.
Sorry to intervene again, the entire evolution of bioethics is because of all these kinds of practices from Helsinki's declaration to ICH to our NDCT rules and everything.
I think 10 or 12 years ago, something happened with the clinical trial, and after that, we lose lots of integrity, and people were not coming to India. And we have gained again
like
that
3-4 years, they said like in the newspaper, they said they used to use the people as a guinea pigs, psychiatric patients, especially.
So we have gained
like 3-4
we
years
have paid very much
patients.
cost, and now we are gaining again the. We have built up images of doing good clinical trials, so it is not recommended.
Awareness among the clinicians, among the researchers, as well as among the participants. Many times I have seen people approach us, is there any trials going on in this condition? Because they cannot able to pay for some of the cancer therapies and they want to enroll and with proper knowledge. Okay, we should tell them everything, the pros and cons.
Name?
Yeah.
This is not related to research.
It's okay.
Routinely, जैसे daily routine में hospitals में adverse drug reactions होती है, उनको report करने का कोई.
Yeah, for any routine adverse reaction, you should report to the Department of Pharmacology, usually runs the pharmacovigilance. Okay, that has to be reported. And that will go to the PVPI, that is Pharmacovigilance Program of India, which runs under IPC. Again, if there is, there also they do the collation of all the data and they raise a signal. New signals can be raised. Like most, it's a mandate. And like most of the drugs, after approving for 5 years, 10 years, it has been withdrawn from the market. How it is withdrawn? Based on the pharmacovigilance. Please report to the pharmacovigilance center in your college. And it is mandatory by NMC that every college has it.
Private practitioners are reporting.
Pardon?
Private
can't? Huh? Yeah, private, yeah, private practitioner can report to the nearby medical colleges. Usually in Bangalore, whatever in the North Bangalore, all will report to me. Even the so many private hospitals, because now even the NABH insists for the pharmacovigilance center. They can't run it because it's very difficult. They get one report in 2 months or something. They can have an MOU with them. They report to us. Okay, and even we ask for a couple of documents for them, their evidence, everything. We'll look into that and we'll upload it. They will show that to the NABH that we have tagged with such a college for reporting process. It is always good to report whatever it is there. Mainly for that, we want actual data.
It is very simple. You can report online. You have to just give
Yeah.
the name of the drug, what adverse reaction you have found out, and that's all.
Yeah, once you report online, for example, let us say from the Ajmer you are reporting to online. Again, the PVPA will contact the coordinator of Ajmer. Okay, they say, I got a report from this so-and-so person. They'll give your number also to us, like whoever is there. They have to communicate with you. See, I got a call from somebody from the other part of the Bangalore. They reported for the inhalation device. He reported very clearly, customer reporting. Okay, he reported because device was not functioning, it was broken. He took all the photograph and through customer report he wrote. And he was staying like 20-30 kilometers away from my place. But I had to reach out to him either through the WhatsApp call, video call and all. I got all the information, confirm it, what has happened and all. And I had to communicate again back to the PVPI.
In academic research, something related to the effect of any drug or comparison between two drugs. So if I see in the institution has been provided the approval letter, then any other regulatory bodies we have to inform or
No. If those two, whatever the drug which is there, it's already approved. And you just want to compare, it. Then you need not report to anybody, ethics committee permission is sufficient. It's already approved drug, you just wanted to see like how these two drugs compare each other with respect to the efficacy, safety or anything is considered.
that drug is not FDA approved, then
No, we don't consider, it's only again, we don't bother about FTI, we are DCGI. We always consider DCGI approved or not. If it is DCGI approved, go ahead as a academic studies. It's like just an observation study as a standard of care.
Query for that. Say, for example, I want to use paracetamol. It's a very well-known drug. But I want to use a different indication. Say, but I want to use paracetamol in treatment of diabetes.
Yeah.
Should I have to go to a DCJ or can only...
No, you did not go to the DCGI there. It is an investigator-initiated studies. It is for the new indication. For any academic studies, with your experience, you want to study the, I'm telling you, X drug in the diabetes, let us say. You need not go to the DCGI. You can do it as an academic study and with your experience, because you know paracetamol is a very safe drug. Ethics committee, you need to take a permission or approval from the ethics committee and go ahead with it. That's it.
What you need to know the here is that you cannot go above the dose that is actually
maximum
approved
dose.
by the DCGI. And secondly, this data that you are generating out of it can never be used to change the label of paracetamol.
Yeah, means
if you intend to change the label, if I'm a pharmaceutical company and I want to change the label that I want to indicate that this drug can be used somewhere else, then I will have to go to DCGI before the study, before I generate this data. And if I want to go a dose higher than what is already the maximum tolerated dose established, then I'll have to go to DCGI.
I'll just tell you, we take a declaration usually from the ethics committee that I'm not going to share any data to the company. I'll not allow you to share any of your data to the paracetamol company, because once you share the data, it will become an obligation. As madam told, like product label, they want to change all those things. We take a declaration. It is only for your study, academic study, just for your publication. After looking into your publication, the company wanted to do a study. Then they can come through the regulatory channel. That is the one.
I will not directly share this data to the
No. You should never give. Yes, you can definitely publish it. You can publish it. That declaration, usually we take it in our ethics committee, because there should not be any relationship with you or the company which is giving the free medication or something like that. Okay, thank you.
Thank you very much, Anuradha ma'am, for a wonderful interactive session.
To multiple clinical trials and device validation studies. Dr. Gunjan is Scientist D at the Indian Council of Medical Research. Completed MBBS from Maulana Azad Medical College and MD from Lady Hardinge Medical College, New Delhi. Worked as senior resident in Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMER, Puducherry. Actively involved in teaching and fielding training for MBBS, MD, and MPH students, organizing research in methodology and clinical trial workshops and webinars. Coordinated major COVID-19 studies, including the PLACID trial and National Clinical Registry for COVID-19. Worked with University of Oxford on the recovery trial as an investigator from India. Published over 50 papers in national and international peer-reviewed journals. Special interests include clinical and community trials and early phase clinical trials.
Thank you. So yeah, I think the most difficult session before lunch. Everybody is eagerly waiting for that. Okay, so unlike the other two sessions that we've had, I think they were a lot more technical. I will talk about integrity. And you know, integrity is something that is not that we can learn in a classroom. It is something that we need to imbibe while we are working, right? So, but still today we will talk about integrity and integrity starting from the very beginning, not only towards the end of the research. I think when we are in medical college and we are doing research, you know, all the integrity problems arise only when we are either analyzing our results or when we are publishing our results. You know, and before that, nobody really looks on what is going wrong. Was it, you know, written well? Was it done correctly or not? So we will talk about integrity from the very beginning, right? So, you know, before we start, can somebody say what is integrity actually? Anybody? What does integrity mean to you? I think that's the most common answer, doing the right thing. And I think integrity is defined something like that, you know, you can be confident or you can be confident that this person is, if you say they have integrity, they'll be honest, they'll do the work honestly. And as clinicians, I think most of you are practicing clinicians. When a patient comes to us in a hospital, I think they trust us, right? That we will give them the correct treatment. They're coming to us trusting their lives. Similarly, when you do research and you do a clinical trial, you enroll somebody in a clinical trial, although we understand that, you know, when we are doing a clinical trial, there has to be some form of uncertainty that this new treatment works or not. But the participant who still gets enrolled, he trusts you with his life there, right? He will want to know that nothing wrong will happen to me. So, you know, trust is a very big thing. Even the policy makers, when they come to you for the data, they trust that, you know, this data is correct. Because based on this, they will make policies. They will, you know, the whole national health programs are based on the data that we are accumulating via research. So, yeah, this trust, I think, is a very big thing here. And the whole integrity in science is based on trust. So our ICMR National Ethical Guidelines for Biomedical Research very clearly says the credibility of clinical research depends on not just what we discover, but it also depends upon how we have discovered that. Okay. And if the science is not correct, if it is not practiced correctly, there are broadly three things that go wrong. First is patient harm, which is, I think, the most serious issue. Anything wrong happening to a participant, to a patient, or to any human being is the, I think, fundamentally wrong thing that can happen. So flawed trials, you know, if the results are flawed and they actually say that, you know, drug X is better than drug Y, we start giving drug X to everybody. That actually, and what if drug X doesn't work because the analysis was not done correctly, because the patients were not enrolled properly, because the data was not collected properly? You actually, if treatments come to market, right? The second is, of course, wasted resources. You all know, research takes a very long input, your time, and taxpayers' money. Doing research is a very costly affair. I think if anybody's from pharma company here, they will agree. And it takes a lot of money, a lot of training, a lot of time to conduct research, and that all goes to waste if it is not done correctly. And third, of course, erosion of trust, as I said. If once a trust is lost in a doctor, in a hospital, in a company, I don't think you ever go back to them, right? If you don't trust a doctor, you don't go to him. I think that's true for us even being doctors. If we think that this doctor is not practicing ethically, I would not go back to that same doctor. So for the integrity, conducting research with integrity, this is broadly some frameworks that are available to us, and I think they all in itself, they are separate full day sessions, I would say. So I will just take you through what these regulatory and ethical frameworks are. E6R3 now, which actually focuses on primarily on protection of human participants, and secondly on data integrity and traceability. It also clearly defines what are the sponsor and investigator responsibilities and what are the essential records that need to be maintained in any clinical trial. Now the updated this, I think R3, E6 R3 version, it also talks about modernized clinical trials, decentralized clinical trials, along with how technology-enabled clinical trials are to be undertaken. About the laboratories that are supporting clinical trials. So they talk about their SOPs and quality checks, the calibration of the equipments and maintenance, what is the chain of custody of the specimens, even that has to be maintained, and what are the proficiency testing requirements for the laboratories that are actually supporting the clinical trials. Then we have the National Ethical Guidelines for Biomedical Research from ICMR that came out in 2017, which talk about the core principles of ethics, which are autonomy, beneficence, non-maleficence, and justice. I think you've already had a session on that yesterday. And then they also talk about vulnerability, risk assessment, informed consent, community engagement, and some special populations. In 2023, ICMR also came up with ICMR Research Integrity and Publication Policy, which talks about what is research misconduct, we commonly call as FFP, which we'll also see in detail, what should be the authorship criteria when we are publishing a manuscript, and what should be the policies for retraction and correction, and how the whistleblowers should be protected for that. And lastly, we also have the New Drugs and Clinical Trials Rules 2019, which talk primarily about regulatory clinical trials, about the compensation, as we already heard, about the timelines of reporting of AEs and SAEs. Although this is for regulatory clinical trials, but I think I personally believe that the same rigor should be followed in all academic trials. How that is how compensation should be done and all is again a very gray area right now, as I think a lot of you already asked, but it is upon the institute and the institutional ethics committee to figure out how this corpus can be made and how the insurance policies can be acquired. So coming to the grant writing first. So, grant writing for us, I think for us people of science, it's usually a scientific activity and nothing beyond that. But we have to integrate the ethics part from the very beginning. So even starting from the conceiving of that idea. So, it actually starts, whenever you write a grant, if any of you have, I think some of you would have submitted grants to ICMR or to any other national, international grant bodies, they will always ask you the first question, what is the preliminary data that supports your hypothesis and your objectives? Why do you want to do this research? You'll get that question only when you have some idea. If you are saying you want to try paracetamol for something other than fever, you've probably seen that indication somewhere in your practice in the clinic, right? So how do you present that preliminary findings? I'll give you a very rough example. Let us say you are saying paracetamol we are giving for, let's say I'm giving for heart failure. It's a very vague example. And I say that I have done a pilot study and out of that, 7 people have shown some preliminary benefit. Okay, and larger studies are required to see if that, if that is valid or not. A very unethical way to put that would be that my a pilot study has shown that 70% of patients have shown a very good benefit, and it is likely to improve when done on a larger population. That's a very unethical way. You don't know that. First of all, you didn't put it as, only 70% patients have shown. You didn't say that you need larger study. You said that it is likely that it will benefit. You're already biased there. So that is a very unethical way to put. So even writing that preliminary knowledge that you have, You might get that preliminary knowledge from review of literature or from your hospital settings when you practice, but you have to write it truly, not exaggerating it. Coming to scientific merit. So proposal has to reflect good scientific need and innovation. Even in that, sometimes for small grant we've got 10,000 proposals this year. And we see a lot of questions, that are already answered. Why would you want to do it? They want to learn the factors of, let us say, factors of heart failure among young people in Kerala. Why is it correct to do a study, for which we know the answer specific in patients to Kerala? Do we have a reason to believe that the answer would differ in specifically patients of Kerala? So unless you have that, it is not right to put that question up if that answer is already available. Okay. So only getting the grant should never be something that you want. Your scientific inquiry should be guiding your writing process. Then coming to conflict of interest. So, sir had raised that very clearly. A company that is giving you kits or whatever medical devices and asking you to do a study without declaring, that is a very huge conflict of interest. It is not declared. The money is from them, the study is being done by them, and probably your ethics doesn't even know that, right? So these are all conflicts that none of us should be getting into. Anything that we are doing should be very clearly stated. So you just saw, I have been an investigator on many trials, and those trials were actually, they were funded by ICMR, right? If you see our papers today or our protocols, we clearly write in them that the program officer or the PI is an employee of the funding agency. So that is how you need to declare that you are actually employed by this, and the same company is funded, your program or your trial is funded by this. So you clearly declare that this is a conflict here. It's not, and sometimes you will always have conflict, not that you cannot work there, but you just have to declare that conflict. Fourth is budget integrity. I think this is another very, very big issue that we see. We understand that India is considered, and we all know that, in medical colleges, I come from state government hospitals, so I know that we have limited resources. We sometimes do not even have chairs, tables, air conditioners. I know that. But our grant should not be capacity building grant. If you are applying for a research grant, please don't add things like that. They do not look like they are, they don't look like it's coming out of scientific inquiry. It looks like a facility. You want to develop a facility, and, it's just a way out to develop a facility, not doing a research. Then human and animal protection. Of course, ethics, I think, will be talked about separately also, but we have to obtain ethics approvals way before we start the study, and for some grants, they also ask for ethics approval before we submit it for the grants. Then lastly, a collaborative credit. You also mentioned that you are not even a PI, but you are doing a lot of work in that study, right? So I think if anybody is doing a lot of work, they should be also, contributed on paper. It is important. It is important in a lot of ways. Everybody needs to go years, and even if it's a manuscript, even if it's a protocol, all the people who are actually contributing to it should be named in it. So make your credit collaborative. Otherwise, you have all the rights to go and say also when that is published, or when that comes into practice, that I have contributed, and you have not, you really acknowledge that. Coming to very common pitfalls that we see in our grants that come to us. So first is data dredging, cherry picking preliminary results to appear more significant. As I already said, you say it is very highly beneficial, it is going to improve this and that when we do it on a larger study. The person who is actually reviewing sees through it directly. Everybody will understand in 10 patients, you cannot say it is good or it is bad. We just can say we have statistician. We can't really say that in 10 patients, right? Then is salami slicing. This is again a very common thing. So let us say I want to do a study on diabetes and dietary pattern and diabetes. It's a very common, study that is, I think there are multiples of studies like that. And I put in one grant on my dietary patterns and diabetes, and I put another grant on my exercise patterns and diabetes, and then I put another on my sleep patterns and diabetes. What happens is that I put in 3 different studies, but my age group is same. Let's say I'm doing all this in adolescents. And I take the same participants. They come to me. I have 3 different CRFs. It's just an observational study, right? It's not that I'm giving any intervention, so my participants cannot participate in 2 different studies. I take the data for sleep, for their exercise patterns, and for their dietary patterns from the same patients. But I do 3 studies rather than 1, and I then publish them into 3 different papers. That's called salami slicing. That happens in grant writing as well as in publication, and both are wrong. Then coming to ghostwriting. So ghostwriting basically means that whatever you've made, your protocol, your paper, your manuscript, somebody else has written. You hire a medical writer and you ask them to write. So hiring a medical writer is not wrong. Not acknowledging them is the problem. If a medical writer is being used, please put them in the paper. Please acknowledge that this is being done by a medical writer. That is, you have to disclose it. Then coming to plagiarism in proposals. So copy pasting from any other proposals, last year mera ye proposal hua tha, iska methodology bahut acha likha hai, so I will just copy and paste. And change words here and there. That's very clearly plagiarism. And nowadays with AI, it is to an extent that, it is very difficult now. And I think ChatGPT will give you a proposal in 2 minutes, the whole proposal. But that is not a right way to do it. Using AI is not wrong, but putting your scientific inquiry in it is extremely important, and not doing that is wrong. Then coming to duplicate submissions, submitting the same proposal to multiple funders, and we've actually held people who have taken 2 grants on same questions, and then stopped them, and then denied them both the grants. And this has happened in ICMR, one from ICMR, one from DHR, which is basically the same body. So that also happens. But yeah, of course, most people are, I think, they tell truthfully when they get one that please do not give us the second one. That is how it should be, ideally. And then is a protocol drift. So protocol drift means you got approval for another objective and you are working on, something else. And this is actually taken very seriously. If an objective which is not approved and you are working on that, basically that means the whole of the submission, the peer review that has happened, the approvals that were given were, they have been put to waste, and you are doing something that is not really reviewed by any scientific committee or maybe any ethics committee. So again, that is a very common issue that we have. Added secondary objectives added exploratory objectives is still, sometimes acceptable if ethics have agreed. But not doing the primary objective of the study is the problem. We've had these things also. When we do an annual review committee, we've seen, people who have actually changed the intervention itself. So, that is not really the correct way to do research. Coming to the grant framework, the key requirements is the whole life cycle of any funded grant, be it ICMR or any other grant for that matter. So when you submit, or even when you, before you start the study, the first thing is feasibility assessment and site evaluation. This has to be truly mentioned in your protocol. From a very good institute. So they're doing a study on osteoarthritis, and they are doing it on grade 1 to 3 knee osteoarthritis. It's a new drug. So when it comes to new drugs, there are a lot of exclusion criteria. We usually exclude people who are on long-term medications. We exclude women of breastfeeding and child rearing age. Patients in OPD for osteoarthritis every day. It's a very heavy footfall hospital, and very heavy OPD for orthopedics as well as general medicine. But when you are doing a new drug, their inclusion criteria was that their exclusion was anybody on medicine for arthritis within last 6 months. That's a very big exclusion criteria. That excludes more than half of your population. So when we started, they said that they will be able to include they will be not assessed that properly. They just said that we have 50 patients every day in OPD. But they were getting one eligible patient every day, barely, and sometimes they also deny participating in clinical trials, right? So this is how different it is when you assess feasibility and how it is reported. So this has to be done properly. All co-investigators and qualifications should be verified clearly. I think our GCP also says that all the people who are actually working in a clinical trial, they should be qualified and experienced to do that, right? People who are not even qualified for that. So that also happens, but we should be very wary of that. Then budget justification and institutional rates should be very clearly mentioned. Whenever budget is one thing, I think it's the last thing on all of your minds. You write the proposal and you write the budget the last day when you submit. Jutna samajh aaya, jo bhi samajh diya jata hai. But that is not the correct way to do it, and that is not acceptable by the organization who's granting that budget. They will ask you that, आपके कॉलेज में, आपके हॉस्पिटल में हीमोग्लोबिन 50 रुपीज़ का होता है या 200 रुपीज़ का होता है. That all needs to be actually incorporated into the budget. So it has to be prepared ahead. Later inflating it कि इतने में तो हो ही जाएगा, that doesn't work. People actually see through. So somebody is getting, 30 proposals from, let's say I get 50 proposals from AIMS. From the 10,000 proposals, we actually get, I think 100 are from AIMS only, more than that in fact. So we know what are the rates, what are the funding agency will always know कि वहाँ पे क्या चल रहा है, and they are giving it every year. So they know that how it works. So people see through, right through it. Then again, there are some mandatory disclosure, prior concurrent grants. So this is another issue, I think. So if there is a long research project and you might have done preliminary work based on some other grant, and then you are continuing that work into a bigger study using another grant, and you might, that you might not be able to complete your study in the grant that you've got, so you might want an additional grant from somewhere else. So it is absolutely fine to do that study with using 3 grants from 3 different organizations, but please disclose it and write everywhere, acknowledge everybody. It's not that there's no competition. We all are doing for the good of the, people. So you can always do that, but please disclose it in your publications also, and when you're writing the grant also. Honesty in that grant writing, that you are saying that you've got a DBT grant and you're doing this, and but your work is left and you want to apply an ICMR grant for, that is it is quite appreciated. That is not wrong. Then, of course, IEC registration has to be mandatory before you start. Sometimes it is before submission. CTRI registration has to be done for clinical trials. And any approval, if mandated, from CDSCO, if you are doing a regulatory clinical trial. So regulatory clinical trial basically means doing a clinical trial which for a drug which is yet not approved for human use and is not available. If you are doing any clinical trial for such drugs, or if you want to claim a label change of any drug that is already available, these are called as regulatory trials. And all these mandate an approval from the Central Drug Standard Control Organization. Then during the study, any amendments that happen have to have IEC approval, even minor. Sometimes minor amendments can be notified, but most of the amendments need an IEC approval. Then annual or interim progress reports have to be given to your ethics committee, to your funding agency, to your sponsor. Serious adverse event reporting, madam already said, we have to report all serious adverse events within 24 hours. It is not mandated, but it is a very good practice. Have a data and safety monitoring board for all your clinical trials for their oversight. It is extremely important to have financial statements and audit trails, because I think this is where, again, our medical community really lags. They leave everything regarding to finance and audits on IT and on the financial group that is in the hospital. But we have to take interest in that, and we should ensure that all our financial statements and audit trails are in place, because if an audit happens, the PI is responsible, not the, the FA sitting or the AO sitting in the hospital. They are not responsible. Only the PI will be responsible for that. Any staff change notifications have to be given to sponsor if mandated. That depends upon sponsor policy. And then again, each and every study, and if it is specifically clinical trial, it is extremely important to monitor them. And monitoring basically means that it is going as per protocol or not. and that is extremely, we have to have final utilization certificates or financial certificates within the stipulated time frame as per the policy of your funder. Then all the reports and deliverables have to be submitted. There has 2 or 3, whichever agencies have helped you, please acknowledge them. Data sharing is another issue that, sometimes when this is tediously, very robustly, I don't think people have a problem sharing it. The main issue that people have sharing it is that kuch galti na mil jaye uske andar, right? So make your data so robust that you financial audit that has to be done after you finish your funded projects, and there has to be an intellectual property disclosure. This also, if you think your study or whatever research you are doing is going to generate any intellect, then you should go ahead with those funding agencies. Coming to research misconduct per se. So what we commonly call as FFP or fabrication forms, or you enter data and you present it as your research findings. So, I think it undermines the scientific, integrity to the lowest standard that it can go. So what can be examples? I think we all know recording lab values for things that have not even been tested, inventing patient responses with no patients at all, and creating false screening log entries. I've seen a person being debarred for this. So that really happens, and it should be looked upon, definitely. The next is falsification. Falsification is findings. So, most commonly what happens if there is an outlier, we think we will, remove them from the data set itself, saying that the compliance was not good. But is it written in your protocol that you will remove outliers? Our statistician, ma'am, she clearly said the statistical analysis plan has to be made with the protocol, and we have to stick to it. If you mentioned in your SAP that you will exclude the participants who are outliers, or you will do such kind of analysis, then it might be okay. But you cannot really otherwise change anything in the data. Outliers to improve statistical results, altering clinical photographs, or any images, or changing patient eligibility criteria post-enrollment. That also happens. You have then you think that you should go back and change your inclusion-exclusion criteria. That is, again, it is a falsification. You cannot say, I went to the ethics, it changed, but if you are doing it if you're going back to ethics after enrolling them, it is still a form of falsification, and it is a misconduct of research. Then coming to plagiarism, I think this is the most common form of research misconduct, and it is basically using another's ideas, processes, results, words, or images without giving them proper attribution. More commonly, I think it is done in publications, but it is also commonly done when you're writing the grant. Somebody who's, we will go back to a senior, or somebody who's actually got a grant last year will try and copy paste most of the method section because it is very well written. That is called plagiarism. It is not that kyunki unka acha likha tha, maine unse seekh ke likh liya. It's not like that. So copying method section from published papers. Self-plagiarism is if you publish your own paper again, with tweak a little finding, find a secondary exploratory objective you have and publish a full paper out of it. And then paraphrasing without citation. Even if you are, reading, we all understand when you are writing a paper, you read a lot of journal articles and then write it in your own words, right? But even if you're paraphrasing, your ideas are coming from somewhere else. You need to cite them there. You need to cite the original authors for that, even those ideas that you have taken. Coming to a few more questionable research practices. So one we call it as harking, hypothesizing after the results are known. So let us say, a very simple example would be I give some drug to treat, let us say I'm giving some drug to treat heart failure, as I said. But what I actually see that these people are sleeping better. And later I present my results as that my hypothesis was that drug X will help in sleeping people, better sleep patterns. So this is what we call hypothesizing after the results are already known. But you have to understand, you never hypothesized that, you never analyzed for that, and your study is not parred for that. And that is a questionable research practice. You can always say that, this has also been found that better sleep patterns were observed and a proper study is required to conduct that. You can make a hypothesis out of it to do a study, but not make a hypothesis of this original study and present it like this was my hypothesis and I have proven the results, right? Then is p-hacking. I think madam also talked about it. Doing again and again, keep doing, subgroup analysis. Males में अलग कर लेते हैं, females में अलग कर लेते हैं, अलग-अलग age groups में अलग-अलग analysis कर लेते हैं, अलग-अलग comorbidities में हम अलग-अलग analysis कर लेते हैं, and कुछ तो significant आएगा, right? This is called p-hacking. Subgroup analysis have to be very clearly mentioned in your statistical analysis plan, and you are not allowed to go beyond that. And it has to have a hypothesis beforehand. If you think that the results will be different in males and females, please write that in your statistical analysis plan and analyze them. But doing it post hoc just to find a p-value that is significant and then claiming that this is the result that is found, that is again questionable. Then selective reporting only positive significant outcomes. I think broadly we all need to first understand that a successful study is not giving a p-value less than 0.05 or or giving a confidence interval which is very narrow and shows you something is significant. A good study is what is done correctly and gives you correct evidence. It can be negative, it can be positive. We have to clearly know this, because I think the positive study, of course, we know that it impacts the clinical practice, but negative study also impacts clinical practice. It actually also, rather than only informing clinical practice, it also tells the future researchers not to repeat that. So you need to publish that, otherwise more and more resources will keep getting wasted on the same question. So we should never practice selective reporting, and whatever outcomes you have thought should be reported as such. And that I think our scientific community is way above that now, that only studies that are positive are the good studies. Then inadequate peer review. So when you must have published articles in journals, and they always ask for suggested reviewers. So this happens sometimes when you put fraudulent email IDs that actually belong to oneself, or to your friends. You send your articles to get peer reviewed by them. So this is also something that happens and of course has to be looked upon. Gift authorship, I think we all know this. We add multiple names based on favoritism, based on hierarchy, based on whatever personal relationships, personal reasons, but we should not really be promoting that. And then incomplete disclosure. So conflict of interest, funding overlaps, any deviations. See, we again, as a scientist, as a researcher, and as a clinician, you all will know everything can never be right. When everything goes right, that is the biggest red signal. If you have no protocol deviation, we know that you've not reported a protocol deviation. It is not that it cannot be a protocol deviation. Something will deviate. No, that is how it happens. That is how it works. So disclose everything, whatever conflicts of interest you have, whatever funding overlaps you have, and whatever protocol deviations you've had in your study. Very important to understand again what is not research misconduct. So again, as people of science, we will have disagreements over certain things, and those scientific disagreements should not be stated as research misconduct. Okay. Coming to publication ethics. So what is publication ethics? So I think our International Committee for Medical Journal Editors, they very clearly give that who actually qualifies for an authorship. They should have substantial contributions in either conception, in design, in acquisition of data, in analysis or interpretation of data. They should be a part of drafting the manuscript or critically revising the manuscript for intellectual content, not for grammar, okay? That is not contribution to the draft. They should be one of the final approvers for the draft, and they are accountable for all that is written in the manuscript and all the work that has been done behind that manuscript in the study. And they should not satisfy one of these, they have to satisfy all of these criteria to be an author. Okay. And how we violate this is a ghost authorship. So I think this is much more common than what is seen, that we get a lot of work done by our junior residents, our MBBS students, our interns, and they are not put as authors. But they should be. Why not? If they've actually contributed substantially, they should be named as authors. Then gift authorship. They are named without this is also, I think, very common, named without a contribution. So usually done because of, I think, because of hierarchy or because of favoritism. And I have actually seen a very wrong example of this. And so we had a person who, when I was in college, I think there was a girl with intern, and I don't know why, but I came across her H index was 15. I was very surprised in intern having an H index of 15. Later we got to understand she was daughter of one of the head of departments. So anything and everything is being published. She has her name in that. That is a very wrong way of doing it, setting a very, very bad example for our own juniors, our own community. So, but yeah, this happens more commonly than we actually know. Then we have coercive authorship. So there are practices where seniors forces inclusion of their names, and for the same, there is a policy in ICMR that the head of the divisions actually cannot have more than 2 first authors in any publication being done in the department. So because the understanding is that they cannot contribute to more than 2 as, being substantially contributed and be first author or corresponding author. So they're not allowed to do that. And then order manipulation. So, we all know that even for your promotion, first author, second author, and corresponding author, I think that is what the criteria says for NMC also. And, but they have to be, those who contributed more have to be first or second and your corresponding. So if you want to be that, please contribute more rather than, coercing anybody or forcing anybody. Also, now this contributor roles taxonomy system has been brought into place, and ICMR also mentions that in our own policy, that there are now 14 roles that include these conceptualization, methodology, investigation and all. And at the end, when you are actually writing the manuscript, there is a author contributions area, and for each of the author, you have to actually write what they have been involved in. And that is a very good way of, doing that so that everybody knows what kind of work each single person has been doing. Coming to a little more in plagiarism and duplicate publications. So these are the kind of plagiarisms I think most of you would already know. Copying it directly, copy paste, is called a verbatim copy. And our authenticator intent, they usually, when it is, in some softwares it takes 10%, in some it takes 19%. When the copy paste is over that, they are called as plagiarized. Then paraphrasing without citation, where there is a substantial overlap. Then there is a self-plagiarism, where we republish our own work. Then there is something called mosaic plagiarism, a little for more intelligent people. They pick up from various different places, patch it up together, and that is, they feel that it will not be caught. But I think the technology is advanced quite far now. And then there is idea theft, using unpublished scientific material from somebody and using their concepts without giving them their due credit. That's called idea theft. Duplicate publication basically means submitting identical manuscripts. I think when you submit, most of the journals will actually ask you, have you submitted it to, you have to actually give an undertaking that you have not submitted, and it is not consideration under any other journal. Then there is salami publication, as I already, I think, explained, that you split your study into multiple objectives, try and publish it all separately. So see, one thing again to understand, it is not wrong to publish multiple papers out of that study, but it has to be substantial objectives. Doing something like what I was saying, diabetes and dietary patterns, diabetes and exercise patterns, diabetes and sleep patterns, that doesn't look like, very separated objectives. They're all lifestyle things. But if there are 2 broad objectives, 2 different objectives, you are most welcome to publish it separately. Then redundant publications, you pick up some old publication which is redundant, not really cited, and tweak some changes and republish it. That's called redundant publication. And then legitimate secondary publication. If you are publishing anything from the same study twice, please disclose that you already have a paper from that particular study. Coming to peer review ethics, so this was a role as a scientist, but as a scientist or as a researcher, you also have a role to peer review. I'm sure a lot of you also review articles for journals. They send you for blinded reviews and you have to give in your comments. So to advance our science, we need to do that also ethically, right? So you have to first maintain confidentiality of the manuscripts under review, right? Then you have to declare any conflict of interest if you have to the editors. You do not suggest any self-citations in that. You do not delay any review. Let's say you're working on a similar idea and you just keep delaying your peer review so that your article can go first, published first. And any reviewers, if you suspect that something, what you have come across is being done wrongly, you are also supposed to, report that. Another thing is that we should never, steal ideas from those unpublished and, start working on them. Coming to how we can, go ahead with the correction or retraction. So there is something called a corrigendum that you would have seen in a lot of journals when there are something minor, some minor accurate, like minor typographical errors or any numbers that you've published wrongly, any affiliations that you've published wrongly. All the journals, they most welcome you to get those corrections. They are happy to publish a corrigendum in that, and that is not looked upon. Because mistakes do happen and we should be correcting them. Then there is retraction. If there is an unreliable data, misconduct, duplicate publication, or any ethical violation, the articles can be retracted. Also, do not think if article is retracted, nobody will know that. The retracted article remains in the database with your name in it, with stating it is retracted. So that is for life for you. It will be there. Then there is an expression of concern. If an investigation is ongoing, the journals usually put it as that this particular article is under investigation. And then there is a withdrawal. Withdrawal is basically from the side of the scientist itself or the researcher itself, if they want to withdraw their article even before it was published. There are again COPE guidelines which actually are for editors as well as publishers as well as for researchers. And they mention that editors must act on any suspected misconduct. Authors should disclose all conflicts of interest. Any journals must have data sharing and reproducibility policies. Post-publication corrections, again, they must be transparent. Confidential peer review records must be protected. And research on human subjects should have IEC approvals. I think most of the journals have now actually started asking for your IEC approvals before they publish. And simultaneous submission to multiple journals is prohibited. So these, on either side, if we are a researcher or if we are a publisher or if we are a peer review person, we have to follow all these guidelines. Coming to now, we've done the publication and grant writing. Coming to data, I think we have a separate session on the whole of this, and I will not really go into detail, but integrity is another integrity that we need to maintain in clinical research, and this is basically done by our ALCOA Plus principle that I believe other speakers will go in detail about. So any data that we are collecting first has to be attributable. So the data has to be traceable to the person who has actually recorded it. The next is legible. Any data it has to be legible, it has to be readable as well as permanent. Then it has to be contemporaneous. It should not be like कि मैं यहाँ से 5 लोगों का blood pressure check करके चली गई, I had lunch and then I go and record. हाँ मुझे तो याद रहेगा. That is not the correct way of doing it. The data has to be recorded at the time of, at the time we are doing that activity or time we are collecting that data. Then it has to be original. So first recording and then transcribing him to CRF is not the correct way. You see somewhere that पहले हमने ऐसे एक paper पे लिख लिया, उसके बाद जाके CRF भर लिया. That is again not the right way of doing it because you will have errors. If you are writing it on a paper, that becomes your source document that goes in your file. If it's a tissue paper, that has to be stapled to there. That is your original document. Okay. Then of course it has to be accurate, it has to be correct, truthful, complete, valid and consistent. And enduring. Complete means that all data should be recorded. Any deviations that happen, those should also be recorded. Then all the elements are coherent across. Data has to be retained for the required retention period. So these are all the principles that are mentioned under the GCP E6R3 and the GCLP I think we have a session on data integrity, so I will not go in much more detail. Then finally, responsible. Who is responsible? This is more responsibility, not really exhaustive list of responsibilities for all of this. So what is the responsibility of the PI? PIs are always worried that sole responsibility of the trial is on us, and I think that is, they are responsible for maintaining their essential records in the investigator file, the trial master file. They have to report the essays with integrity, and author manuscripts have to be as per the ICMG criteria, and again PI will have to take responsibility for that. The IEC members, the consent is properly taken, because right safety, of course, is a participant's rights, and ethics has to oversee that. They have to monitor any ongoing transactions that happen. IEC should be managing that independently without any coercion, and they have to review any amendments and protocol deviations, and they have to maintain confidentiality of all the deliberations that happen. And of course, beyond that, if we are doing regulatory trials, they are also responsible for the relatability assessment of the essays at the institute level. Records, they have to ensure specimen chain of custody. They have to participate in proficiency testing. They have to report any data integrity issues to the quality assurance teams, and to institutionalize this culture of integrity. So we have to establish misconduct investigation committee. There's a research integrity officer that the ICMR publication talks about. You as an institute, the leadership is most welcome to have some policy in place for their protection also. So just, I think we are finished with most of the content, and we'll have a kind of a quick rapid fire round, though compliance was never a pre-specified exclusion criteria. The manuscript is submitted to 2 journals simultaneously. Junior co-investigator who contributed to primary data collection is not listed as author. Instead, the department. Okay, anybody wants to specify what are the issues, specific issues we can pick up? Elephant in the room type of thing, right? But we have to openly talk about it. Until the the junior team doesn't speak about it, the senior team acknowledges it, we will seniors at one point of time. How good or how ethical seniors do we want to be? So we all need to get that correct. So that's why I said it's nothing you can learn in a classroom. It's something that you have to imbibe. All of us have to imbibe upon. So, of course, data was manipulated later from future funding. Duplicate submission, as we said, the our COPE guidelines do not allow duplicate submission. So, it is a publication misconduct and author list. So, it is authorship violation, and we should be correcting that. There should be a complaint to the institution. And of course, there's a gift authorship here, which is again authorship violation, and there has to be it is something you do, doing something right when nobody is watching. That's how people actually say it. So integrity is, research misconduct has direct consequences on patient safety, on scientific credibility, as well as public trust. So these frameworks provide us the foundation, but it has to be practiced within yourselves. Grant writing also has ethics. Ethics is not only in writing manuscripts. Even grants has to be written ethically. From accurate preliminary data to conflict of interest disclosure, there are a lot of obligations that as researchers we should be taking care of. These FFP, as I had written in my slide also, they are called cardinal sins. They can be career-ending violations. Okay. Any fabrication, falsification, plagiarism that is caught can be career-ending as a researcher. Then authorship is not ceremonial. See, authorship is not something you can gift. If your name is there in an author, you're also responsible for the work. If if that work was wrong, you are actually responsible for that wrong work also. So don't consider it as a gift, consider it as a responsibility also. Then data integrity under the ALCOA, then we had mentioned that all the data points must be attributable, legible, contemporaneous, original, accurate, complete, consistent, and enduring. And I always like to say that any research is not one person's job. It is always a teamwork, and you need a big team for that. And everybody has a role, and our GCP has very clearly defined those roles. PIs, IC members, lab personnel, institutions, they have specific roles and obligations that we should be following. ICMR also gives this framework for responsible conduct of research in both of these guidelines, which are that there should be an informed consent, data integrity and confidentiality and privacy has to be practiced, all participants need to be treated fairly, and authorship should be responsible. There has to be a peer review, be it grant or be it publication, and compliance with all the ethical guidelines, which I think we've already read yesterday. Lastly, we have a very quick quiz. And I think it's very simple quiz, and let us finish that very quickly. So anybody who can raise hand. It is a very simple quiz. According to ICNG authorship criteria, which of the following alone is sufficient to qualify someone as an author? You can say A, B, C, D quickly and we can go through it. Right. So we said that they have to be responsible, they have to contribute to all the 4 criteria, not only any single criteria. So the second question, a researcher conducts 20 statistical tests on data sets, reports only 2 that show P less than 0.05 without mentioning the others. What is this best classified as? Yeah, it is P hacking. Then under ICH GCP, what does ALCOA stand for? Let's see if you can remember, I told that twice. Okay, so the answer is B. Then which ICMR guideline specifically addresses research integrity, authorship standard, publication ethics? I think that is easy. It clearly says that research integrity and publication ethics. So a PI removes 5 patients from clinical trial data sets after unblinding because they were outliers. What should this action be described as? So you are correct. It is falsification, which is research misconduct. Under GCLP, which document used to demonstrate the chain of custody for biological specimen? I didn't think I took that in my session. Yeah, but the answer is C, specimen tracking log with signature trail and collection to analysis. I think Dr. Meenakshi will tell you a little more about it. Then an investigator submits the same manuscript to Journal of Cardiology, Indian Heart Journal without disclosing. What is this? So it's a duplicate submission. A senior professor insists on being listed as first author on a paper from her department student having read and commented on draft, not contributed to data design analysis. So yeah, it is a coercive as well as a gift authorship. And then we have which of the best describes responsible conduct of research as promoted by ICMR. Right, so the answer is C. And the last I think we have is one case scenario that we have. So there's a multicentric community-based study in assessing anemia prevalence among adolescent girls, and a site submits data much faster than others with 100% questions answered, no missing values, hemoglobin values neatly clustered, there are no outliers, data is submitted before deadline, and during the monitoring, the PI notices that field visit logs are incomplete. We have some monitors also, they can say if the question is wrong. So when questioned, the field investigator said that the participants were cooperative and they maintain a good rapport with the field team. So how do you classify this? Is this fabrication, falsification, poor supervision? Okay, yeah, it is fabrication. I think it's a mix of all of them because we did say that outliers nahi hai, so probably they've removed some. They have some empty logs, so I'm sure there is some fabricated data. And it seems that they were not supervised well. So yeah, but we don't know if it was poorly supervised or not. So now who is responsible? Field worker, site investigator, or the PI? So yeah, the overall responsibility is of the PI, and we also said that PI is responsible for training their staff also. And monitoring should also be done as a team, ethics as well as the PI has to do that. So what are the immediate steps that should be taken? What do you think? So right now we said the data is completed. What to do now? Madam can tell better, I think, better than me. What do you do, ma'am, if something like this happens? quarantine the data, and then how do we go about it? Michael, no?
Anybody else wants to add to it?
Yeah, anybody can answer.
Because first of all, like as a QA, we would do always the impact assessment. There is something that has happened. So there is a systematic failure across multiple levels. This would not have happened over one day. So if somebody is going out to the field, there's delegation of tasks, the training, everything has systematic failure. So quarantine the data. Root cause analysis must be done as to who has not been accountable for the delegated task and what are the future implications. So site needs to be closed, who needs to be notified, licenses need to be revoked. This systematic chain that can happen.
So there's a lot of things that needs to be done, but to answer this question, can the site's data be retained? It cannot be retained. It has to be clearly re-verified, the whole data. And what if it has already been published? It should be retracted, because that is evidence being published on false data. And then, if everybody is hungry, I can skip that. So, single study, investigator-initiated clinical studies approved by the Institutional Ethics Committee to assess the effectiveness of commonly used drug for new indication. And the approved protocol specifies a fixed dose, defined inclusion-exclusion criteria, and outcome assessment at 4 and 12 weeks. Midway, the investigators noticed that several participants are experiencing mild adverse event at the approved dose. So, improved tolerability, the treating clinician reduces the dose of some participants. IEC is not informed, protocol is not amended, the dose change is not documented clearly, and final analysis pools all the participants together. And the study is later submitted for publication. So, what do you do in that? What do you think went wrong here? Is it justified? The PI did it to save the patient. The patient was having adverse events. Yes. So it's a complete violation. What needs to be done is the PI has all the rights to not give that higher dose and stop giving that medicine altogether. That is, of course, under the discretion of the PI. If the PI wishes to decrease the dose, they need to go back to their scientific review and the ethics committee, discuss the scientific credibility of that reduced dose, get an approval from the requisite authorities, their scientific review, ethics review, as well as DCGI if it is a regulatory trial, and then go about the decreased dose. Later also, when we do the final analysis, that should be very clear who got what dose and how it is analyzed. With the statistician, we will need to understand how this modified data needs to be analyzed, and it cannot be definitely pooled together, right? And of course, publication has to come later. So I think that is all. But this is just for everybody's thought that all these things are happening amongst us, and this is happening with people whom you know. How do we want to behave? How do we act upon that? These are just some of the reading material that if you would like to read more about integrity, these are all the international and national publications on that. So yeah, thank you.
Hello.
Yes, sir. Sure.
You gave an example of Kerala, heart failure. But I am only accessible to Kerala. How can I go all throughout country?
No, sir. So I think I was not clear in that. When I said that I want to generate data about Kerala, right? I said I want to see factors affecting heart failure among the population of Kerala. So as a medical person or as a researcher, I would have done some kind of background search, some kind of review of literature, right? Don't I already know what are the factors affecting heart failure? And do I have a reason to believe that factors would be different in Kerala?
There are differences, many differences.
So whatever factors you already know, do that indicate that there can be a difference? If you can clearly rationalize that no, the factors in Kerala are different and it mandates a study, that is a very different thing. But what happens when we submit grant? One wants to find out factors in Kerala, one will want to find out in Rajasthan, one will find out in West Bengal. When the whole population is probably, we already have that data. So only giving that rationale because we do not have local data and we have a country spread data is not a correct rationale. If you have a scientific rationale of why this data should be different in a subpopulation, you are of course most welcome to submit it. But that has to have a scientific rationale. It should not be, defined by because just I want a grant, I will put anything. It has to have a scientific query. That is what I meant. It is very common, exactly. So, it is basically that they are doing research in the true sense, researching it. So, yes. So, most common theses are like that. Factors affecting some disease. It's an observational study. We'll list out the factors and what. But I think the data is already there. So, if you just want to do something that is already established, that doesn't really have a scientific inquiry into it.
Okay, I want to assess one knowledge attitude practice. In, say, for example, biomedical waste management, J.L.N. Medical College today. I involve some UG students, those who are collecting data. I conceptualize the protocol. Some statistician I take have from the PSC department, assistant professor, he has doing the assistant statistical assessment. Who are the authorship rights? Who have the authorship rights?
So I think we very clearly mentioned who's got the authorship rights. The ICMG criteria clearly says that the person who are involved, I can actually go back to that also.
Nobody is fulfilling all the four criteria.
So who's actually done the study if nobody is fulfilling all the criteria? First is idea, then conceptualizing the protocol, curating and collecting and curating the data, analyzing the data.
Everybody is having authorship. Yes. Everybody. But not all the persons are not having all the criteria.
No, but if they are not involved in, so if they, let's say they only do analysis, but they are not involved in writing the manuscript at all, not even revising the manuscript, not giving their intellectual input in the manuscript, and not agreeing to be responsible for the work that has been done, they are not eligible for the author.
Those who are collecting the data, are they not having the right for the authorship?
No. If they are only collecting the data with no intellectual contribution, they do not have the right to claim.
What about the statistician?
If the statistician is giving their intellectual inputs, that is why I think our statistician already said it involves statistician from the very beginning. The statistician should be involved in the design stage, in the data cleaning, data curation stage, in the analysis as well as writing the paper. And they should be a part of the author if they are involved again.
Sometimes they will just upload the statistician to analyze. They are not the authors. But they are helping in like analyzing your literature, data, and then interpreting it, then they will be part of it.
Yeah.
Okay, if a statistician is being paid for his work, can he be author?
No, not at all.
I think if
I think I would differ a little here. So
What he wants to say is that if the
we can acknowledge like their work.
yes, exactly. So if the work is outsourced only for analysis, running a few tests on the, on a statistical software, they should not be a part of the thing. But, our statisticians in hospital, they are all being paid to be statisticians. So yeah, they have all the right if they are involved completely. Yes.
One study has been sponsored by ICR, the huge study, India B. And 17 publications until date has been there out of that study. How 17 objectives can be there for something?
There can be, sir. So that is probably a live study which keeps collecting data and publishing at points. So I had mentioned I was a part of the clinical COVID registry. We've had 10 publications out of it. It was a live registry that collected data for 4 years, and over the duration of years, we did multiple data logs and published different objectives from it. And each paper you will see that we have mentioned that these many papers have been published out of it. I don't know the details about the study, but I think if that has been done, there have been probably objectives to it. So, sir, this usually happens in registry-based studies where data is continuously being collected and we want to answer different scientific queries that keep coming. That is how it usually.
It was just data collection all throughout country. Where more than 1,000 centers have been there. 1,000 centers.
So probably it is a lot of data, a very huge data set. And then if it is something similar to then NFHS. So NFHS is the National Family Health Survey. That data is available online. And even I have published an article from it because I had a scientific inquiry that I thought that data can answer. I wrote my question, I gave it to the NFHS team, they gave me the data, and I published out of that. That is also a mode that, that National Health Survey data are available for anybody, for any of you to use and publish. So maybe that data is available from that. I'm not sure. Again, I haven't seen that study.
One practical question related to first question. I am certain. I get patient from pulmonology. I operate and I send patient back to pulmonology and all the data. They wrote a paper. They write it usually. I don't contribute anything in writing of paper. My name should be there or not?
No.
As a first author, second author, corresponding author?
No. See, first of all, you have to see if it is a trial or if it is use of secondary data. It's a case report. So if it is a case report and you actually contribute to the treatment and actually thinking about how that participant, how that patient should be treated, if you've devised a treatment plan for them and if you've written the paper. See, operating is something, telling you आपको ये वाला surgical technique करना है और आपने किया. But when a patient comes to you, you decide that कौन सा surgery करना है, right? That there are two different things. Making a plan for treatment and then actual doing that. So when a patient comes to the hospital, you plan that, आज इसका ये वाला surgery इस तरीके से करना है, whatever procedures you have. And then you go to the OT, but the team is big. But usually only 1 or 2 person have devised that plan. So if you are actually planning the treatment of your patient and you are involved in writing that manuscript, why should you not be a part of that? Because it's a case report. So there is no data collection as such, there's no primary data collection or filling up data sets. This is probably written from a hospital sheet में से data लेके हमने उसको किया है. And if you are involved in, again, if you are involved in collecting that data, your surgery is also part of that collecting that data, right? Then if you write in writing that manuscript, if you are giving your intellectual input, then of course you can be a part of it. That depends upon how much you've contributed amongst your team members. There are 4 people who has contributed the most. That I think as a team you will need to decide together that who is contributing most to it. Yeah, some institutions do have a publication policy also, and we also encourage when you actually write a multi-center protocol or if you have a bigger team, always mention in the protocol that how will you later publish. There should not be those differences later at the time. You should clearly write, we usually write that the center who contributes to the maximum number of patients will be listed in the priority order of their authors. So you can make your own policy like that and get it reviewed by your institution. Yeah. Yes, sir.
Is there any limit? I mean, maximum कितने authors हो सकते हैं?
There is no limit.
कोई limit. मैं अगर मेरा कंप्यूटर ऑपरेटर ड्राफ्टिंग में हेल्प करता है, तो author
कौन? Again, can you come again, please?
ड्राफ्टिंग वर्क में हेल्प कर रहा है कंप्यूटर ऑपरेटर.
Drafting work में? They cannot be the author.
मैम, हमारे VC है, उन्होंने एक पेपर पब्लिश किया था BMJ में. उनका जो कंप्यूटर ऑपरेटर था, उसको उन्होंने ऑथर्स के नाम में आया कि ड्राफ्टिंग में हेल्प करिए.
So that is what we called gift authorship. Yeah, there is a separate section of acknowledgements. You are most welcome to acknowledge people there. But they do not, they are not eligible as authors in that paper. So somebody, who is not scientifically, not even a scientific person, and we are expecting no scientific contribution, how do you make them responsible for the whole scientific study that you've done? Would that operator or whoever will he take responsibility if, something wrong happens, something wrong comes out of that whole data? I said it's not really a gift, it's a responsibility also. Yes. I think that depends upon journal to journal. I am not sure. But whenever you submit, there is a author's, a guidance. I'm sure it is mentioned somewhere there.
As you are in ICMR, so if you are getting 20 student projects from anybody, so how will you select and what's the procedure of the ICMR?
So, okay, ICMR is, I think it's very transparent in that whatever grants that come out, for students it is usually STS grants, and then there are for other researchers, there are small grants, intermediate grants, there are Center for Advanced Research grants. And in all of those advertisements, we actually mention our marking scheme. So you're most welcome to see it there. We have separate marks for novelty, separate marks for methods, separate marks for whatever timelines, whatever procedures you're submitting. If it's a higher grant, like an intermediate grant, we give marks to the teams as well as preliminary work also. But all the marks, the whole, criteria is always mentioned in your advertisement. So we see how what kind of infrastructure institutes have, what are the qualifications that of the teams, will they be, are they qualified and experienced enough to do such a big project or not, that depends. But it is there in the exact marks and the different sections, how they are marked, it is there in the advertisement.
What do you mean by preliminary work? Preliminary work on the topic or preliminary work
On
done
the
by the
topic.
PI or OP?
By preliminary work done by the applicant on the topic. So, sir, these are some intermediate grants. We have an intermediate grant scheme where we fund projects from 2 crores to 8 crores. Because they are bigger grants, so we expect that some kind of baseline data, some kind of pilot or some data has already been collected by the PI, either using the institute's corpus or without even corpus in your clinical settings, or even using small grants that are smaller grants for less costing grants.
I want to go on some different topic which is not been addressed by the date. So can it not be?
It can go in small grant. So small grant is a grants up to 2 crores, and intermediate grants are grants up to 2 to 8 crores.
But the problem is, if I want to do some health survey, which has not been done by me till date, I have done some other academic researches which are more than that, which are more than required for 50 publications sort of. So am I not eligible for this intermediate grant?
So you are always free to apply if there is a scientific rationale, and if you score well, it will be given. But for any large grant, so that is judicious use of grant money also. If we are giving somebody 6 crore to 8 crore rupees, we will have to see what is the background, what is the question that needs to be answered using that huge survey. Is there a background base that has been collected?
That is the question. The background of the question or background of the PI?
Background of the question, not the PI.
CPRI registration is for particular trial or for particular institution?
For each trial. Each and every trial has to be registered prospectively, which means before you enroll first participant. And it is mandatory. Without that, you cannot even publish your papers.
So, any particular registration needed for the institute?
No. The institute doesn't need registration. The PI or the applicant, they will have to register at the website. Yeah. The only thing that after IEC clearance. When you fill, you have to upload the ethics approval certificate in that.
Thank you very much, Gunjan ma'am, for a very informative session on do's and don'ts. So integrity, as madam said, is of utmost importance, starting from protocol to publication. And ma'am elaborately clarified upon all the points. And also I would like to thank, because you are a representative of ICMR in providing the funding for this particular workshop. So thank you very much, ma'am. And I would request Sanjeev Maheshwari sir to present a token of appreciation to madam. Sir, kindly stay here, ma'am, please. We'll have a faculty photograph before we leave for dinner. Sir, please. Ma'am. Vaishali, ma'am. Meenakshi, ma'am. Gayatri, ma'am. Anuradha, ma'am. And please call your group members and friends who were sitting next to you.
Okay, chalo, without wasting time, I think we should start. Member Secretary? So we will have the conflict of interest as well if she is present. So that's why I said, no, perfect. Okay. So you want to become layman? Very good. Lot of responsibilities there, huh? Ma'am? Anuradha ma'am, she wants to become layperson. Achha. Social scientist is also required. You are. Okay. So you will become clinician. So, okay. Perfect. That is enough for us. For academic, this is enough. Okay? अरे हाँ वो अपनी थे ना कहाँ गए? So मैम को लीगल बना देंगे. उनको लीगल बना देंगे. लीगल इलीगल. So अभी मैम अभी इन्फॉर्म कंसेंट करेंगे कि क्या करेंगे? पहले मॉक करेंगे.
I just want to know is the quorum is here.
chairperson, member secretary, and legal advisor, and clinician, layman, and social scientist.
Everybody is there? Okay.
Yes.
For the regulatory team, this is a must.
Yes.
Okay. For the academic, only one extra is enough. Usually the late person is always the extra person. Yeah, sometimes we have two social subjects, one is the extra affiliated and one of the teachers can be considered as now, since the quorum is there, we are going to start a meeting. Okay. I think chairperson, I am just be blinded because they know their roles now. I want to see how they are going to conduct. And she is a researcher who is going to present for the today's meeting. Okay. Vaishali, it is over to you.
Okay, so your name? Okay, so Dr. Mamta is going to present. So, okay, please kindly present your presentation. Please, yes, please seat. And please introduce yourself, your area of interest, and then present.
Welcome everybody. I am Dr. Mumtarina, Associate Professor in Pediatrics, and I am presenting my study for the same pediatric department, related to pediatric department.
Pediatric.
Okay. My title is a prospective observational study to evaluate sensitization to indoor allergen in children with bronchial asthma.
Okay.
Asthma is a serious health problem affecting approximately 300 million people around the world, causing around 1,000 deaths per year. I have
Dr. Mamta, you can directly go to aims and objectives.
Okay, purpose of my study. The main purpose of the study is to find out the sensitivity to indoor allergen in order to help in designing effective primary preventive measures for bronchial asthma in children.
Okay.
So aim of my study to evaluate the proportion of sensitization in indoor allergen in children between age group of 5 to 15 years with bronchial asthma by using skin prick test.
By using?
Skin prick test.
Skin prick test, okay.
Okay, objective to determine the sensitivity to indoor allergen in children with bronchial asthma between age group of 5 to 15 years using skin prick test. Study design, it is a prospective observational study, hospital-based study. I will conduct this between the July of 26 to July of 27 or whenever the sample size is completed. Study place, the study will be conducted in the Department of Pediatric Medicine, R.K. Joshi Hospital attached with the Government Medical College, Gurugram. Study population, all the children between age group 5 to 15 years, either sex, diagnosed with their bronchial asthma, based on recent GINA guideline 2025, who will be visited in the OPD of Pediatric Medicine Department. Consent, informed written consent of child and parents or guardian will be taken before the enrollment.
Okay, so it is assent, not consent. Okay, you complete that, then we will give comments.
Sample size I cannot calculate, but I have mentioned that sample size should be calculated by a statistician. I'm not a statistician.
Okay. But before any time, yes, before you are presenting in front of the EC, the sample size calculation needs to be there.
Yes. That's why I have mentioned.
Yes.
Inclusion criteria, children with pediatric asthma between the age group of 5 to 15 diagnosed per GINA guideline 2025 and child along with parent and guardian who have given the written consent for this and child's consent as well because 5 to 15 years. Exclusion criteria, patient having any known immunocompromised state, nephrotic syndrome or any hematological malignancies. Patients who have taken antihistaminic, beta blocker or any immunosuppressant drug at least within 96 hours of preceding test. Patients who having severe atopic dermatitis or any skin condition. And child or parents or guardian if you refuse the consent for the study. Statistical analysis I have mentioned which I have mentioned in my video.
Okay. Methodology? Methodology, how you will do that?
Yeah. This will be the observational type of study we will conduct between the July to June early, start from July 26 to 27 of June, and 5 to 15 year of age group, both of the sex, diagnosed with bronchial asthma on basis of guideline, and exclusion criteria applied, and we have selected the cases for the same. And for that, we do the skin prick test for the common allergens like house dust mites, and cockroach, house fly, mosquitoes, अल्टरनेट्स जो कि हम लोग यूज़ करते हैं डिओड्रेंट्स एंड जो परफ्यूम्स वगैरह यूज़ करते हैं, सम फंगाइज एंड कॉट एंड कैट एंड डॉग और हाउस पेट एलर्जेंस. We will collect these allergens, record these allergens from some pharmaceutical company. I have not mentioned that because I am not able to discuss because one night I have prepared this. And we'll do this skin prick test. Test is performed by the cleaning the skin with the lancet 20-25 case of needle. We will do on the roller surface of the skin. The skin is pierced at the angle of 45 degree with the epidermis up to 0.5 mm and slightly and left upward direction. How we do? I have mentioned exactly. And side of it which will be marked, and we'll wait for the 15 to 20 minutes for the wheel. Generally the wheel of 3 mm can be regarded as positive. 10 mg per mm histamine and other things will keep it prepared for any kind of reaction. And the tools which we will use: allergen extract, style lancet, marker pen for the marking and time marking, tissue paper or cotton or positive or negative control solution, container disposables, ruler and recording sheet. And we'll prepare some anti-anaphylactic drugs on hand, like adrenaline injection syringe 1, 2 ml and 10 ml, and insulin syringe with a hydrocod, phenylephrine. And if any case of severe reaction, we'll prepare intubation material, all the things, antidote tube, oxygen supply, laryngoscope, MOM mask, injection, NS Rexona, and ventilator. Procedure: first we will do the informed consent, then till the skin testing report, explain the patient about the procedure, history taking regarding the any drug reaction or any interfering agent which I have mentioned, like beta blockers and any drugs if he has taken within 96 hours that can affect the skin prick test. Or preparation of skin site, proper cleaning, marking of pen, injecting the allergen, actual reading after 15 to 20 minutes, recording the diameter, laser meter by the measuring tape, and after that removing the excess allergen. After 15 to 20, maximum 30 minutes will interpret the data and document the data. And this is the procedure. Study universe like GINA guideline, inclusion and applying exclusion criteria, case selected,
Okay.
test, data collection, statistical analysis.
Fair enough. Fair enough. Yes.
And this is performance for the state.
Dr. Mamta, I just want to know if you have two separate forms for consent from parents or legal guardian and an assent form that is to be signed by the child. And what if the child, because your range is 5 to 15, if the child is less than 12 years old and is...
Mentioned like written consent from child and parent or guardian.
No, because a 5-year-old might not be able to sign a written or understand the written consent. And assent and consent are two different things, and written assent and verbal assent.
I know verbal consent in front of parents you will take.
So you will need two separate forms and two separate procedures for different age groups of children, and also both.
To divide between 5 to 12 months.
Yes.
12 year and 12 year to 15.
0 to 7, 7 to 12, 12
So
to
I have
17.
included 5 to 15.
Yeah, so that will fall in the 0 to 7 category. So there you are going to take only verbal in front of the parents. So that will be documented part. Assent which will be required. Now there are again two age groups. Like from 7 to 12 years, you need to have verbal assent in front of the parents. And from 12 years onwards, you will have written. So these all forms you need to specifically when you are talking about the written assessment. That form needs to be developed in the local language as well.
नहीं, that's fine.
Being a member secretary, affiliate member, I should not ask so many things. But as being a pharmacologist, you have mentioned about in exclusion criteria, something beta blockers and this and that. What beta blocker will do here?
Like they can delay the reaction.
But we are not giving, beta blockers are not indicated in this age group even. No, for what purpose? Beta blocker is, no, if they are contraindicated. Bronchial asthma.
Patient are diagnosed cases of bronchial asthma.
Contraindicated.
ब्रोंकियल अस्थमा में तो ऑलरेडी वो कॉन्ट्रा इंडिकेटेड है ना, तो बीटा ब्लॉकर पे तो हो ही नहीं सकता ना बच्चा ब्रोंकियल अस्थमा तो.
Yes, this is the only one. Okay. You are prepared very well. Yes. Yes, she has to accept each and everything. Yes, yes. Yes, yes.
Correct.
That will depend on the outcome of the...
Then, okay, again.
Because that will help in outcome also, submission demands.
Okay, that's a, you don't have to say it. Okay, my further question is, are you going to do procedures by yourself? So yes, if you are going to do the procedure by yourself, then it cannot be an observation study. Somebody is doing and then you are observing, then it is going to be called as observation study. Now you are doing it and you are doing something that this is intervention study, right? That you are trying to find out? It is not intervention, but you are not observing, you are actually conducting the study.
Because we are doing a test and we are observing the main purpose is not the skin prick test. Main purpose is about the
टेस्ट का रिजल्ट ऑब्जर्व कर रहे हैं ना अपन. We are not intervening.
Okay.
इससे कोई भी ट्रीटमेंट या कुछ
ट्रीटमेंट नहीं कर रहे हैं वो.
सिर्फ ऑब्जर्व कर रहे हैं. कैरेक्टरिस्टिक्स ऑब्जर्व कर रहे हैं.
आफ्टर इंजेक्टिंग एलर्जन 15 to 20 मिनट के लिए वो ऑब्जर्व कर रहे हैं कि क्या रिएक्शन डेवलप हो रहा है.
ओके और आपके प्रोटोकॉल में मुझे कहीं भी साइड इफेक्ट्स नहीं नजर आए. कुछ अगर इंजेक्ट किया तो क्या हो सकता है? कुछ नहीं होगा ऐसे तो नॉट पॉसिबल ना. नहीं, प्रिकॉशन नहीं. जैसे आपने मुझे इंजेक्ट किया तो मुझे कुछ हो सकता है क्या?
For example, I just wanted to ask, I think what Vaishali ma'am wants to ask is, if you are injecting allergens and somehow patient develops anaphylaxis or something like that, so what will you do in that case? No, in spite of all your preparations and resuscitation measures, if some untoward thing or some harm happens to the patient, what is your protection against that? Do you have insurance?
usually like skin allergen when we do skin prick test, nothing. It's not about nothing. Like the reaction time and recovery time is very fast for the skin because we are giving just in the skin.
I understand that, but still, out of 1,000 patients.
What ma'am is asking is, like, if it causes anaphylaxis, what should do? Ma'am, like, this is a skin prick test, it is already approved, the dose which we are giving does not cause us anaphylaxis. Yes. Okay, I have submitted the supporting documents, so that should be the answer. Okay? You should be very clear and very smooth. As a researcher, you should talk less and telling you. Don't try to dig your brain. The other person will try to find out what you are digging. Okay? And you should be very specific with evidence. Because I'm playing a role as researcher now, I'm supporting her right now. Because I'll sit the other side and I have some more questions for her to ask when I shift there.
Okay, one more thing that if suppose you are taking the bronchital asthma, and if the person is having already dust allergy or something, what will happen to that? Will you going to test to that, or that will be your exclusion criteria?
Actually, it is not an exclusion criteria. We are doing household, this is study to evaluate household allergies.
Yeah, that's a valid question, ma'am. Thank you. Because, I just wanted to test that allergen only. It is in the panel of list. Even it can test the household allergen, what are the things. Okay? That is included in the case. Oh, household test, na?
नहीं मैम,
Yeah, वही मैंने
क्वेश्चन ये था कि डायग्नोस केस है
Yeah,
ऑलरेडी
you should understand the question what they're asking. See, you should be mentally
ऑलरेडी
prepared.
कोई बच्चा है डायग्नोस केस है कि उसको डस्ट माइट से एलर्जी है, तो उसको आप क्या करोगे फिर? टेस्ट रीटेस्ट करोगे आप? मतलब वो ऑलरेडी डायग्नोस है, तो उसका क्या करोगे आप?
They are having a history of allergy. Because they know already the history is there. There is, no, that is the exclusion
That is
criteria.
simple question.
That is the exclusion criteria.
See, I am from a social scientist background. I am not a medical person at all. So
Yeah.
my questions are something different.
Yeah. Okay. Can you just allow them to speak? Because as a chairperson, no, they should allow everybody to speak. And chairperson is very dominant here. Okay? Actually, in any committee, chairperson will be there, but usually member secretary should be dominant. Whom they are representing? Your institute. Okay? Madam is very soft and she is quiet, and you should support because she will be knowing the researcher very well. Because some researchers are very good, some researchers will be like they'll have an apprehension while presenting it. She should say, okay, you know that, no, you have written it, just say it. See, like that, because I cannot, because when it comes to some documents, I'll be very strict. I'll be very rigid also. I may not be giving it, but I should be little bit motivating you to support in front of other externals, because other are non-affiliated. I cannot put you down. That is the one thing. Okay? Usually don't think that everybody is targeting you. No, usually it happens in the ethics committee. Whenever the people comes to ethics committee, they say, meeting is there, how many people, ma'am, are you there or are you absent? Because they don't want to face so many people. Sometimes they'll apply someday like when somebody are absent. Some people.
So as a social scientist, I would like to know ki jo allergens what you're injecting. So as you told, there is something from cow extract, from pig extract. So will you take this informed consent, because maybe some children may not be willing to get injected from some animal extract or something. So have you considered that point? So you will be choosing, they will be allowed to choose the allergens कि उनको किससे check करना है? That will be the excluding criteria. And have you considered socio-economic status for asthma? Because that is also, I think.
You say like I'm going to collect all the data. It is in the demography.
लेमैन पर्सन के रूप में मैं पूछ रहा हूँ कि मुझे जहाँ तक समझ में आया, आप कोई रिसर्च कर रहे हो जो कि अस्थमा से रिलेटेड है. आप 5 से 15 साल के बच्चों को बुलाओगे अपने हॉस्पिटल में और उसके बाद में उन पर कोई जांच करोगे जो कि ठीक है. हाँ. आप कोई शायद स्किन पे कोई जांच करने वाले हैं जिसमें उनको कुछ प्रिक करेंगे, तो ये प्रिक कितना गहरा होगा, क्या उसको खून निकलेगा नहीं निकलेगा, या वो बेहोश तो नहीं हो जाएंगे, वहाँ पे खून नहीं निकलेगा, तो इस प्रिक करने से भी उसको कोई नई बीमारी लगने की संभावना है क्या? अच्छा, तो जैसे मान लो कोई बच्चा 6-7 साल का है आपके पास में, आप उसकी जांच कर रहे हो और उसकी मम्मी ही है साथ में, मम्मी ने तो हाँ कर ली, उस टाइम आपने प्रिक भी कर लिया, बच्चा आपका जो भी जांच कर ली, उसके बाद में घर चले गया. घर जाके मान लो पिताजी ने मना कर दिया कि ये कैसे करवा लिया, ये क्या करवा लिया, इससे पता नहीं क्या नहीं हो जाए, आप क्या क्या जानकारी लोगे उससे और उसको कैसे सामना करोगे कि खाली एक जनरली ऐसा होता है कि पिताजी कमाने चले गए किसी के, वो कारीगर है, मजदूर है, कुछ भी है, वो गए, मम्मी उसको खांसी हो रही लेके आई कि भाई आपको हमेशा दिखाते हैं। नहीं, आप तो डायग्नोस्ड मरीजों के बारे में जांच कर रहे हो। मैं ये कह रहा हूँ कि आपके पास तो डायग्नोस्ड मरीज वापस चेक कराने आ रहा है फॉलोअप में, आप उसी की जांच कर रहे हो और खाली उसको मम्मी दिखाने आई है, आपने वो जो भी जांच कर ली चमड़ी पे, निशान बना दिया, घर चला गया। अब उसके पिताजी आ गए कि भाई आपने ये क्या जांच कर डाली, मेरे को तो आपने बताया नहीं, इसको ये ज़्यादा समझती नहीं थी, आपने हाँ भरा ली, कहीं साइन करा दिए, तो इसका कैसे सामना होगा? अगर कोई ऐसा बच्चा आया, जैसे कितने वर्ष तक के बच्चों में आप माँ बाप से, माँ बाप दोनों से, उसके बाद में फिर भी अगर मान लो कोई,
That's good. That's a valid answer.
कितने दिनों तक वो जांच के लिए?
No, 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 no. Usually, no, don't say ek saal. Usually we say like we'll give you 1 day time, one day time. Usually usually we don't take it like in the sensitive issues because pediatric case, it's a vulnerable population. We always say go and consult your husband, and you can come next day and can opine. That's
ये जितने भी एलर्जन की जांच है एक बार में पूरी हो जाएगी या उसको बार बार हर एक एलर्जन के लिए आना पड़ेगा कि आज कैट के लिए आया, कॉकरोच के लिए आया, या क्या सिस्टम है इसका? एक बार में सभी कितने बच्चों को आप बुलाएंगे इस जांच के लिए? अभी तो आपने खैर सैंपल साइज
इसीलिए 50 नहीं,
क्या क्या आप उनसे पूछोगे कि भाई क्या उसकी हिस्ट्री रही है, क्या पूछोगे आप उससे? और आप उससे क्या उसकी जानकारी लोगे, उसका नाम वाम, पता कुछ, क्या चीज़, कितना उनका, नहीं मेरे पास में आम आदमी ग्रुप आने जाने का अगर बार बार आया, नेम ऑफ चाइल्ड, एज, ये जो आप रिलीजन पूछ रहे हो उससे का क्या सिग्निफिकेंस है आपकी जांच में? मैं तो लेमन के रूप में पूछूंगा अगर हाँ। बच्चा आपके पास में जांच के लिए आया, भगवान ना करे उसके साथ में कोई दुर्घटना हो गई, मान लो वो जो भी जांच के दौरान वो भगवान को प्यारा हो गया, तो आपके व्यवस्था में कुछ उसको कंपनसेशन देना प्रावधान है या नहीं है? नहीं, मैं तो लेमैन आदमी भाई, इतनी साइंटिफिक बातें मेरे तो समझ में नहीं आई ये सारी साइंटिफिक बात मेरे समझ में नहीं आई थी, तो इसलिए मैंने
in a committee many times what will happen, same question other persons can ask, you cannot get offended, you can repeat it, you can मैं बोल दिया, ऐसा नहीं बोलने का है, बोलो एक बार, हमारे तो अप्रूवल चाहिए।
मैंने मेरे रोल में हूँ
you should say like sir like वो yeah
क्या आप उसके पेरेंट्स को ये बताओगे कि यहाँ पे इतने खतरनाक?
she told it's a prospective observation study, you can say it's a routine standard of care. Is it a routine standard of care? That you should mention, that will avoid your compensation. Not research. रूटीन में लाइक हम वो टेस्ट करते हैं ऐसे बोलो, वो रूटीन में है तो
इस संबंध में कोई आंकड़े हैं क्या कि आज तक किसी को कुछ नहीं हुआ है इस जांच से? और जैसा आपने बताया कि अलग अलग एलर्जन के लिए बार बार आना पड़ सकता है सेम पेशेंट को, तो अगर वो बार बार आप 15 साल तक के बच्चों के ऊपर ये जांच करने वाले हैं, अगर जैसे आपने बताया कंसेंट के बारे में कि बड़ा बच्चा है तो वो खुद अपनी कंसेंट दे देगा माँ बाप के साथ में, अगर कोई मान लो 14 साल का बच्चा है आपके पास में जो भी बोलना नहीं जानता है, ना वो स्कूल गया ना लिखना जानता है, उस परिस्थिति में आप कैसे कंसेंट वगैरह लेने वाले हैं? और वो बता नहीं सकता है हाँ या ना में, तो कैसे आप उसको कंसिडर करने वाले हैं? ओके, आपकी जो मेथडोलॉजी थी उसमें जो तैयारी लग रही है कि आपने
डोंट आस्क अबाउट मेथडोलॉजी
आप ले मैंने सर
बताने का है।
हाँ वो क्लिनिशियन और
scientifically
बाकी लोग पूछेंगे
lay
ना।
person.
Yes, I totally understood your methodology. मेरा सवाल ही अलग है. आप उनको 2-3 बार आने के लिए बोलोगे तो उनके लिए ट्रांसपोर्ट की कोई आप व्यवस्था करोगे? वो आपके रिसर्च के लिए आ रहे हैं ना वो. एवरी 15 पर आपका स्टडी के लिए वो अगर आज आपका सर्कल बन गया 15 डेज के बाद आपको कुछ रिजल्ट्स मिलेंगे उस सर्कल से?
नहीं
15 to 20 मिनट में ही उसको ऑब्जर्व कर लिया जाएगा।
नहीं मैम, like actually we are doing the test, okay? We are testing for the 10 allergens. We are doing 5 to avoid the pricks. We are doing 5 at one sitting and another 5 sittings after 15 days when they come routinely for the another checkup, we'll do it.
So routinely whenever
Yes.
you will be testing 5.
Yes. That is done uniform. No. That is uniformly done for all the participants. No, you cannot say जितना भी. You should define it. 5 या 10 कितना भी. Because एक के लिए 5, एक के लिए 15 नहीं कर सकते हैं. You should define in your study.
Yes.
Because you cannot analyze differently for different people.
आपने एक बार टेस्ट कर लिया 15 दिनों के बाद वो बोलेगा, पेरेंट्स बोलेंगे अरे नहीं हमें दोबारा नहीं ये सब कुछ करवाना है. So that will be the exclusion criteria again.
Yeah, no ma'am, in that case no, we will ma'am, they can withdraw from the study anytime. Yeah, thank you. Esthe. No, you should speak in that way. That is the researcher work. Okay? Is it okay?
किस टाइप का रिस्क रहेगा मैम इसमें पार्टिसिपेंट्स को?
पढ़न
किस टाइप का, मतलब 4 टाइप का रिस्क वो बताया था ना?
नहीं वो नहीं. Listen. No. Sir, like, no, we don't know. They can't. That one has to be done by you people.
Okay.
That you should do it. As a clinician, you should do it. I am asking you, sir, like as a chairperson, what type of risk? You should have given it in your review. That is, the clinician and the basic medical scientist should do it. Review form. No, it is like once they are related, we'll counsel them and we'll guide them, we'll refer them. Ashte, over. Guide them as per the standard routine. Ashte. That is the end of your study. Don't do that. You just talk about your study. Don't dig your grave there.
Consent के लिए आपने बोला. For consent, ma'am, you were saying for father consent, we'll give 1 day कि एक दिन आप घर जाके आ जाइए, तो next day the patient be coming only for the test ना. He is not coming for a regular follow-up visit. Regular follow-up तो आपका 15 दिन बाद है. तो जब वो एक दिन बाद टेस्ट
अगर आए तो अच्छा है, नहीं तो लाइक आप 15 दिन के बाद भी आ जाओ. Anyway, it's observation study.
Okay.
Usually in the clinical
So you'll
trials,
give
we give
15
just
days
yeah.
time.
In the trials, we are very strict over there. We'll give just for 24 hours.
Okay.
City में. इधर recruiting.
Academic studies we can.
Because you don't have anything for them to give a out-of-pocket expenses in the academic study. पैसा तो नहीं है आपके पास. Yeah, anything else?
Thank you so much.
Thank you. Yeah. I just wanted to see like any comments on it. What did you feel? See, this is how it will be conducted. Okay, and then there will be more proactive, those who are affiliated also. And we should, even the ethics committee members will not be very harsh. They'll be very settled. I know like it depends upon the individual person always. Okay, and the chairperson and the member secretary will handle that. Any opinion?
Submitted. So whenever you are going to ethics committee, the ethics committee will provide you the checklist that what documents will be submitted. With that checklist, you can submit the document to the ethics committee.
I think yesterday Shivani projected it along with
Yes.
the protocol document. There was the essential documents. Those were the enclosures which is required, like CV of the PI and the COIs, and then the CRF, ICF, assent, and if there is any MOUs, MTA, medical trans agreements, all the agreements, everything should be written. And even whatever if you want to advertise also for the recruitment, that also needs to be get approved.
No, consent should be bilingual. Yes. Document, see, the basic underline is whatever is required for the patient, which will be given to the patient, that will be bilingual. अगर आप diaries उनको देते हो कि आप diaries maintain करो, so that diaries also will be in the bilingual. So whatever patient को जो भी जाएगा, वो सब bilingual होगा.
Even if you give one pen to the patient as a gift, that also should get approved by the ethics committee.
Yeah, I
okay?
will
You
share
cannot give
my,
anything.
I'll
For example, I want to give some snacks or something. You should say, I'm going to provide the snacks when they come for the each visit. It should get approved. Let us see, like you are giving a snack as an inducement for them. You're not told. By mistake, as a affiliated member, I'm just passing by. I say, like, why, who is distributing? Ma'am, it is part of the study, they say. Then I say, वो तो बोला नहीं है. IEC में.
To share,
approving,
just to
you
share.
should have told everything transparent, it should be. Because IEC can do audit anytime. You can give it because nobody will say मना नहीं करेंगे हम 2 बिस्किट देंगे तो वो तो inducement नहीं है. Some people will
वही
be,
बता रही
yeah,
हूँ कि when I was working as a study coordinator a long time back in around 2006 or somewhere, or rather before that also, our sponsor wanted to give thank you card to the participant once the trial was over, and a very nice water bottle. I still remember that I had to go to the ethics committee. I took approval that I can give the thank you card because they had checked the content of the thank you card also.
Sometimes इसके ऊपर लोग नाम और phone number लिखा होता है. That should be disproved. Ethics committee में वो क्या सिर्फ thank you लगना है, no logo, nothing. Okay?
So that got fit in my mind that whatever requires to be given to
we have to check and they have to
have to
present to
take
the
permission
department
from the ethics
like see like what they are giving it. That is very critical. It should not be an advertisement for themselves. You cannot endorse anybody there. Okay.
If you want to give any advertisement also in the paper for the, okay, if you want to recruit any patient and you want to give ads in the paper, that ad content also should be approved by the ethics committee.
Yeah.
Buy one, get one free kind of things are not allowed.
We are told
in
some
the content of the
some of the diabetic studies, like they want to give glucometer for them to do the test at home and all. Okay, sometimes we have asked, is it only during the study they are going to use it? Sometimes they will take it back after the study is over. Okay, that also should be mentioned in the beginning itself. Okay, we are going to give it for lifetime, or else like we're, because some people will be having a habit of getting free every time. Once the strip is over, they'll say like for the replacement of the strip, who will give the replacement of those strips when the study is over? That should be very clearly mentioned in the informed consent form.
Nowadays, sponsor
I'll be
major
giving only the
strips
strips only for this period. All those things. See, it is very clear, and you can say, no, हमने बताया था ना पहले ही. We are not allowed to give anything extra. Whatever you do, put it in the protocol and the consent form. Take their signature. It is to protect you people as a researcher, most rather along with the participant also. Because there should not be any like disagreement later on. Okay?
Yes, that is the most important thing because they.
Yeah, together it is called as an informed consent document. It includes two parts.
So I'll
Part
talk
A-
about that little later.
Now she is going to talk.
Yes, I'll.
Yeah.
Anybody else wants to present any protocol?
Is it? Okay.
ठीक है.
If you want, you can just.
They wanted to have one more mock, or this is enough for.
Yeah. You want to present or? Huh?
You also have prepared. I think what now we will do.
Let's just go through it briefly.
Okay.
Yeah. Just.
So we have spent a lot of time in one protocol. Now we will keep some time limit.
Yeah.
We will keep some time limit for
Madam
the
Dei?
next two.
Okay, then I'll become member secretary.
So you become the member secretary.
अभी आजा. उधर उधर है, laptop उधर.
आप बोलोगे तो भी चलेगा क्योंकि as it is we are unable to see.
Just finish in 2 minutes. Just the title and objective because we're running out of time.
How many people have registered for this workshop? Yes. So we will not be issuing certificates unless the attendance is compulsory. I am presenting and so on, so I will mention. If anybody wants to learn, they should be in this room. Otherwise, they will not.
Yeah, go ahead fast.
My name is Dr. Pradeep Kumar from Associate Professor Anesthesia. My topic is effect of inferior vena cava, ultrasound guided preload optimization on the incidence of post-spinal hypertension in adult patient undergoing surgery under spinal anesthesia. A prospective randomized controlled interventional trial. As you know, post-spinal
What intervention you are doing, sir? Is it first of its kind? Is it you are doing for the first time as a newer modality? No, is it a routine thing or it's a, then why you are written as an intervention?
Routine thing in other departments like focus area where point of care ultrasound is very common, like in emergency department or medicine department. It is not common in anesthesia department to see.
This technique is not done in the anesthesia department routinely, but in the other departments. You are doing it for the first time in your department. Do you have an expert who is expert in this technique? Have you included them? No, usually, but technique, though, you said like they were doing in the other department.
Point of care ultrasound, everyone should know about it, and we use.
No, ultrasound you are using, but you said the modality, that because you said intervention, there's a new intervention which is doing for the first time in your department. You have an expert in this.
In your department.
We use this in ICU. Infravena compression, we see ICU patient, but we will use it in OT patient, in operation patient. We use
But normally you won't use it in the spinal anesthesia, but you will use it in the ICU patients, but you want to try it in the...
For fluid correction, we use this method to see fluid responsiveness in ICU patients.
That is usually use it for lymphedema, no? The same device like that?
It is inflamed vena cava comparable. We see the diameter only.
Okay.
And then we give fluid and then we see the response.
But you won't do it normally for all the spinal anesthesia people.
In spinal anesthesia, we give fluid as to, we give fluid whenever hypertension is happening within prescribed range or with predefined range, and we give vasopressor if required as per protocol. But we want to see the inferior we want to...
What made you to take up this study? Any literature?
No, not yet.
Not yet.
We want to do pilot study first, then we will go for...
Do you have any funds for this? Fund? Like, how do you address it? Because you want to first time doing intervention.
Intervention, fluid, we did...
Yeah. What fluid do you give? Care, na? That is not called as an intervention. That is not intervention. It is not even observation because you told it's a first of its kind, you are doing it. It's a prospective study. It's not observation because you're doing first time. And it's not intervention because you're not injecting, because you're just doing ultrasound. Okay, it's non-invasive. Correct? That's what I understood. See, that's the whole title get messed up. Now your methodology will change, objective will change, सब कुछ change हो जाएगा. See, always your objective should be very proper, hypothesis it should align with the title now.
Actually, there is a side effect, this is a post-spinal anesthesia, there is chances of hypotension is there.
No, that is normal. Hypotension, according to him, hypotension is a very common adverse effect seen following spinal anesthesia. They'll just raise the leg end, I think they know, and it's a routine thing. And even they should not say like the paralysis, caudal paralysis was very, very rare, which they should have mentioned even in the consent form, the routine ones. That is common one. He wanted to reduce the incidence. There, for example, let us say it's in 30%. He wants to check how much it is if it is ultrasound guided. That I understood. He could have done it in a better way because he made it very invasive one. The looking at the title. It is not so risky, but the title and the objectives you should modify. It looks like the intervention. You got it now? How you present, how you modify is most important. Yeah. Yes, sir. Thank you very much. Like, you need to modify it. Can you please resubmit?
Injecting the fluid before operation, pre-op phase is not a routine procedure. So this must be intervention.
No, before.
Before giving the spinal routine, injecting the fluid is not
Preloading and colloading are routine procedure.
Routine procedure.
Preloading with guidance, exact guidance is not routine.
So that is how madam is saying that you have to change the title of the.
वो change करना है अभी. वो सभी गलत है अभी. Methodology सब change है. I want to say what is the routine over here, and then what he wants to do above and the routine now. And what? You are from the anesthesia only? Yes. Okay, because I am not an anesthetist, because I am a pharmacologist, because they are the experts, you can say, because I don't know what is done before and after. Because if I have any doubt, see for example in ethics committee, if I don't have any anesthetist, but still I want to know, but I will call an expert who is a senior most person and make them sit, I'll try to understand what is the routine, all the things. Okay?
One more question. Suppose USG is routine habit, no issue. But the USG guidance with fluid measurement, we never measure fluids in routine pre-op. But now we want to measure with USG,
Yeah.
and this is.
But USG you will use it, but you will not measure it. Okay?
Yes.
But the measuring the fluid, this thing, that is not much risky, right?
Risky, but it is newer.
Newer. I know, it's not intervention. You anyway you are going the fluid, but you never used to measure. But now you want to measure. Okay? I understood what is given there, what you never used to. For example, let us see like you are giving the fluid, but you are not measuring the output. But now you want to measure the urine output. उधर में क्या intervention है? कुछ नहीं है. Now you are measuring it, that's it. Okay, we see what is the routine over there. Now he is measuring. It can be run as a prospective thing and can be given, but no intervention there. Now I'll assess which risk he belongs to. That 4 categories of risk and risk benefit analysis. Whether it's a high risk, low risk, and all. इसमें तो मुझे high risk नहीं दिख रहा है, low risk भी नहीं risk है. It may be minimal risk. वो तो routine है. Okay, minimal risk में तो usually approve करते हैं. But his title and all looks very horrifying. Looks, actually, you can modify it in subtle way and it can be doable, this study. But you should modify in a better way.
Because the members of the ethical committee might not be a part of your subspecialty. So it should be in such a way that it is understood clearly by everyone. Because this kind of a title might look very intimidating from a person who's not from your background. So you could just rephrase it and make it better understood by the people who are not from anesthesiology or that subject specialty per se. So because the only thing that you are trying to do in this study is that you are giving fluid to a patient with who is given spinal anesthesia, but earlier you used to monitor it, or say it used to be guided by hemodynamic parameters such as blood pressure. But blood pressure is something that comes very late. Like a fall in blood pressure will be a very delayed kind of a thing, observation. So you can improve the patient outcome by guiding it by ultrasound. So that is how you can change your title for it to be easily understood.
मैम एनेस्थीसिया पीपल्स के लिए यूएसजी रूटीन नहीं है ना, तो क्या रेडियोलॉजिस्ट को इसमें इंक्लूड करना पड़ेगा?
रूटीन है हमारे लिए. It is routine. We don't have portable because of PCPNDT Act. It is not allowed. Portable USG devices are not. We have full console USG machines in our operation theaters. They are registered under PCPNDT Act, and we have taken. Yes, we use it for regional anesthesia. We use it for hemodynamic observations. Everything, for everything. Lung scans, it is like point of care ultrasound. Wherever the patient is, we use ultrasound.
See, in doubt, always call an expert. Ethics committee will clear in their absentia. Then we call them and tell our decisions. Okay, we never discuss in front of them. Because an expert will not give a right expert opinion. It will become a conflict. वो नहीं support किया, ऐसे होता है ना department ने. इसीलिए like अलग बुलाते हैं. So we should call them separately. We take whatever the doubts by the members should take it separately and keep it confidential. Take a decision in a separate way. Okay, thank you. Thank you.
I won't take much time because I know time is very pressing to us. So now, since yesterday we are talking about consent, informed consent, what is it now your understanding about what is consent is? What is consent? वो तो खैर that is peelers. So consent is giving permission in simplest language. And informed consent is after being informed giving the consent or requesting for the consent. That is, okay, I have given you all the information and now I am requesting for the consent. It's called as informed consent. So this is one of the very much ethical pillar of doing any kind of research. So since yesterday we are talking about a lot of ethics. So today I would like to tell you a story about ethics which really fascinates me. The depth of the ethics we can understand by this. It is a story about Chanakya. So we all are aware about Chanakya. So Chanakya was friend, philosopher, guide of Chandragupta Maurya. So one day, another ambassador came to Chandragupta Maurya and stated that how your country is so happy. When you are asking for 1 rupee tax, people are ready to give you 2 rupees also. So Chandragupta Maurya said, rather than me explaining things to you, I'll introduce to the person who has actually designed everything. So another ambassador got formally introduced to Chanakya. And they both started sharing the things, both started discussion. Soon they became very good friends. Reason behind, because their intentions were matching. So they became very good friends. Days went and they both, the Chanakya was sharing many things. In today's scenario, how 1 rupee comes in, how 1 rupee goes out, and how you are going to facilitate the things. Days went, and the last day when it was there, Chanakya said, now very little is remaining with me, which I can share with you. What we will do, we will go to my place, I'll share whatever remaining part is there, and then we will proceed for dinner. So the ambassador was really very happy because he got the invitation for dinner. We cannot deny for dinner, right? So he readily accepts the invitation of the dinner. So both goes to so-called Chanakya study room. So where the ambassador finds out that there is a pair of lamp. That time there were the earthen oil lamps. So there was everywhere there were pair of lamps. One was lighted and the other was unlighted. Ek jal raha tha, ek nahi jal raha tha. Ambassador couldn't understand that why there is a need of everywhere there is a pair of lamp, which is one is lighted and another is not. But as we always, whenever we are visiting for the first time, we never ask so many questions, right? So even the ambassador didn't ask any question. So they started discussion, and soon the discussion got over, and Chanakya said, now we will proceed for dinner. As soon as he said the sentence, a servant walked in. And what the servant did, he unlighted the lighted lamp and lighted the unlighted lamp. Understood? जो चल रहा था उसको बुझा दिया और नहीं जल रहा था उसको जला दिया. Now ambassador couldn't stop himself by asking that why you are taking so much pain when one lamp is already lighted, why you are taking pain of unlighting that and lighting with the other one. Chanakya gave him a very beautiful answer. He said, till the time I was doing official work which was given to me by my king, I was using the oil which was given to me by my king. And now you are guest at my place when we are proceeding for the dinner. Now it is ethically not correct to use the oil which is given to me by my king, but now here I have to use the oil which is purchased by me. This is something called as height of ethics. Now if this kind of ethics we start implementing in our research, I think we will make miracles in the research. Because this is, we always call that ethics is something pillar of any kind of research. In even today's scenario, in day-to-day life also, if we start implementing these kind of ethics, we will make miracles. With this story, we are moving towards the informed consent. Okay, now we are going to see what is the objective, what is the importance of ethics committee. I am not going to go into the details of this because since yesterday we are talking a lot, but yes, few concepts which needs to be highlighted again, that part I will definitely highlight. Now, what are the basic principles, basic guidelines for this informed consent is one is Declaration of Helsinki, and the other is Nuremberg Code, because Nuremberg Code has given the concept of consent. And by Declaration of Helsinki, these are first international guideline which talks about the biomedical research in the human participant. You must be aware why Nuremberg Code came into existence. Are you aware why Nuremberg Code came? Or when Nuremberg Code came? Because that is the basic thing we need to understand. What now? World War, which World War? World War II. So what happened in World War II? Okay. Okay. So in short, in World War II, the Nazi did unhuman experiments. What kind of experiments? I'll tell you 2 experiments. They had done the twin study. So for twin study, they had cut one child hand to find out what is the reaction of others. This kind of twin study they conducted. They inoculated live gangrene cell to find out how the disease is going to get progress. They kept the people hungry for weeks together to find out what are the symptoms of hunger. Do you find any science behind this? Is there any science behind these kind of studies? Practically not. So there was no science, no rationale for the study. On and about, nobody was asked whether they want to participate in study. If today, if I do something like this, you will sue me in the court. Correct? So that is something, a baseline, that is the reason it again highlighted. On and about, in Nuremberg Code, once the study got over, the US has interfered. And there were 20 Nazi 3 doctors who, they just ran away from Germany. And some of them were caught, and then there is something called as famous doctor's trial. That is a court case which took place. And when the court case was going on, the judge asked them that your country only has given the Berlin Code in 1931, which has talked about the consent. But you have violated everything. So they said, no, we don't have these kind of guidelines. Neither we have any international guidelines, nothing is there. And on and above, the answer was, these studies were conducted on Jews. And if at all the regulations are there, those regulations are for human beings, not for Jews. These kind of answers were given in the court. So again, after that, the 2 doctors were formulated the Nuremberg Code, which highlighted the concept of consent, that is voluntary participation in any kind of research, and a participant will have, they can stop in between without losing any benefit out of the study. That is something which was highlighted with the help of Nuremberg Code. Okay. Now there are certain definitions which we really need to understand. That is as informed consent. Now what is informed consent is? A process by which a subject is going to voluntarily agree to participate in the study. After being informed, मुझे सब information दी है, I have understood everything, and now I am going to voluntarily participate into the study. That is something called as, so this is not only the signing document, but this is a procedure to be followed, that the person will understand what is going to happen with them, and then they are going to sign the consent. Subject, trial subject, or now we call it as participant. They are the study participant who are going to actually take part into the study. So they are going to be called as study participant or study subject. So an individual who participate in clinical trial, either they will receive the study product or they will receive the comparator arm, whichever way it is. Then there is legally accepted representative. Now we will have the scenario. If suppose my patient is, patient can read and write. He understands, can read and write. So I don't need anybody. Patient has understood everything. Patient only is going to sign the consent form, and that's all. The investigator will sign, patient will sign. Both parties are going to sign. This is mandatory because this is legal document, legal agreement in between doctor and patient or researcher and participant. So this is fine, that person is literate. We will take the signature, investigator will sign, and the informed consent will be over. Second scenario. Now if my participant is illiterate, what to do? Can I take the participant into the study? If yes, what is the provision? But then, okay, you can explain, no doubt. But on which document you are taking sign, they will not understand. Anybody else? Verbal consent. No. There is a provision in law that there is something called as legally accepted representative. Person can sign on behalf of the subject. So common son, mother, husband, wife, they can sign on behalf of each other. So again, person who is authorized by law to sign on behalf of the subject will sign on the consent form. So I will take thumb impression of the person. Okay, thumb impression will be taken for the person who is illiterate. Which thumb impression? Why left? Why left? You instantly said left, no? So why left? Why not right? So actually it is non-dominant hand. Legally it is always said that left hand, but it is non-dominant hand so that there won't be any scars. So never understood that everybody is right-handed. So non-dominant hand thumb impression will be taken and then LAR will sign on behalf of the subject. My third scenario, my patient is illiterate. My legally accepted representative is also illiterate. Can I take the patient into the study? I repeat, my patient is illiterate. My legally accepted representative is also illiterate. Can I take the patient into the study? How? Okay, little bit more. So वो sign करेगा. Anyone else? So that is something, it is a person, impartial witness will walk in here. Who is the impartial witness? Third party, who is not part and parcel of trial activity, but the person will sit into the entire process and he will make sure that the patient has understood everything. So he is literally attesting the procedure. That patient has understood whatever was there, he has asked the question, the investigator has answered the things, and then the patient is voluntarily agreeing to participate. Nowadays, even if patient is literate, sometimes even sponsor demand for impartial witness. Reason behind, because they want to make it double sure that patients are not forced to participate. So we understood the three. These are very basic concept in informed consent, because every time we are going to utilize these concepts. That is these definitions.
And also, ma'am, some days later, the patient, if the witness is not there, can say, "मुझे तो जबरदस्ती किया था," something like that.
So that is the reason, even for the literate patient, it is they are agreeing for the impartial witness. We have much more talked about the vulnerable population. So who will protect the vulnerable population? Since yesterday we are listening, so who will protect the vulnerable population? Parents will protect, okay? मैंने तो अपना भाई कल एग्जाम्पल दे दिया था आपको, right? If you remember, I had given how I can become a vulnerable population. So ethics committee will be there to protect the vulnerable population, so that there are more and more things which are required, how you are going to protect the vulnerable population. So in simple language, who is vulnerable population? Who cannot take decision on their own are called as vulnerable. We have list, we have definition, but in simplest language to understand, people who cannot take decision on their own are called as vulnerable population. Okay, these are synonyms. You can call it as patient information sheet and consent form. Now, informed consent form is made up of two documents. One is patient information sheet. The name itself will tell you that information needs to be given to the patient, will be patient information sheet, and then the consent form. We can also call it as patient information sheet, consent form, or only an informed consent form, whichever way it can be. Now, when to conduct and who can conduct? So, when to conduct informed consent? When we are supposed to take the before at the time of recruitment. So before starting any study related procedure, see, if the patient is into the research, I cannot take a simple height of the patient also without consent of the patient. It is as simple as possible. So any study related procedures can be done only after the consent is done. Many times we have कि चलो height ही तो लेनी है, BP ही तो लेना है, क्या ही हो जाएगा. काफ़ी मशीन्स भी आते हैं कि वो टाइमिंग भी दिखा देते हैं कि आपने कब किया था, और फिर पता चलता है बाद में मॉनिटरिंग में कि बीपी पहले लिया गया, कंसेंट बाद में ली गई. So that is a violation of the protocols. So we don't want to go with that. So without taking consent, not a single procedure is going to start with the patient. Now, who can take consent? Anyone who is competent enough, because our guidelines, our regulation, they have not given any guidelines who can take the consent. The person has to be competent enough. The person should be known about the intervention. The person should be knowledgeable to explain the things to the participant. And on and above, the very important, person should be on delegation log. That the person who will be delegating, investigator will delegate the person who can do the consent for the patients. Now, these are parties which are responsible for consent form. Sponsors, because they are designer. They are going to design the consent form. Ethics committee, because they are going to review the consent form. Now, what needs to be reviewed? Whether everything is written correctly or not. Whether translations are correct or not. For translation, there should not be translation like dear subject priya vishay. These kind of translation should not be there. I have seen this translation and that's why I am sharing. Dear subject, priya vishay. For clinical trials per se, there are no problems. I think now you have understood what I wanted to say. Because for clinical trials, because we do have translation certificate, back translation certificate, but when it comes to student thesis, they can do anything. Majority of the time, Google translation is there. So Google uncle, whatever they will give, we will accept it. And that Google translations is horrible, sorry to say. But then it is ethics committee's responsibility to check the translation. Whether patient has really understood. Otherwise, मैं पढ़ूंगी और पता ही नहीं चला क्या पढ़ रही हूँ, तो क्या फायदा है उसका? तो ये नहीं होना चाहिए. So it has to be best understood by the participant. Again, a simple example. If it is written in the informed consent, 10 ml of your blood will be taken. हमें तो एक ट्यूब दे के भी फेंट आ जाता है. So patient will definitely faint. So rather than that, if you write, okay, 2 teaspoons will be taken from you. They are also at ease. Right? So these kind of things, non-technical language, needs to be taken care with the help of informed consent. And investigator is the person who is going to practically take the consent from the participant. So he should be, what he should be doing, he should be taking the version which is approved by the ethics committee. Why? Because the consent form also can get amended. Simple example, if the protocol is going to get amended, consent also will get amended. So if the new version is coming up, if the new version will get approved from the ethics committee, then version needs to be implemented whenever the trials are going to be conducted. Now, what are the essentials? Essential part. Okay, this also we have done. Content of the informed consent. If you remember yesterday I was telling that if you compare the R3 version of GCP and ICMR guidelines, you can find out quite a lot of similarities. So ICS section has definitely taken okay, what ICMR or what India is doing. Because there are many parts which are taken from ICMR. And practically the language is also same. And some additional part, yes, definitely are there from the GCP version also. So what is important whenever we are designing the consent? What is the research is about? Our first sentences should be always that this is a research. This is an experimental research. We should always explain them with the help of what is the purpose, why you are doing it. That needs to be added into the informed consent. Then trial treatment, if there is a randomization is there, how the randomization will be done and how the things are going to be carried out, that needs to be added. Then procedures. Procedures, in detail procedure needs to be there, which needs to be included. So there are altogether 26 points are there, which needs to be added into the informed consent. So you can imagine if you start writing at least one line for each point, how much length of the informed consent is. So that part, everything has to be included into the informed consent form. How many participants are going to participate into the study? We always talk about the sponsor's responsibility, ethics committee's responsibility, investigator's responsibility. We never talk about the participant's responsibility. So that part also we've seen it today, that okay, participant also has some responsibility to share. And that also needs to be highlighted into the informed consent form. For example, okay, you are supposed to come to the visit within the stipulated time, you are supposed to come. If you are supposed to take medicine, yes, you are supposed to take medicine. These all part needs to be highlighted into the informed consent form. Under which, now usually we always say that patient can withdraw from the study. But at the same time, even investigator can terminate the patient from the study. Maybe for the safety reason, whatever the reasons may be, but those also needs to be included into the informed consent so that the patient will understand, okay, under these kind of circumstances, even the investigator is going to say, okay, now your safety is getting hampered, we are not going to continue you in the study. Then what are the aspects which are experimental? What kind of experiment you are going to conduct? That needs to be highlighted again. Then what is the risk and benefit? Obviously, none of the drug will come without any risk. So explain the risk, at the same time, explain the benefit out of the study to the participants. Compensation, hot topic everywhere. Compensation needs to be explained. Under which circumstances the compensation will be entitled. Those things needs to be added into the informed consent form. Any payment, if whatever kind of payment needs to be given to the participant. And then, like we have talked about that your participation is completely voluntary. So the statement has to be there into the informed consent form. I won't go into the details because whatever is there in the content form, it has to be in the discussion also. So whatever we have seen, this is research, this risks are there, these benefits are there, whatever will be there, those all point needs to be there whenever it will be discussed with the patient. Patient, their relatives, whosoever are going to be there. Still we are going to have common problems. Although we have learned quite a lot, but learning and giving paper is something different, right? So which is always there with the informed consents also. So the common problems are there, so many common problems. That investigator has signed at the place of patient, patient has signed at the place of investigator, they have signed with pencil, thumb impression along with date, common problem. थम इम्प्रेशन ले लिया और बाद में कोऑर्डिनेटर ने डेट डाल दी. Invalid consent. So there are kind of a problems which are going to come. So always be vigilant whenever we are going to take consent from the participant. I'm sorry, I'm running a marathon because I can see that one more topic is still there. Okay, now it will be open if you have any questions. Because since yesterday we are talking a lot about informed consent.
Informed consent समझने के बाद में तो ऐसा लग रहा है जैसे वो आजकल इंस्टॉल करने के पहले डिस्क्लेमर नहीं आता कि उसको चेक करो तो पढ़ते पढ़ते तो कौन करेगा?
नहीं, that is the reason.
My question is, ऐसे में जनरली अब जो होने लगा
नहीं सर, आप कंसेंट में ऐसा नहीं कर सकते. Specifically when you are doing the drug trials and everything, that is, yes, that is the reason if you are taking a perfect consent form, you need at least 25 to 20 to 25 minutes. And it is ideal to be spent that much time, because if you explain thoroughly to the participant, the chances of patient will remain with you for the longer duration. Compliance will be much better.
Generally, it is done at the reception, somebody else.
No.
For the delegation, for the yeah, study,
Separate rooms are there to take the, it has to be there.
see what we had done once was taken the group together, read out the consent form completely to everybody, and then asked, is there any question?
Which cohort?
Which group? Students.
Students is different, sir. Because students के लिए like it's different. Because we are doing, let us see, like we are doing some survey of the students. For them we can understand the patient information sheet. बाद में उनको दे देना, time दे देना. Like read it again.
And then ask if there is any question you want to ask, and
Yes,
then
yes.
they are
For the patient it should be one to one.
But we also have to understand students are vulnerable population. If you are asking your student to participate in something, students will not say no to you.
That's what I was
Because their
telling
marks
you.
are in
In the break I was talking to him, the gentleman from the anatomy department. I was telling him like we don't allow the first year to do study in the first year students. Because I tell him if you really wanted to check some of the teaching learning methodologies, check it on the second year, third year. Because they refuse it many times. Then get up and go to the class. I just allow them. Because the first years they will be scared that they will be failed on the exams. Definitely. Okay, they cannot become their more.
So they are most vulnerable population. So as far as possible, avoid.
Yeah, second year students, though he is starting in the first year, they are not scared. Out of 160, 20 definitely will get up and go, and we should respectfully accept it.
is there any provision of witness on the sign of residency of the witness on every informed consent?
Same.
See, if the person is literate, able to read and write the consent, there is no need of.
Doctor is well qualified, and that who is participating in the research is also well qualified.
There is no need of.
But if there is any conflict is across.
No, there is no need of witness in case the participant is able to read and write and understand what is written in the consent form. Absolutely not. Definitely, we should see. Then we have to respect it.
After the study,
After reading the paper,
it is taken study of the consent. After the study, after the results, it will be
after the results, why you want to consult him?
Consent is taken for the entire test, not part by part consent we are taking. So it will be for the entire.
In the beginning you take it. At the end you are not going to consult him. Na? If you want to disclose some of the results, if they will approach you and you should disclose them. For example, like you would have taken as me as a participant and you will be doing the test as a team will be doing some analysis. So that team analysis is done only at the end because we will be collecting all the samples and then we run the test at the end. But you say like disclosure of the result will be done at the end of the study. That time like I said like kindly disclose through my email ID or something. I would have mentioned in my consent. Should disclose the result. Otherwise I can come and approach you. So you are not disclosed.
There is no ideal, but minimum if the clinical trials are there, the consent form are somewhere from 16, 17, 18 pages.
And then for the academic studies, I can understand it.
Yes.
It is like
Academic study, that's not possible. Only thing, make a point that all the points should be there. Yes.
regarding the withdrawal, this thing, and the consent, any risk involved, all these components should be mentioned.
Specifically for academic studies.
Since
One is enough. One मिलने के लिए बहुत time है. Thank you so much. And extremely sorry, ma'am.
Thank you very much, Vaishali ma'am, for extensively covering all the components of informed consent. And now hopefully we will actually take, we are always taking consent, but now it will be informed consent. So,
To invite our next speaker, Dr. Minakshi Bakshi ma'am, currently serving as advisor QA at ICMR and DBT. Over 29 years of experience in quality management across tertiary hospital laboratories, central reference laboratories, and clinical research in domestic and global clinical operations. Postgraduate in biochemistry with certification courses in clinical research, ISO 15189, ISO 13485 certification standards, NABL CAP accreditation for labs and medical devices. Expertise in design, implementation, and maintenance of quality management systems. Plays a key role in promoting quality culture and strengthening QMS to meet accreditation and regulatory standards. Experienced in GCLP, GCP, and other GXP standards for vaccine and therapeutic clinical trials, including clinical and immunogenicity laboratories. Held leadership roles in corporate quality assurance with strong experience in global CROs, including early phase and central labs. Recognized for strategic leadership, operational excellence, and quality-driven management in healthcare and clinical research settings. Please welcome.
Thank you. I think that's a lot of information about me. So I'll try to keep it simple. I want a help from you. Can you do the head count, please? Unfortunately, my job requires me to be on the toes. I'm an auditor. I'm a certified auditor for various regulatory bodies. So if we have registered for 80, I'll begin with the head count, please. Can you do the head count and let me know? 23? Okay. So ultimately, I'll continue the session. I'm sure those who are sitting here have been investing their time and energy. They are the ones willing to learn, grow, evolve. Research is meant for those who want to have an intent to put in their best, right? And as auditors, I think whatever we've been studying, it's almost impossible to put it up into slides. Because I think for me at least, it's been 30 years. I have served across geographies, India, China, Belgium, Singapore, US, worked for regulatory bodies. But for the last 10 years, I'm contributing to Government of India as ICMR and DBT, simply because there are no QA professionals from industry helping and wanting to do for Government of India. And in my own capacity, I've been trying to mobilize people to strengthen capacity at medical colleges. At least there are 20 medical colleges that I have supported, and we have tried to build up the capacity where we can promote regulatory trials. So one of the trials recently that has been concluded at ICMR, that is a phase 3 vaccine trial on tuberculosis with 2 molecules from India, and that has been published in the BMJ with an H index. It's a significant one with a. So what I'm trying to say is that nobody would have imagined tuberculosis phase 3 vaccine trial sponsored by ICMR on Indian molecules. The sponsor companies, they simply gave their molecules and everything was conceived by ICMR. We did it at 18 institutes on 12,700 participants with a follow-up of 38 months. So that's something that, Government of India has been putting up the mission to drive capacity building exercise. And it's not just the vaccine. Currently, like I'm associated, and I know I'll not even run through slides most of the time because I'll speak like this. I went with the lab. I think within 5-10 minutes, we did a whole GCLP course there. So we are setting up at DBT, we are setting up a medical research center. That is the phase 1 unit, and CHIS, which is called Controlled Human Infection Studies. So the mandate is very clear to bring in the AI technology. I'm associated with the AI tool that is for chest abnormality detection. So maybe in your pulmonology department, you will be doing a lot of x-rays. In radiology, you'll be doing a lot of x-rays. They may not be necessarily tubey. What we want to do is to segregate at the point especially at the PSC level, at the far remote areas and the tribal areas and all, the solutions which can reach to the difficult to reach areas. So that can only happen with research, and only with the researchers who are happy and willing to learn and evolve. So if getting an attendance of 23 is significantly lower, at least I'm not quite happy with this kind of attendance. Nevertheless, the credit goes to everyone who's sitting and doing that. So we should not take away the joys of learning from those. So at the end of the day, whatever we've been learning since yesterday, how do you qualify yourself? All of this has been done to meet up the requirements of the regulation. So there's a difference between standards, guidelines, and regulators. Feel free to stop anywhere you feel that it's not appropriate, you're not able to understand. The idea is not to train you to face a regulatory inspection. The idea is to sensitize whatever you do, each activity, right from protocol, writing a protocol synopsis, to reviewing it, to put up an informed consent document, identifying your potential participants. Like we were talking about informed consent. Now, imagine a situation in a controlled human infection study, which doesn't happen in India also. आप कैसे एक illiterate को even enroll कर सकते हो? So there the qualification is graduate. Okay? So informed consent level of comprehension is determined by the level of literacy. That's an indirect way. So literacy in human, for example, in Indian Constitution, they say 5th pass. So इतना समझ में आए कि उसका अपना भला बुरा समझ में आ जाए. वो समझ भी जाएगा, लेकिन शायद वो आपको हाँ नहीं करेगा. हाँ भी करेगा तो probably लिख के नहीं देगा. So what we want to do is that informed consent process should be in such a manner, even in last 30 years, even yesterday, FDA, which is a regulatory body, has issued 2 at least letters, 483s they are called, to Indian sites. One is AIIMS Bhubaneswar, yesterday only. FDA issuing site, and both of them are for oncology trials. So I'm not saying that, our तो challenge कहाँ पर आता है? हम भी जब deal करते हैं, there are at least at ICMR itself, I would have probably, we have a network of 150 sites that we are dealing with. Challenge है clinicians को patients देखने हैं और हमें research करना है. There has to be a balance between the two. So researchers को guidelines or regulations को imbibe karna, and then that much of time to be given to the patients is very, very important. The moment आपने अपना delegation अपने एक SR को या JR को पकड़ा दिया, letter 483 PI को ही आएगा. I worked for international companies and I can proudly say, even in US, India में नहीं होता, US में ज़्यादा fraud and misconduct होता है. When I was working for India, I used to say proudly कि मैं sitting here, हम लोग थोड़े बहुत ही ऊपर नीचे ये वो कर लेते हैं. हम smartly नहीं करते probably. But 483s आना is not a good thing. So अगर एक site को 483 मिलता है, तो then we have to seriously think of where is an issue. Is it, so basically the whole quality management system is 5 M's, right? Manpower, जो हम कर रहे हैं. We're investing on a human manpower. So trial में, it's like a relay race. We change hands. I give it to you, you give it to somebody, like that it happens. Somebody identifies the patient, tells the PI, this is a potentially eligible participant. Then somebody will screen through the symptoms and see if the trial में fit हो रहा है कि नहीं. Sponsors will come to do a feasibility. Then they will look at your lab, your pharmacy area, your social worker, how do you follow them up. So this is wherever you go lenient and the whole chain breaks. It's like a relay race में 100 मीटर पे एक भाग रहा है, दूसरे को पकड़ा, एक ने गड़बड़ किया तो सब गिर गए, right? Sorry, did I do something wrong? How do I go next? This one, okay. So GCP readiness. So GCP, since yesterday we are reading about GCP, maybe 45 slides होंगे, मैं cut down कर दूँगी. The whole idea is to, मुझे online लेना पड़ेगा, मैं online session ले लूँगी. But I'll try to make it more, आपको जितना समझ में आएगा, आप उतने तक समझ के मुझे बताइएगा कि is this okay, and then I move to the next. Who can answer? How many principles of GCP are there? And I'll go back and ask my previous speakers as well. How many principles of GCP are there? 11? Okay. So first GCP was introduced when? No, the faculties are answering only. Anybody? You know what? हम लोगों का सबसे बड़ा problem क्या होता है? Auditors, they don't trust anyone. जब तक कि वो खुद से evaluate ना करके readiness. Because आप जो prepare करेंगे, your team will be audited by us, auditors. Why? So that when inspectors come, you are ready. We are a shield between you and the inspectors. Okay? So when was the first time GCP was introduced? 2017? No. Google not allowed. Okay. 96? Okay. Next revision. Phone मत देखिएगा कोई. हाँ. Next revision. R2 बोलते हैं जिसको. नहीं पता? So हमारा program का success will depend upon these 5 basic things. E6 R2 कब आया था? 2016. 1996 के बाद 2016. And now we have R3. 25. So 96 and implementation के लिए तो हमें 25 का 26 का ही मिला basically. And it is a major revolution. Those are the lucky people. हमने 96 भी देखा है, 2006 भी देखा है, 16 भी देखा है, now 26. It's been almost close to 30 years that I'm working. So what is quality? Basic things. We'll not go into what is quality as per regulatory definition. I think most of my speakers were sitting this side, probably this is more lucky side. So, clinical research and clinical trials and clinical study. What is the difference between these three? Anybody, simple language? And what is quality in your terms? Last, madam, what is quality? किसी भी चीज का quality, not in the clinical research perspective. Anything that you feel? If you have to buy a watch today, if you have to buy a phone today, fit for purpose. Fit for purpose, right? So if I have to buy a phone which I want a clearer picture, I want a long battery life, I want a secured system so that nobody can install or theft money from my online information, something like that. I would think of so I'll map my requirements, and then if it's meeting, it is like a quality. For example, we just went to the lab, right? There's a Hitachi AC lying there, standing up. So that is of high quality. There's a Sony system, jiska music is very high quality. Bose ka music system, right? So these are quality. So quality is something that is eligible to you in terms of requirements, and it meets its intended objective. Okay. What is the difference between clinical research, trial, and study? बहुत सिंपल क्वेश्चन पूछ रही हूँ मैं, अभी पहुँची ही नहीं ऑडिट में. अगर ऑडिट होता है तो हम लोग सोते ही नहीं रात को, मतलब. No. Trial means comes under the regulatory perspective. Okay? Trial means regulatory. Research, you can do any kind of research. Research, bedside to bed to, Trial means you are under the umbrella of a regulatory body. In India, the regulatory body is CDSCO. In US, it's FDA. So various agencies, they work together. Like in COVID, for example, India had produced vaccine quite quickly. But that was not meant for Indian population alone, right? Even Bangladesh would not have done, Bhopal, Bhutan, they don't have that R&D system, right? Whatever works in India is acceptable globally. How it is done? That is done by the harmonization. That is when 96, everybody was doing their own research, putting a lot of money, they were investing in a lot of infrastructure and everything, and there were a lot of duplication. So they came up together to have a consortia or a understanding to have GCP, that we will follow minimum this rule, we will follow this guidance so that we have the same objective. It is like कि मैं आपको सबको, who loves rajma or anything, any recipe? I know यहाँ पर कड़ी कचौड़ी is more famous, but let's say I give you same set of ingredients. if I give it to you versus your mother, एक taste आता है अगर आप 2 लोग बनाएंगे भी तो. So even with the same recipe, same ingredients, you may not have the same taste. So the idea is that you need to follow certain common set of guidelines so that you don't duplicate the effort, and that is work. ICH GCP, it's an international collaboration which is for different countries together. Whatever is being done in India, that will be accepted globally. So if you produce any vaccine in India, that will be accepted globally as well. Okay, if you want to have any solution from India, that will be accepted globally. जैसे आप यहाँ टेस्ट करा के वहाँ लेके जाएंगे तो भी they will be accepting it. So what is audit basically? Financial audits, I'm sure everybody knows about it. आप अपने सब ITRs भरते हैं, organizations legally, they know. Audit का objective वही होता है, independent evaluation of the data set or the procedures or the systems, but they are done by certified people. For example, I'm certified, I did my studies from Cambridge, I did my courses from different institutes, did my AI from somewhere else, medical device from some. If I am not educated or competent to do an audit, would I be able to give you an audit observation? Can I give you? Would you accept it? No. So that means I need to be aware of what are the regulations. जो जैसे गेम में रेफरी होता है ना, उसको अगर रूल्स ही ना पता हो और उसको ही बना दो तो लड़ाई होगी दोनों गेम्स में. That is what an auditor's job is, that to be aware of the rules and regulations. So when we say guidelines, they are the guiding principles. And when we say regulations, they are like rule book. So अभी क्या हुआ है, ICH GCP R3 ने बहुत सारी ऐसी चीज़ें हैं जो GCP में it was unsaid कि GCP follow कर रहे हो तो आपको regulations पता होंगे. But it's not like that. जो GCP में लिखा था वो अलग लिखा था और there were million regulations जो अलग लिखा हुआ था. 21 CFR Part 11 compliance. आप Make My Trip पे जाके आगे की बुकिंग कर सकते हो, फ्यूचर ट्रैवल की. कैन यू डू पास्ट की बुकिंग? तो सॉफ्टवेयर बना ही नहीं है ऐसे, है ना. इट विल प्रॉम्प्ट यू दैट यू आर गोइंग बैक. सो 21 CFR ऐसे ही एक वन ऑफ द रेगुलेशंस हैं जिसमें टाइम ट्रेल स्टैंपिंग ऑडिट लॉग वगैरह सब कुछ होता है. सो ICH GCP R3 इज़ लाइक अ रेवोल्यूशन इन GCP वेयर डिफरेंट रेगुलेटरी बॉडीज़ का जो निचोड़ है वो भी ICH GCP R3 में आया. तो टू बी ऑडिट रेडी, टू बी GCP ready, we need to be aware of the regulations, etc. And how to do, how do you prepare the sites who are participating, the sponsor? The obligation of monitoring, auditing lies with the sponsor. Different indications, different drugs, different therapeutic vaccines. We are not even talking of the high end. Phase 1 तो इंडिया में होता ही नहीं है, मतलब why it doesn't happen? Because the molecules are so tough. It's first time in human. There are so many risk factors. The government is worried that anybody who doesn't have an office in India, they would not allow. Like I said, government of India is very, very stringent about. You need to have your legal presence in India to even have a molecule. So most of the companies, they send the molecules outside. They get the phase 1 done. Then when they bring it to India, they have to do phase 2. Or they have to do a bridging study. So how does phase 0 happens? How does phase 1, 2, 3? And consent, like my earlier speaker said, consent is not at all only at the beginning. Consent is an ongoing process. आप ये मत मान के चलिए कि आपने शुरू में अगर आपने consent ले लिया है, so that is valid forever. Consent is an ongoing process because things change, especially for the long-term cohorts. Lot of things change, lot of new information come, lot of adverse event data that keeps coming, the formulations are likely to change. So that means it's an ongoing activity. Anytime the new information comes in, you need to do. Sorry. We've already gone through pitfalls, etc. by fraud and misconduct. This is again a very, very tricky one. Fraud is an intentional falsification or an activity, while the misconduct is even due to negligence or like errors kind of things. So regulators are very, very active. What we do research here have an implication. Sponsors जो इंडिया में आज research करें, they may take it to Australia, they may take it to Canada, they may take it to US, they may take it to Brazil. Different companies have different regulations. So whatever is happening today, like for headache, the hypertension, the medicine is being done today in India, the same dossier they'll apply to different regulatory companies. So आज हम जो whatever research we do at the site and in the trial, we always have to build in those elements of regulations which are likely to be asked later. So quality, total set of characteristics which meets its purpose. Quality control is a regular day-to-day routine real-time activity. जैसे मैं चाय बना रही हूँ तो मैं चाय में चीनी की जगह नमक ना डाल दूँ, मेरा हाथ तब पकड़ना is a quality control. चाय पीने के बाद बोलना कि नमक लग रहा है is a QA. So quality assurance is a systematic review. किसने बनाई, कहाँ से ingredient उठाया, label था कि नहीं, that's all quality assurance. Quality control is real-time activity. For example, आप lab में हैं, right? So you picking up sample 20 microliter, मैं यहाँ डालने की जगह यहाँ डाल दूँ, दूसरी ट्यूब में डाल दूँ. So real-time activity checks are quality control. So, and they are deployed into different this thing, like aircraft, you know, we travel so often, so every day. And I come from an Air Force, you know, my dad was in Air Force, so we traveled all places. एक एक कंपोनेंट छोटा छोटा है. इमेजिन अगर एक एक छोटा छोटा कंपोनेंट में क्वालिटी कंट्रोल ना लगा हो तो एयरक्राफ्ट का क्या हाल होगा. You know, so we come straight away कि this quality is not good, not up to the level. But that is split up into multiple small processes. So whenever you do any activity, divide it into multiple small components and control each activity in such a manner that you can create a larger picture without, it's like creating a Lego set or a puzzle set, solving anything, any step gone wrong and you're totally mistaken. So QMS, I know my topic is मेरे कोई peers नहीं हैं जो quality control, quality assurance, quality monitoring system के लिए होंगे यहाँ पर, but that's all the more reason that you become the ambassadors for QA. So independent examination, every unit, at least sponsors के यहाँ पर, QA is an independent unit, जिसको ये डर नहीं लगता कि मुझे management के पास जाके ये बोलना है कि ये AC खराब है, ये flooring खराब है, यहाँ पानी नहीं होना चाहिए, यहाँ से leakage आ रही है, that is QA. Independent of the activities, who are your eyes and who have directly access to the management. So why quality matters? You know, absence of quality सबको पता चलती है. जैसे मैं आज घर पे नहीं हूँ, रोज मैं घर पे होती हूँ तो मेरे बेटा मुझे बोलेगा आप क्या आज he is calling up mama we missing you, right? So absence of quality takes a hit. Presence of quality शायद आप realize नहीं करते होंगे आज यहाँ AC है, you may not know, but कल AC नहीं चल रहा होगा तो you will realize कि यहाँ AC नहीं चल रहा है. So that is how the quality plays a role in all of our activities. So compliance का मतलब क्या है? Compliance means non-negotiably acting and working towards achieving that one goal which fulfills your criteria. Compliance is a regulatory term. आप अगर it is something similar to हम स्कूल में टेस्ट देते हैं तो मैंने पेंसिल से लिख दिया, माई टीचर वुड बी ओके, नेक्स्ट टाइम मत लिखना. जब मैं बोर्ड एग्जाम में जाऊंगी, इज एनीबडी गोइंग टू टेल मी कि कोई बात नहीं पेंसिल से लिख लिया चलेगा? नोबडी इज गोइंग टू टेल. बट आई माई सेल्फ ऑल्सो नो कि मुझे पेन लेके जाना है. आई नो दैट कि मुझे ब्लैक यूज़ करना है या ब्लू करना है या रेड करना है. आई डोंट राइट माई, डिड वी एवर राइट अवर आंसर्स इन रेड इन द बोर्ड एग्जाम्स? नो. डिड एनीबडी से कि आप अपना रोल नंबर खाली मत छोड़ देना, चलेगा? नो. Did we write anybody wrong name there? No. Why? Because we were conscious. So we were trained to be compliant, right? Instructions used to come from board. इतने घंटे पहले. There were no exceptions. आपको आधा घंटा पहले रिपोर्ट करना है. Nobody had the liberty to say कोई बात नहीं 20 मिनट हुए अंदर कर दो एग्जाम के. Nobody. Think of everything in your real life situation. There are no exceptions when it comes to compliance. So there are different type of, how do you monitor compliance? There are two important pillars. One is called monitoring and one is called auditing. The yawning has become like wide, big. I can't help it. My session is at the end. I've traveled from Delhi to try and contribute. I think Pooja has been kind enough to have been coordinating for last 2 weeks. I said yes and I said no, but we tried to pull it up all together. So, शायद आपको आज ये नहीं पता चलेगा. Maybe when you will be a part of the regulatory trial, you might remember this session. And I'll leave the slides here. जब भी time मिले 2 slide, 1 slide आप पढ़िएगा so that you know. जो who are into drug, for example, think of a research like this. आज आपको अपने बच्चों को vaccination कराना है. Are you confident? ना you take up to the doctor कि इसको flu लगा दो, इसको MMR लगा दो. Aren't you confident? Somebody has invested millions of dollars and amount of research to bring in that molecule to India and get it into mankind, right? आज हम इतना कॉन्फिडेंटली पिछले 30 साल सोच के देखो कि ऑन्कोलॉजी के लिए सॉल्यूशंस नहीं थे. टुडे वी हैव सॉल्यूशंस फॉर इवन ऑन्कोलॉजी. Would we have imagined कि यहाँ पर solutions आएंगे? So the research is not for today. We already have solutions for many things. It is done for the unmet needs. जो हमने सोचा नहीं है, unimaginable, unfathomable, we are trying to do revolution in those areas. And I'm proud to say that Indian companies, Indian researchers and Indian startups, IITs, AIIMS, everybody has been doing their best. And जो हम सोच नहीं सकते थे, उस तरीके के solutions आजकल आ गए हैं. I'm proud to say मैं पिछले 96 से at least I'm into the clinical trial research industry. मैं इंटरनेशनल में काम कर चुकी हूँ, सब जगह काम कर चुकी हूँ. और शायद हो सकता है मेरे जीन्स हैं बिकॉज मैं फौजी की बेटी हूँ, तो मेरा पेट्रियाटिज्म बाकियों से थोड़ा और हाई है. थैंक यू. हमारा एक 96 में आई थिंक वाज द फर्स्ट टाइम व्हेन वी हैड स्टार्टेड द ऑलमोस्ट GCP एनवायरनमेंट सेटअप हुआ था. एंड वी हैव सम ऑफ द फाइनेस्ट माइंड्स who do research in India. Unfortunately, because of the ecosystem, they are sometimes not able to do but when they go abroad, they are able to do quite well. Now at this time, in the last 5 years or 10 years, there are many people who are turning back to India and contributing. They have started their setup. The government of India is funding a lot of it. DBT has set up ecosystems, startups. There are many schemes, small grant, large grant, intermediate, Center for Advanced Research, first in research. There are so many fields are there. We have to see where do we fit in. पहले कभी किसी ने मेरे टाइम पे 3 ही हमारे पास ऑप्शन थे, IIT, AFMC, NDA. ये 3 होते थे प्राइमरीली. हमारे सेंट्रल स्कूल्स में तो यही होते थे. मेरे सारे क्लासमेट 3 जगह पे पहुँचेंगे और चौथा आई डोंट रिमेंबर कहाँ था, ज़्यादातर यहीं पर. जब मेरे जैसा आई डेंट चूज़ एनी. बट सम हाउ आज की डेट में क्लिनिशियंस एंड इंजीनियर्स आर वर्किंग टुगेदर. The pacemakers are not developed by doctors. They are developed by engineers for clinicians, with the input of the clinicians. That is the time era nobody would have imagined. कि आज के डेट में IITians में doctors की PhDs हो रही हैं. You know, the integrated systems, how they work. There are many hip implants, somebody was talking about the hip implant and the implants. They are done by engineers, but the workflows are designed by the clinicians. डॉक्टर बताता है मुझे ऐसा चाहिए कि ड्रग डिलीवरी सिस्टम है. सम फार्माकोलॉजिस्ट मैम वो सिटिंग हियर कि ऐसा हो कि वो इतना ड्रग डिलीवरी सिस्टम ऐसा है, मुझे ये इफेक्ट चाहिए. दैट इज़ अ वे इट इज. सो इतना सब कुछ एनवायरनमेंट को कंट्रोल कौन कर रहा है? रेगुलेटरी बॉडीज़. अगर हम सब कुछ छोड़ दें क्लिनिशियंस पे, रिसर्चर्स पे, इंजीनियर्स पे, व्हाट विल हैपन? आवर एथिक्स. सो GCP के 2 मेन ऑब्जेक्टिव्स होते हैं. कौन मुझे वो बता सकता है GCP के 2 मेन ऑब्जेक्टिव क्या है? सिर्फ 11 प्रिंसिपल का 2 ऑब्जेक्टिव्स हैं. So patients are, we don't say, we always say participant. Participant safety. Second is data integrity. 2 में सार है. अब इसके इर्द गिर्द आप जितनी मर्जी कहानियाँ बुन लें, SOPs लिख लें, मैनुअल्स लिख लें, ट्रेनिंग कर लीजिए. अल्टीमेटली जितना भी रोबोटिक सिस्टम आ जाएगा, काम तो ह्यूमंस को करना है. सो हमारी एजुकेशन सिस्टम इज़ ट्राइंग टू बी ब्रिज्ड. वी प्रपोज फ्रॉम ICMR ऑल्सो AI शुड बी अ पार्ट ऑफ द मेडिकल करिकुलम, बिकॉज अल्टीमेटली बाहर निकल के भी उनको वही करना है क्लिनिशियंस को. सो वाई नॉट टू डू देम वाइल दे आर स्टडिंग. सो इस पूरे सिस्टम को हम कैसे मॉनिटर करेंगे? इंस्पेक्टर्स तो रोज नहीं आएंगे. समबडी सिटिंग इन ऑस्ट्रेलिया विल नॉट कम डेली. CDSU दिल्ली में बैठ के तो डेली नहीं देखने आएंगे. सो हु आर ऑल द स्टेक होल्डर्स? रिसर्च एक स्पॉन्सर है जिसको मॉलिक्यूल बनाना है. एक प्रिंसिपल एक साइट है, इन्वेस्टिगेटिव साइट. लेट्स से दिस इज अ इन्वेस्टिगेटिव साइट. विद इन इन्वेस्टिगेटिव साइट लेट्स से ट्यूबरकुलोसिस ड्रग बन रही है, तो देयर इज अ पल्मोनोलॉजिस्ट हु इज देयर. पल्मोनोलॉजिस्ट को अपने रिसर्च करने के लिए माइक्रोबायोलॉजिस्ट की भी ज़रूरत पड़ेगी, उसको रेडियोलॉजिस्ट की भी ज़रूरत पड़ेगी, उसको लैब की भी ज़रूरत पड़ेगी. सो दे हैव एन इंटरडिसिप्लिनरी टीम. सो दिस बिकम्स योर साइट. In fact, I did not know. When I had to come here, at least I got 5 calls. If you're going to J.L.N. Ajmer, हमारा ये feasibility कर देना. And I'm actually going to tell them कि hold it on for a while. until we say ourselves that, okay, we have organized, and give them 5-10 days or 1 week. And I would really appreciate that this hospital has a QSL or no? No. NABH? No. Okay. Never mind. We always can support each other, and you can, think of in your respective areas, and then you can do. So, अभी हम लैब में गए थे तो क्वालिटी बाय डिज़ाइन. व्हाट इज क्वालिटी बाय डिज़ाइन? I'm a little distracted due to change in the numbers, but that doesn't matter. What is risk? हम ट्रायल, सबको पता चल गया कि ट्रायल कैसे करते हैं. एक स्पॉन्सर होता है, एक इंश्योरेंस पॉलिसी लेते हैं, एक साइट सिलेक्शन होता है, एक साइट. बहुत लोग सोचते हैं कि ट्रायल का मतलब एक कंपनी और एक इन्वेस्टिगेटर और एक पार्टिसिपेंट. इट्स नॉट लाइक दैट. देयर आर many स्टेक होल्डर्स इन द होल प्रोसेस. So while the important stakeholders are sponsor, participant तो नहीं है indirectly, एक investigator and ethics committee. These are the main ones, right? Ethics committee की सिर्फ rights नहीं है कि वो आपको reject कर दे. उनका responsibility भी है कि वो आपको आके monitor करें और check करें. You know, a lot of I get a call that ethics committee ने हमें ये objection लगाया. I said they need to train you also. If the objection is there, what is the alternative solution? You know, you have to guide them also. Lot of researchers just drop the idea of research just because उनको पता ही नहीं है कि किससे पूछना है और क्या पूछना है. So, ecosystem of strengthening each other, supporting each other, you should know. Ethics committee have a role, like for example, we were discussing anesthesia protocol. If there's nobody in the ethics committee, they'll call a subject matter expert to facilitate your discussion. जिसको आपकी भाषा समझ आए. होता है ना कई बार कि एथिक्स कमेटी को तो सब ज़रूरी तो नहीं है सब कुछ पता हो. सो देन इट इज़ इम्पॉर्टेंट दैट यू हैव समबडी हु कैन अंडरस्टैंड. लाइक आपने सबसे डिफ़िकल्ट आर मेडिकल डिवाइसेस. अब आप ड्रग दे दिया, वैक्सीन दे दिया, 1 टाइम पॉइंट है ना, आपने डाल दिया, जो होना है 72 आवर्स तक आपने ऑब्जर्व किया, इम्यूनोजेनिसिटी देख लिया, चेक कर लिया, इमीडिएट रिएक्टोजेनिसिटी तो नहीं है, एनाफाइलैक्टिक तो नहीं है, इतना ही है ना. कोविड सबने लगा लिया था वैक्सीन, किसी ने नहीं बताया था एनाफाइलैक्सिस क्या है ना, आम जनता ने भी लगा लिया. मेडिकल डिवाइसेस आर गोइंग टू स्टे विद इन योर बॉडी. हाउ डज इट बिहेव? लॉट ऑफ पीपल हैव कॉम्प्लिकेशंस. किसी को निमोनिया है, किसी को कार्डियक प्रॉब्लम है. लॉट ऑफ पीपल कंप्लेन ऑफ सर्टेन थिंग्स. आर वी रिकॉर्डिंग दोज इवेंट्स? आर वी सेंसिटिव इनफ टू द पार्टिसिपेंट्स कंप्लेन? बहुत लोग तो बोलते हैं इनको साइकेट्री में भेज दो. पार्टिसिपेंट बार बार एक ही बात बोलता है. नो, वी नीड टू टेक व्हाट दे आर स्पीकिंग एंड नोट डाउन एंड कन्वे टू द कंपनीज. We are working for the researchers, are working for the sponsors, but they need to take feedback of the participant very carefully. Okay? And it's very unfortunate that despite having a lot of regulations, still sponsor companies, they have their, we have to make them accountable for anything that happens to the participant. A lot of time people ask me, it's not related. So adverse event का difference जो था, एडवर्स इवेंट वहीं से शुरू हो जाता है जहाँ पार्टिसिपेंट ने कंसेंट फॉर्म साइन कर दिया. Am I right? Right? हाँ. Right? It is not even related to कि आपने उसको ड्रग दिया कि नहीं. आपने एडवर्स इवेंट मतलब फॉर्म साइन करा, यू आर नाउ लायबल. मैंने फॉर्म साइन करा, मैं निकल रही, चक्कर खा के गिरी, मेरा सिर यहाँ लगा, नथिंग डूइंग, यू आर रिस्पॉन्सिबल. आपका फ्लोर स्लिपरी था, हवा नहीं थी, पानी नहीं था, खाना नहीं मिला, वट एवर इट इज़. It is not related. So, whole soul. इसीलिए वही लोग रिसर्च करने के लिए आगे आना चाहिए जिनको पता है कि रिसर्च के रूल्स क्या हैं. अदरवाइज यू लैंड अप योरसेल्फ इन ट्रबल. सो ऑडिट एंड इंस्पेक्शन का क्या डिफरेंस है? मैं वही भाषा बोलूँगी, मैं वही चेकिंग करूँगी, मैं वही चेकलिस्ट फॉलो करूँगी जो मैं रेगुलेटरी में पढ़ती हूँ. फॉर एग्जाम्पल, माई स्टडी इज़ बीइंग प्लान्ड. I need to, as an auditor, let's say I am deployed as an auditor, I need to develop an audit plan, audit strategy. मेरा audit strategy should take care of मेरा risk कहाँ है. My risk is where? My protocol says कि participant को, let's say protocol design हो रहा है, okay? हमने उसमें लिखा हम 10 ml blood लेंगे. अब आप 10 ml आपका ethics ने approve कर दिया. जब हम काम करने आए तो हमें पता चला हमें CBC भी चाहिए, हमें CRP भी चाहिए, हमें HbA1c भी चाहिए. वो सब जब लैब आपके साथ बैठेगी तो बोलेगी एक येलो ट्यूब दे दो, एक रेड ट्यूब दे दो, एक ईडीटी के ट्यूब दे दो, एक 2 फ्लोराइड का ट्यूब दे दो, उसका वॉल्यूम 20 ml हो रहा है। अब आप क्या करेंगे? क्या करेंगे? वापस किसके पास जाएंगे? आईसी के पास में। तो गलती कहाँ पर हुई? प्रोटोकॉल डेवलपमेंट में यू हैव नॉट टेकन इनपुट फ्रॉम द रेलेवेंट पीपल. So protocol designing is an art. When you develop a protocol, please ensure that all necessary stakeholders, चाहे आपकी वो clinical lab हो, and आज की डेट में कोई भी blood sample लेके उसको डस्टबिन में नहीं फेंकता after processing. It goes to the repository, it goes for future genome sequencing, it goes for future purposes. Every drop of blood is precious. Every drop of not blood only, biospecimen is important. You know, people are only surviving. इतना बड़ा hospital है. Having a biorepository or biobank is absolutely essential. You're throwing away assets. There are many researchers who don't have access to hospital. So you can have a good repository here where you have healthy लोगों का, oncology का, there are many indications. A lot of institutes do not have access to clinical sample. In fact, you can collaborate. That's also another form of research. Supporting research is also research. Okay? That's just one idea, I feel, because a lot of people, they come back that they don't have access. Yes, please, ma'am. I thought you were telling we are really running late of time, so, okay. 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 Wonderful. So just to add to it, the bio ICMR has guidelines. They have, पहले क्या होता था, देश से बाहर sample. I remember myself, 2012 when I was working for this company and we had to shift our office to Singapore. वहाँ किसी ने rule बना दिया, इंडिया से बाहर sample जाएगा नहीं, right? I remember somebody had undergone IVF transplant. Even जो embryos थे, वो भी airport पे ही पड़े रह गए, और some couple had opted for that. क्योंकि वो जो कस्टमर वाला बैठा उसको तो डिफरेंस ही नहीं पता ना, सैम्पल वर्सेस उस वायबल एम्ब्रियो का. somebody was getting it to Singapore. I'm just telling you this story because it was very, and that's when we fought with the government. आप रूल बनाइए लेकिन समझाइए अपने लोगों को कि कहाँ किसको अप्लाई करना है और एक्सेप्शंस कहाँ है और एस्केलेशन मैट्रिक्स क्या है. आपके पास में ऐसा नहीं होना चाहिए it becomes dead end. That couple had come to India, given something, done everything, the embryos had to be transferred, and one guy at the airport did not know the rules. He said customs mein allowed nahi hai, and that was such a shocking thing actually. So we all actually sat there and went there and tried कि आप जो rule बनाते हो कम से कम affected parties को तो बता ही दीजिए. आप biological sample को आप airport पे बिना fridge के या freezer के आप कितने देर रख लेंगे? So when you have collaborations, you must have material transfer agreement in place. I don't know whether you have it or no. ICMR की website पे है. Collaborations have to have MOU and they have to have a material transfer agreement. क्योंकि biological sample is like a, सोना तो अभी 1,40,000 something पे हुआ है. Biological sample उससे भी महंगा है. आपको ये पता होना चाहिए कि वो लोग कहीं sample कहीं और तो नहीं भेज रहे. उसका end use क्या है? तो आप कुछ नहीं तो डिस्कार्डिंग सर्टिफिकेट, डिस्ट्रक्शन सर्टिफिकेट या तो अंडरटेकिंग लीजिए कि आप उसको उस पर्पस के अलावा कहीं और यूज़ नहीं करेंगे. राइट, दैट्स एन MOU का लैंग्वेज. सो यू शुड सपोर्ट, दैट्स वेरी गुड. बिकॉज जैसे फॉर एग्जांपल डेंगी तो पूरे साल पहले कुछ टाइम होता था, पूरे साल होता रहता है. रिसर्चर्स के पास सैम्पल नहीं है, दे डोंट हैव, तो दे वुड वांट कि NS1 पॉजिटिव सैम्पल्स हैं या जीका सैम्पल्स हैं, लेप्टो है, ये all of this infectious disease is a different type. Now Ebola का outbreak हो रहा है, we don't know what is happening, right? So all of the biospecimens are very important. So everything and anything, imaging, अब इतना imaging यहाँ पर हो रहा है. AI के projects के लिए लोग clinicians ढूंढ रहे हैं, radiology का data है. I have no idea whether your institution has framework to protect the data being sent out from the institute. There has to be a committee who looks into that. So like I said, data integrity or data governance and participant safety and well-being. These are the two primary objectives. Rest is mithya. Risk identification, like we went to the lab. Risk क्या है? हम यहाँ खड़े हैं, क्या risk है? मेरे पास समझ लो, ये मेरा consenting room है. यहाँ पर क्या रिस्क है हमारे पास अगर हमारा पार्टिसिपेंट यहाँ होगा तो? विच फ्लोर इज दिस? ग्राउंड फ्लोर. लेट्स से चौथी मंजिल पे इन्वेस्टिगेटर बैठा है विद पार्टिसिपेंट. क्या रिस्क हो सकता है? चाहे वो कभी भी ना हो दुर्घटना, आपको प्रिपेयर करके रखना है ना? हाँ, इमरजेंसी एग्जिट, क्योंकि लिफ्ट तो बंद हो जाएगी इन टर्म्स ऑफ एरियल अटैक हो गया तो. इनफैक्ट दिस इज प्रीटी क्लोज टू जोधपुर, राइट? Not that close, 2-3 घंटा, 4 घंटा, 5 घंटा, like that. So my dad, when my parents got married, so my dad was posted in Jodhpur. And शादी के कुछ दिन बाद ही वॉर हो गई. मेरी मम्मी बेचारी वो पूरे बिजनेसमैन फैमिली से वो बंकर्स में घुस रहे हैं एंड सायरन बज रहे हैं. ट्रेनिंग्स आर वेरी इंपॉर्टेंट. सो दे आर ट्रेन सिंस देन. सो मैंने कहा मम्मी आप लोगों के पास तो कोई है ही नहीं. शी इज़ वेरी हैप्पी टू गिव ट्रेनिंग सोसाइटी में, सबको देने के लिए शी इज़ रेडी. एंड शी इज़ 81. सो यू नो वेटरन्स, they know emergency management systems pretty well. आजकल के modern system, I don't see here इस room में कहीं पर fire extinguisher. Is there one? No. So I'm just saying कि when I walk, talk, go here and there, I can, risk identification is everyone's responsibility. आप चल रहे हैं, कहीं पर crack है, कहीं wire है, you need to be alert. Safety vigilance committees होती हैं, fire committees होती हैं, electrical load होता है. हम सुबह से AC चला के बैठे हैं, बाहर इतना टेम्परेचर है, फायर ब्रेक हो जाएगी तो हम यहाँ से कैसे भागेंगे? 2 दरवाजे दोनों तरफ हैं, एक की कुंडी लगी होगी, एक का ताला लगा होगा. यू नो, दिस इज़ व्हाट हैपन्स. सो हम ना रोज़ सच में बताएं ईश्वर के भरोसे ही सोते हैं, वैसे भी हम उसी के भरोसे उठते हैं कि कोई तो हमें बचा ही लेगा शायद. ऐसा नहीं होना चाहिए. वी आर इन हॉस्पिटल. अगर आप ट्रायल कर रहे हैं तो थिंक ऑफ द रिस्क. इमरजेंसी इवैक्यूएशन में सबसे पहले आपके एसेट्स विच इंक्लूड योर पार्टिसिपेंट्स. ओके, इनफैक्ट कल या आज देयर हैज़ बीन गाइडलाइन, देयर वर लास्ट गाइडलाइन इशूड लास्ट मंथ अबाउट हाउ द बिल्डिंग ऑडिट्स और समथिंग हेल्थ केयर ऑडिट्स शुड हैपन इन. आज एक ICU के लिए गाइडलाइन आया, आज या कल आई है ICU का, राइट? सुप्रीम कोर्ट गाइडलाइंस. सो गवर्नमेंट ने गाइडलाइन, गवर्नमेंट का काम है आपको अलर्ट करना. अब आप बैठ के सोचिए कि वो गाइडलाइन कैसे बनेगी. फिर गाइडलाइन बन भी गई. हमारे पास देश में हज़ारों गाइडलाइन है. सर इज़ लॉ, आई एम थैंकफुल. आई थिंक मे बी लाइक आई वांटेड टू बी अ लॉयर, यू नो, बिकॉज देयर वर 3 एरियाज आई वांटेड टू गो. या तो क्राइम समथिंग फॉरेंसिक में, बिकॉज मेरा दिमाग पूरा टाइम ऐसे ही चलता है. या आई वांटेड टू बी अ लॉ एंड आई टेकन एडमिशन एंड देन आई विथड्रॉ बिकॉज माई पेरेंट्स एंड नहीं, पता नहीं तुम घर पे ही लड़ते रहोगे टाइप में. तो दे आस्क्ड मी टू विथड्रॉ. एंड द थर्ड वाज ऑडिटिंग एंड आई हैव नेचुरली एंडेड इनटू ऑडिटिंग. एंड माय क्लासमेट्स हु मेट मी आफ्टर 30 years ऑफ स्कूल, दे सेड सही जगह हो तुम. आदत थी तुमको आके पहले चेक करना बोर्ड ठीक है नहीं ठीक है, चौक ठीक है नहीं है. दैट वाज आई यूज्ड टू डू. सो यू मस्ट ईच पर्सन, अगर एक भी गलती करेगा, ऑडिटर्स इंस्पेक्शन में क्या डिफरेंस है? ऑडिटर्स आपको मौका देते हैं कि आप एक्सप्लेन करो, गलत होगा तो बता देंगे. इंस्पेक्टर्स क्या करते हैं? सबसे पहले उसको अलग करते हैं जिसकी शक्ल से लगता है इसको आता है. ठीक है, वो मुझे बोलेंगे आप जाके कमरे में बैठिए, मैडम आप चाय. पोलाइटली दे विल से, बिकॉज दे नो दैट आई विल नो देम. मैम यू प्लीज़, मैम यू व्हाई डोंट यू सिट नाउ, यू बीन रनिंग अराउंड. मैम प्लीज़, हमें अलग कर देते हैं वो. ठीक है, वहाँ से फोटोकॉपियर हटा देते हैं सब. मैम यू नो हाउ. या FDA कम्स अनअनाउंस्ड. हम लोग ना, ऐसा नहीं है कि देश के कानून को हल्के में लेते हैं, ऐसा नहीं है. बट कोई ना कोई तो किसी ना किसी का तो रिश्तेदार निकलता है कि इधर से एक फ़ोन कर, सर आपके बहुत परेशान कर रहे हैं लोग आके. अरे सर कोई बात नहीं, हम देख, सर कोई बात नहीं, कुछ तो करिए आप कर. FDA, MHRA, EMA, सबसे डिफ़िकल्ट इज़ यूरोप एंड US. यूरोप ने तो बिल्कुल लिख दिया. आई डोंट नो हाउ मेनी पीपल नो सॉफ्टवेयर वैलिडेशंस. आई डोंट नो हाउ यू कैप्चर. अगर इसमें से किसी ने ट्रायल करा, आप लोगों में से किसने ट्रायल किया? अच्छा असली वाला ट्रायल, नकली वाला नहीं. असली ट्रायल किसी ने किया? कोई ड्रग पे, डिवाइस पे, वैक्सीन पे नहीं किया. करने की इच्छा रखते हैं? वो भी नहीं लग रहा मुझे अभी. लग रहे हैं? सर वी आर फ्रॉम विच डिपार्टमेंट? जनरल में. आपको तो बहुत पोटेंशियल है. आपके यहाँ से ही तो सबको बटेगी ट्रायल. और लैब, मॉलिक्यूलर, इन्फेक्शियस सीरोलॉजी, एनीथिंग, एनीबडी एल्स? सर आप किस डिपार्टमेंट से? एनाटॉमी. सर आप? फिजियोलॉजी. तो फर्स्ट ईयर में पढ़ लेते हैं, मैं एनाटॉमी फिजियो, है ना? आई डिड माई बायोकेमिस्ट्री, तो हमारे पास तभी पढ़ लेते. सर आप? एनेस्थीसिया. आप तो बेहोशी करके पढ़ा लेंगे उनको, कंसेंट भी बेहोशी में साइन कराएंगे. सर ऑर्थोपेडिक्स, यू वुड हैव लॉट ऑफ ट्रायल्स, नॉट येट? वो आपके यहाँ पर रिस्की है बिकॉज वो सीधा प्रमोट के लिए आते हैं, सर बन गया है FDA से, आप सीधा बस लगा दीजिए इसको, राइट? दैट्स अ चैलेंज. Government of India has tried to discourage, but they have also facilitated. For example, molecular. कोविड में अगर कोई किट FDA ने अप्रूव कर दी है, CE-IVD, सर आप भी करते हैं ट्रायल? आप हाथ खड़ा ऐसे कर, आप अच्छा, मुझे लगा ऐसे हाथ खड़ा कर कि शायद इनको भी इच्छा हो, ठीक है, पार्टिसिपेंट बन सकते हैं, नो डाउट. कोविड में मैक्सिमम रिसर्चर्स ने खुद ने पार्टिसिपेट भी किया था. दैट वाज वन एक्सेप्शन. यूजुअली अदरवाइज नोबडी वुड अलाउ देम टू. तो अच्छी वाली ट्रायल अगर करना कभी चाहोगे, देन आई विल कम अगेन टू ट्रेन. वाई? बिकॉज देयर आर मेनी थिंग्स दैट वी कैन डू, राइट? आप सिर्फ ये सोचना है कि पार्टिसिपेंट कहाँ से घुसेगा, कहाँ चलेगा, कहाँ से घूमेगा, कहाँ बैठेगा, उसको मैम ने जैसे बोला अलग कमरा है, इनको नहीं पता अलग कमरा चाहिए. क्यों चाहिए सर अलग कमरा, बताइए? प्रिवेसी देनी है ना? कहाँ है हमारे, डू वी हैव लग्जरी? मैंने 18 साइट्स पे अभी वैक्सीन ट्रायल कंप्लीट करी है. 18 पे हमारा AI टूल चल रहा है. 30 पे मैंने मेडिकल कॉलेजेस में करा है. मोस्ट ऑफ देम आर गवर्नमेंट ओनली. गवर्नमेंट हैज अ मैंडेट, आप लिख के देते हैं हर चिट्ठी में, मैम टाइम कितना हो मुझे बताते रहना, आई कैन कंटिन्यू बट आई विल रिलीज एट सम टाइम. Don't, the slides are going to be here. What I speak would be anyways registered. What's the time? 5. Another 10 minutes. Okay. If somebody has any flight or something to, वैसे तो कल सेशन है तो फ्लाइट नहीं हो सकता, ठीक है? अब मैं I'll only give certificate signed specifically for those who have attended the session. That's a sadistic pleasure I have of being an auditor. And मेरे husband तो मुझसे दुखी हो ही गए हैं, मेरा बेटा भी हो गया जल्दी से. So there are 2 days they are enjoying themselves. Okay? My son has so much of problem. He says you are invading my privacy. He is only 12. He doesn't know. He's actually gone to school principal and said, my mom is an auditor. She has a way and means to track me of anywhere and everywhere. She's going to Japan. So he says, ma'am, don't worry. मेरी mother के पास सारे mechanism है. और तो और I called up my friend who's posted in Japan ministry. ये स्कूल आएगा, इतने बजे लैंड करेगा, तो just keep. He says, Mama, leave me. Privacy breach and security versus taking care, there's a little difference only. Okay? कभी कभी हमें ओवरस्टेप करना पड़ता है, ऑडिटर्स को ओवरस्टेप करना पड़ता है कि भाई आपको बता रही हूँ, आप सुन लीजिए, कल जब इंस्पेक्टर आपको लिख के जाएगा तो आपको नहीं लिखेगा, हम सबको लिख के जाएगा. So we prepare you for the things which we can imagine. We are not hallucinating. हमें पता है वो होता है, इसीलिए आपको बता रहे. और ऑडिटर्स का सबसे बड़ा क्या होता है, किस्मत. मतलब अगर मैंने एक समोसा खाती हूँ ना, 100 लोग इकट्ठे समोसा खा रहे हैं, वो एक समोसा अगर मैं अपने ग्रेजुएशन में, वो कैंटीन में बनते थे दिन में लाखों समोसे, वो एक समोसा मैं जो लेती थी उसमें आलू ही नहीं होता था. तो वो बेचारा ना बोला, कैसे आपने वही समोसा पिकअप, इट वॉज परफेक्ट इन शेप, वो तो फूल के वैसे ही बन जाता है. इट इज़ जस्ट नॉट ऑडिटर्स लक. अभी रिसेंटली ऑल्सो इट हैज़ हैपन, समथिंग हैड हैपन दैट माई, दे वर सेइंग दैट PI दैट मैम आपके पहले 10 लोग चेक करके गए यही फाइल. तो हम फेज़ 1 सेटअप कर रहे हैं, जो चिस सेटअप कर रहे हैं. द मैंडेट इज़ ह्यूज. डेटा सिक्योरिटी, डेटा इज़ एवरीथिंग. डेटा साइबर अटैक्स, पता ही नहीं चलता आपको सिस्टम से. लोग इतने सयाने हो जो बिल्कुल नहीं पढ़ रहे हैं, उनको पता है कैसे साइबर अटैक करना है, कैसे फाइनेंशियल फ्रॉड करना है. यू नो, you need to secure your systems very, very clearly, which means you're participant. And so only commit to research if you're actually genuinely interested and willing to give that much of time and energy, and then also willing to learn about million regulations. Auditors की job बहुत tough है. Already they're very highly stressed out because एक भी observation from inspection means it's a failure of the auditor's knowledge. We call it, there are 2 terms madam used in the morning, deviation and violation. Can anybody tell what is deviation? Normal life में भी बताएंगे तो चलेगा. Deviation and violation. कोई भी real time example life से बता दीजिए. सर आपके मैडम ने बोला आपको रात को बजे घर पे खाने पे पहुंचना है और आप आए 9:30 बजे, वो क्या माना जाएगा? डेविएशन. लड़ेंगे झगड़ेंगे और तो कुछ नहीं करेंगे. हाँ, ये भी फीडबैक है मुझे. आपकी सारी कहानी बच्चे और हस्बैंड पे क्यों होती है? मेरे को सबसे ज़्यादा एक्सपीरियंस उनसे मिला है. दे आर एक्चुअली माई एजुकेटर. आप कुछ कह रहे हो मैम? सुबह वो वायलेशन हो गया। अब ठीक है, तो आप समझदार खुद ही हैं कि कितना का ओके और कितना का बिल्कुल नहीं ओके। ठीक है, वही डिफरेंस है बिटवीन डेविएशन। हल्का सा भटक गए, माफ कर दो, ठीक कर लेंगे, और भाई भूल गए, कैसे हो ही कैसे गया, that's a violation. So in terms of protocol, what we write in the protocol has a meaning, why it was meant to be like that. If you're not doing, you're violating. For example, कोई मुझे ये बोले कि मैंने सारा कंसेंट फॉर्म, कई लोग तो ये बोलते हैं मैंने भर दिया। भरना क्या होता है? कंसेंट, कंसेंट लेना होता है, राइट? दिस इज अ, हमको लैंग्वेज सिखानी पड़ती है खड़े कर करके। वी राइट स्क्रिप्ट्स, ऐसे नहीं है। इंस्पेक्शन फेस करने के लिए तो भाई बहुत मेहनत लगती है। हमारे एक बॉस होते थे, वो मुझे बोलते तो तुम आगे ही रहना, तुम कहीं जाना मत, ओझल मत हो जाना, बिकॉज ही यू नो द फियर। आप ऐसे भी कुछ नहीं बोलते, और आपको इंग्लिश में कोई ऐसे बोला तो आपको ऐसे खबर, तो भाग जाते लोग कि पता नहीं मैडम कुछ पूछ रही है वो। मैंने कहा क्या पूछा था उन्होंने? कहते वो तो पानी मांग रहे थे खाली। तो अब मोदी जी वहाँ पर मेलोडी डाल रहे तो हमें बड़े से क्यूट लग रहे हैं, वही हमसे कुछ इंग्लिश में पूछ लेगी तो फिर हमको घबराहट होगी कि पता नहीं वो ऐसा अलाउड होता है कि ऐसे मेलोडी दिखाना, नो ऐसा होता है। सो व्हाट ही डज इज एन अथॉरिटी दैट ही हैज। हम जैसे उनको मेलोडी की पिक्चर खींच के डालेंगे, वी कैन नॉट डू दैट। सो डेविएशन, अभी रेगुलेटरी बॉडी कुछ खुद से बोल दे तो मान लेते हैं, चलो ठीक। हम रेगुलेटरी बॉडी को भी नहीं छोड़ते। आप ऐसा सोच रहे होंगे शायद कि रेगुलेटरी बॉडी 24 घंटा लिखा है ना रेगुलेटरी बॉडी को देने के लिए, हम उनसे लड़ रहे हैं कि 24 घंटा, तुम 3 साल में हमारा रिव्यू करके वापस नहीं किया, तुम्हारा ऐसे ही हमारा रिकॉर्ड हो रहा है, ठीक। क्यों? हाँ, होने दो। आई एम जस्ट सेइंग, सपोर्टिंग। हम जैसे मजाक बीच में, वो भी इतना अटेंटिवली पढ़ रहे हैं, ठीक है। सो आप इक्वल स्टेक होल्डर है। मेरी जिम्मेदारी है ना, अगर कि मेरा बच्चे को मैंने बोला मैं 7 बजे तुम्हें पढ़ाना शुरू करूँगी, और वो 7 बजे खिसक गया, क्यों कह रहा आप 5 बजे 7:05 पे, उससे पहले भी वो खेल रहा था, उसके बाद भी खेल रहा है। मैं 7:05 पे आई तो उसने पढ़ना छोड़ दिया, क्योंकि कह रहा आपने 7:05 बोला था, आप देखो अब तो मम्मा अलाउड नहीं है। अब ही नोज। आई सेड ओके फाइन, मैंने कब तक के लिए बोला था कि, तो कहता आपने बोला था फिर 9 बजे। मैं कहा फिर अब 9 बजे बैठ जाना, फिर 9 बजे हम बैठ गए। So deviations can be addressed to a point. Violations are not that you can waive off. For example, आपको baseline पे before you give any vaccine, आपको एक blood sample लेके उसका testing करना था, मैडम को भेजना था लैब में, लेट्स से। अब आपने उसको, किसी को याद ही नहीं है कि सैंपल लेना था, और आपने उसका कंसेंट में सब लिखा है बराबर, सुंदर बुंदर सब राइटिंग वाइटिंग करके, आपने उसको दवाई ववाई खिला दी, लगा दिया, इंजेक्शन वगैरह लगा दिया, और वो चला भी गया घर। फिर मैडम कह रही अरे इसका सैंपल ही किधर है? अब कैन यू रिवर्स दैट? उसने तो खा ली गोली या तो खा लिया, लगा लिया वैक्सीन। कैन यू गेट द बेसलाइन सैंपल? व्हाट इज द करेक्टिव एक्शन फॉलो? कैन इट बी डन? एनीथिंग कैन बी डन? एनीबडी? एनी? लेट्स से कि हमें बेसलाइन लेना था और हमने लिया ही नहीं, और हमने उसको वैक्सीन लगा दिया और अब वो चला गया घर। कैन वी डू एनीथिंग? व्हाट आर आवर ऑप्शंस? एक्सक्लूड करना। पार्टिसिपेंट ने आपको कंसेंट दिया, वो विलिंग था कोऑपरेट करने के लिए, गलती आपकी है कि पार्टिसिपेंट की है? भुगत किसको पड़ रहा है? तो इज इट, हाउ इज इट इवन पॉसिबल दैट ये एरर होना ही चाहिए? दिस इज नॉट इवन एन एरर, दिस इज अ वायलेशन। सो व्हेन वी डू ऑब्जर्वेशंस, ऑडिट ऑब्जर्वेशंस, व्हेन वी डू ऑडिट, वी कैटेगराइज देम इनटू 3: माइनर, मेजर, क्रिटिकल। Okay? What can be the risks of these हल्का फुल्का गलतियाँ? You know, patient safety किस किस कैटेगरीज में हो सकता है रिस्क? पेशेंट सेफ्टी में हो सकता है, प्रोटोकॉल के रिस्क हो सकता है कि एलिजिबिलिटी हमने चेक नहीं करा। एलिजिबिलिटी से इसकी प्रीवियस जॉन्डिस नहीं होना चाहिए था पार्टिसिपेंट को, लेट्स से। अब आप कैसे पूछेंगे उसको? आपने किसी ने पूछ लिया, अभी मैम का स्लाइड में था, एंड आई एम लिटिल इन डिफरेंट जोन, कि कंसेंट कौन ले सकता है? जो कॉम्पिटेंट है। अब कॉम्पिटेंट की डेफिनेशन वेरीज। नर्स वो काम कर सकती है जो डॉक्टर डिग्री करके आया है। वी आर ऑल डॉक्टर्स, राइट? कैन नर्स डू दैट जॉब फॉर विच यू हैव टेकन योर टाइम एंड एनर्जी टू डू द डिग्री, मास्टर्स एंड एवरीथिंग? एंड कैन शी और ही टेक द ब्लेम for doing something which actually person was not even willing. So अगर आपका सिर्फ मेडिकल का ही इंफॉर्मेशन, वी कॉल इट ब्रीफिंग सेशन, ब्रीफिंग डीब्रीफिंग, आप कुछ तो बैठ के उसको समझाएंगे ना कि आपको भाई सुई लगेगी या गोली खानी है, 1 बार आना है, 10 बार आना है, 2 चम्मच खून लेना है, 25 बार. फार्माकोकाइनेटिक स्टडीज़ में हर 5-5, 10-10 मिनट के बाद में आपको सैंपल लेना है. आप मुझे बताइए कितने लोग हैं जो कैनुला लगवा के तैयार होंगे कि आप लेते रहिए सैंपल. आधे लोगों को, कितनों ने ब्लड डोनेशन किया इस रूम में? गुड, वेरी नाइस, दैट्स वंडरफुल. कितनी बार किया सर? 1 बार? फ्रीक्वेंटली आप करते हैं? वेरी गुड. सो दिस इज, यू नो, दिस इज हाउ यू फील कि बस एक प्रिक है. बट टू इवन टेल देम कि किसी को बताना कि आपको सिर्फ ये करना है, 4 कम से कम 7-8 क्वेश्चन होते हैं कंसेंट पे जो पार्टिसिपेंट पूछते हैं. चाहे हम जितना मर्जी बोलें, उनको कोई फाइनेंशियल फ़ायदा नहीं होता. सर एथिक्स में है, दे विल नो ऑल्सो. कुछ तो वो खर्चा पानी अपना करेंगे ना आने जाने के लिए भी. मैम ने बोला कि वो क्यों उठ के आएंगे कहीं से दूर से. 2 तरीके के ट्रायल्स हैं, हेल्दी वॉलंटियर्स एंड पेशेंट ट्रायल्स. हेल्दी वाला क्यों आएगा? पेशेंट तो चलो डॉक्टर के पास आएगा, इलाज मिल रहा है उसको अच्छा, नहीं तो वो लाइन लगा के खड़ा होता है, उसको इलाज भी नहीं मिलता. उसको एक्सरे फ्री मिल रहा है, रेडियोलॉजी, इमेजिंग, इतना महंगा है सब कुछ, MRI मिल रहा है ना, केयर तो मिल रही है, मेडिकल केयर मिल रही है. What about healthy people? Why should they participate? That's a big question. Regulatories come with big eyes. ये क्यों? Why do they participate? I said आपकी कंट्री में करते हैं? कहते हैं हाँ करते हैं. आपके तो हमारे से ज़्यादा करते हैं फेज़ 1 में. वो क्यों करते हैं वहाँ पर? वो ज़्यादा देशभक्त हैं, right? So there is a mechanism. You have to compensate them. You have to write also correctly and do also correctly. But you have to be very. अगर आज मुझे छुट्टी लेनी पड़े because मेरा आप 20 ml खून ले लेंगे, तो मेरे 1 दिन का नुकसान होगा या 2 होगा. How do you know? कल हो सकता है मुझे ज़्यादा थकान लग रही हो, तो मुझे फिर छुट्टी लेनी पड़ रही हो. So you compensate for certain things that you put it up. So patient safety is very important. Operational risk, delay हो गया, timeline नहीं meet हुई, recruitment risk. हम जब रिस्क मैनेजमेंट, ICH GCP R3 में रिस्क मैनेजमेंट एक बहुत इंपॉर्टेंट चैप्टर है. आई टोल्ड यू अबाउट क्वालिटी बाय डिज़ाइन के प्रोटोकॉल लेवल पे घुस जाओ, जो इनपुट देना है वहीं दे दो. रिस्क फैक्टर्स आर वेरी इंपॉर्टेंट. एनवायरमेंटल, नेचुरल डिजास्टर्स, इवैक्यूएशन प्लान, फायर, सेफ्टी, अर्थक्वेक, ऑल ऑफ दिस. एक जगह मैं गई थी लास्ट मंथ, मैं यही पढ़ा रही थी, माने नहीं, कहते अर्थक्वेक हमारे यहाँ नहीं आता. अगले दिन ही आ गया सुबह 4 बजे. तो मुझे बोलो मैडम पहले आप जाओ वापस, यहाँ कभी नहीं आया. मैंने कहा जो नहीं कभी होता ना, मैं वही बोल के आती हूँ आपको, ठीक है, मेरा काम ही वही है, ठीक है. ये दिस स्टडी मॉनिटरिंग आई टोल्ड यू. तो स्पॉन्सर की ऑब्लिगेशन होती है कि मॉनिटरिंग करवाना, मॉनिटर आता रहे, दिखता रहे, करता. धीरे धीरे क्या होता है, मॉनिटर भी चाय समोसा खा के बस चला जाता है. दिस इज अ मेन प्रॉब्लम, राइट, बिकॉज दे बिकम पार्ट ऑफ योर टीम. दे नीड टू बी ऑब्जेक्टिव. चाय समोसा खाइए, बात करिए, बैठिए. आधे लोग तो PI के रूम में जाने से डरते हैं. मॉनिटर्स छोटे होते हैं, बच्चे अभी नया नया करते हैं. दे आर वेरी स्केयर्ड टू गो. दे फाइंड इट वेरी टफ एंड चैलेंजिंग टू गो एंड गो देयर कि सर आपका ना फॉर्म पे साइन छूटा. इतना भी नहीं बोल पाते. मैं क्या बोलूँगी एज एन ऑडिटर, आई विल से दैट कंसेंट फॉर्म इज नॉट साइन, हाउ हैव यू एनरोल द पार्टिसिपेंट. दिस इज एन ऑडिटर्स लैंग्वेज. मॉनिटर का लैंग्वेज होगा, सर प्लीज़ वो लास्ट पेज पे साइन कर दीजिए ना थोड़ा सा, सर आपको थोड़ा सा साइन कैसे छूटता है, पूरा ही छूटता है, लेकिन डरते हैं ना. सो मॉनिटरिंग हैज़ टू बी ऑब्जेक्टिव दैट, एंड वी डू इट. पहले क्या होता था, भर भर के सब चेकिंग होता था. नाउ वी हैव रिस्क बेस्ड. तो रिस्क बेस्ड मॉनिटरिंग, रिस्क बेस्ड ऑडिटिंग. RBQM, दिस इज वेर एवर इज अ रिस्क. डिज़ाइन में, अप्रोच में, स्टाइल मॉडिफिकेशन में, डेटा में आपको ट्रेंड एनालिसिस दिख रहा है, आपका सारा CRP हिल रहा है, आपका सारा पैरामीटर हिल रहा है, सबके ग्लूकोज नीचे जा रही है, इलेक्ट्रोलाइट हिल. एक स्टडी में हमारे वैक्सीन्स में कॉमन होता है, इलेक्ट्रोलाइट सारे सोडियम सबके लो आ रहे हैं. ऐसा तो होता नहीं, हाइपोनेट्रीमिया सारों को थोड़ी ना हो जाएगा एक बार में, अच्छे हेल्दी लोग हैं. तो लैब में भी एट फॉल्ट ऑल्सो. लैब का GCLP कल सेशन है, बट आई वॉन्ट टू टेल दैट लैब, आप ना जो इन्वेस्टिगेटर्स हैं, दे हैव टू ट्रस्ट नो वन. लैब और इमेजिंग, आप लैब इमेजिंग छोड़िए, वो राइट की जगह लेफ्ट में ऑपरेट हो जाता है, होता है ना हॉस्पिटल में भी. तो इतनी भीड़ भी नहीं होती कि हम लाइट लेफ्ट भी ना पूछ सके उनको. कंसेंट रिसेप्शन में तो उसको पता ही नहीं होगा कि क्या होता है. सो कंसेंट प्लीज़ टेक वेरी सीरियसली बिकॉज लीगल ऑब्लिगेशंस आर वेरी हाई. किसने लिया कंसेंट, कितने बजे लिया, हम यहाँ तक भी देखते हैं, कैमरा भी खुलवा लेते हैं, दिखाइए कि कितने बजे आया था। आप मान के चलिए कि वी आर नो लेस देन डिटेक्टिव्स, ओके। सो इंस्पेक्टर्स जो हैं वो नेक्स्ट लेवल के डिटेक्टिव। So I don't think we'll be able to cover up that much. We have already, I'll leave it till this point because इसके बाद का जो सब कुछ है that is more on why do we have audits and why do we do monitoring. Monitoring is like कि आप रोज रोज कुछ कुछ देखते रहिए ताकि आज पेशेंट एनरोल हो गया, नया वाला जो एनरोल है उसका क्या हुआ, पुराना जो था उसका ठीक है, आया था नहीं था, उसका एक प्लान होना चाहिए मॉनिटरिंग का, तो वी मेक इट इन द बिगिनिंग. That is a sponsor's obligation. It's already defined in IHS GCP R3 also under sponsor. दुनिया में दो ही लोग हैं जो सबसे ज़्यादा जिन पे जिम्मेदारी आ जाती है, एक स्पॉन्सर जो सब चीज़ों के लिए, एक इन्वेस्टिगेटर जो बेचारा सब चीज़ों के लिए वो भी बन जाता है. थोड़ा थोड़ा एथिक्स कमेटी, बट उनको फिर भी राइट्स ज़्यादा मिले कंपैरेटिवली, बट उनका भी मॉनिटरिंग होना चाहिए. It is written that the ethics committees need to monitor the studies periodically. ऑडिट के लिए आप ऑडिट के लिए लेटर भेजते हैं. डिफरेंस बिटवीन मॉनिटरिंग कभी भी चला जा सकता है. ऑडिटर्स बता के जाते हैं कि हम आना चाहते हैं, आप हमें टाइम दे दीजिए, आप मिलेंगे तो हम आपको ओपनिंग मीटिंग करेंगे. अगर इन्वेस्टिगेटर्स हमें टालते रहते हैं, फिर हम फिर पहुंच जाते हैं, सर टाइम दे दीजिए, टाइम, है ना. हम उनको बोलते हैं आपके पास टाइम नहीं है तो आप को-पीआई के लिए दे दीजिए. बट वी सेंड द लेटर, वी टेल द एजेंडा, वी टेल देम विच डॉक्यूमेंट्स वी विल नीड, वी विल टेल देम हु विच ऑफ योर स्टाफ विल बी अवेलेबल. ऐसा तो नहीं है कि उस दिन नर्स छुट्टी पे है, टेक्नीशियन छुट्टी पे है, कोई दिखाने वाला नहीं है, फाइल्स दिखाने वाला. वी डोंट वांट टू, ऑडिटर्स आर ऑलवेज इन्फॉर्म अबाउट अनटिल एंड अनलेस इट्स अ फॉर कॉज ऑडिट. फॉर कॉज मीन्स कहीं से भनक पड़ी है कि कहीं कुछ गड़बड़ हो रहा है. कभी कभी कोई पार्टिसिपेंट, मुझे तो एक दो पार्टिसिपेंट ने कंप्लेन कर दिया कि मैडम ऐसे करते, मैडम वो जो है ना वो ऐसे, एंड एक्चुअली इट टुक इट टू बिग इन्वेस्टिगेशन. दे आर द वंस, पार्टिसिपेंट्स इतने भोले नहीं होते जितने दिखते हैं, समझदार होते हैं. वो निकलते निकलते बोल गया, मैडम वो उसने जो मेरा, मैंने कहा क्या बोल रहे हो, ठीक से बोलो. कह रहा पीछे कैमरा है, पीछे कैमरा है, ऐसा ऐसा, ठीक से बोलो. उसको पता था कि मैं ऑडिटर हूँ क्योंकि वो नज़र आती थी मुझे उसको. ही टोल्ड मी कि मुझे 200 रुपये की जगह उसने 100 रुपये ही दिया. मैंने कहा बाकी का 100 रुपये, कहता वो जो ला रहा पीछे से वॉलंटियर. यू नो एवरीथिंग हैपन्स. I can't believe, because on the ground when the records speak differently, so we go by the records, but in case needed we interview people. Okay, we can interview even the participant. So protocol में लिखा रहता है कि आपको auditors, inspectors, ethics committee सब लोग कुछ कुछ पूछ सकते हैं. वो that much is there. कोई ये नहीं बोल सकता कि privacy है, confidentiality है. Confidentiality है लेकिन नाम मत, मतलब बताइए मत, participant क्या है, initials, anonymization of the data is mandatory. सो यहाँ से आप समझ सकते हैं कि ऑडिट तक का आपका रास्ता जो है स्पॉन्सर साथ देता है, मॉनिटरिंग से और ऑडिटिंग से, ताकि इंस्पेक्शन की जर्नी इजी हो जाए. इंस्पेक्शन इसलिए मैंने बोला, आप जो डेटा आपका यहाँ से जाएगा इंडिया से, जब वो जमा होता है 5 साल तक आपको कभी भी क्वेरी आती है, वो वाली जो क्वेरी के बाद FDA से अगर आएगा तो उसको फॉर्म 483 बोलते हैं. वो कहीं भी जाके FDA की वेबसाइट पर जाके डालिए फॉर्म 483, आपको पूरा हिसाब किताब दे देगा इंडिया का, बाहर का. इंडिया में एक बहुत मेजर इंसिडेंस हुआ था जिसके बाद से इकोसिस्टम ख़राब था. एक ही जने का 13 बार ECG लगा के करके लगा दिया. ऐसा नहीं है कि नहीं हुआ, इंडिया में हुआ है बहुत, है ना. भोले हैं लेकिन दिमाग लगा के नहीं, शातिरपन में नहीं करते ना, है ना. वो तो एक क्या ज़रूरत थी करने की, उसको पूछा कि क्या ज़रूरत थी करने की, भाई लोग नहीं मिलते, ECG करा के रिक्रूटमेंट. तो ऐसे केसेस भी हुए हैं. सो वी हैव रियली कम अ लॉन्ग वे. आई थिंक दोज ऑफ अस हु आर इन इंडस्ट्री, वी हैव डन एवरीथिंग पॉसिबल टू रिवाइव इंडियाज इमेज. कुछ एक दो की वजह से, दैट इज़ द रीज़न अप्रैल में CDSCO ने CRO रजिस्ट्रेशन भी मैंडेटरी किया, वो इन्वेस्टिगेटर ECs को भी रजिस्टर किया, सो दैट जितना नॉइज़ कम हो इकोसिस्टम में उतना बेटर है. ओनली सीरियस प्लेयर्स कैन एग्जिस्ट and survive. Okay, I think with that I would conclude my today's this thing. We can continue this tomorrow at any time. Anybody? Thank you so much. You can always send your questions. And sorry for holding you back extra time.
I don't think anybody minded that. I'm very sure everybody enjoyed your session thoroughly. And thank you so much for explaining all these complex concepts in a very lucid language and also with relatable examples. I'm sure everybody could understand and relate to all the kids and husbands and family examples because, yeah, they are easy to understand. And if there are any questions, or ma'am is there with us tomorrow also. So we will have the privilege of having a few more sessions with her on GCLP. Definitely, ma'am. So thank you very much, ma'am.
A token of appreciation to our speaker, Dr. Anuradha ma'am. A small token of appreciation to Meenakshi ma'am.